well-known Indian Academy of Echocardiography. To begin with, let me request all of you to stand together for a national anthem, and then we'll start the proceedings. Can we have the national anthem, please?
जनगणमन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you very much, everybody. Thanks a lot. And let's start with the proceedings. Well, every program has got an opening batsman, and today we are going to have an opening batsman with the opening chairpersons. May I request the respected chairpersons, Dr. Hansa Gupta. Dr. Hansa is in Gurgaon right now, and she is one of the ace pillar of Indian Academy of Echocardiography. I remember that those days when we were in shamble in the form of secretary, and there she chipped in and brought this society to highest possible level. Then I'll call upon Dr. Hardeep Grewal. She's a cardiologist based in Medanta, Medicity. I'll request all of them on a chair, please. And followed by Dr. T.M. Agarwal, our money man, Koshadhaksh, everything. Whatever we spend, we have to take a permission from him. And for these few words, I'll request the chairperson to start the proceeding. It's all yours. And I'll request all speakers and I request my chairpersons to stick to times.
Thank you, Dr. Rakesh. We quickly start with the program, and I invite the first speaker, Dr. Meera Govindrajan, to speak on degenerative MS. Please. And by the time, please, the next speaker get ready, which is Dr. Vivek Tandon.
Good morning, all. Thank you, chairpersons. Thank you, organizers. My salutations to Dr. Parashar, to the other eminent luminaries here, and to my esteemed colleagues. Without further ado, I will start with my talk, which is on degenerative mitral stenosis. Okay, next slide, please. Do I need to move it here? I can? It's not moving. I'm sorry about that glitch. What happened? I think you would have to move it. Next slide, please. Yes. A brief introduction about me. I'm primarily from JIPMER. I have worked in eminent cardiac institutions all over the country with very eminent persons, for which I'm deeply grateful. Okay, the next slide, please. Yes. Now, basically, we mean what you mean by mitral stenosis. It means a hemodynamically significant obstruction at the level of the mitral valve, which is causing an increase in the transmitral gradient. What we have traditionally understood from mitral stenosis is rheumatic mitral stenosis, and that's a very familiar topic for all of us. At this point, still it dominates. That is the Western statistics. Probably in India, it would be closer to 95%. Western statistics say 85% of mitral stenosis is MS. Mostly it is seen in the disadvantaged pockets. With increased in the affluence, with better medical care and longer lifespans, Now, degenerative is coming to the fore. That is, most studies reported between 12 to 20%. So basically, there is calcification in the annulus that is extending to the leaflet and causing obstruction to the movement of the leaflet and thence to mitral stenosis. Now, we all know the other causes of mitral stenosis: radiotherapy, chemotherapy. We know there are infiltrative disorders, and there are conditions which mimic its hemodynamics, such as myxomata. Next slide, please. I can. Thank you. Thank you. It's not happening. Can I go to the next slide? Oh, out here, I guess. Yes. Okay. Okay. Now, what are all the degenerative changes in the mitral valve? I studied some 500 patients whom I had done the echocardiography in the last 6 months or so. And among them, I found about 10 point, this is all people above the age of 65. Amongst them, I found 10.9% had mitral annular calcium. Various statistics report 10% in general population, 22% in those for echo, and more than 40% in those in the older age group with a mean age of 76. Of these patients, 6 of them, namely 11.3%, had mitral stenosis. And totally 8 patients had mitral stenosis, but 2 turned out to be rheumatic, detected at a much later age. Now, what all is it associated with? We know they have a whole lot of comorbidities. They are older, they are mostly women, there is increased BMI, smoking is an association. It is almost a marker for atherosclerosis, though not quite designated as such. And people who have this always do have a higher risk of MI and cardiovascular accidents. CRF is a classical association because the calcium metabolism is affected. And 20% of those with over 70 who have CRF have this association. Other things are those that basically it's a process of strain at the level of the mitral valve. So those who have LVH invariably have this, that is hypertension, HOCM, aortic stenosis. Aortic stenosis, same pathology is mimicked. So the association is about 27%. Then diabetes and people with atrial fibrillation. Okay, so this is a patient with classic mitral annular calcium. Occasional ectopics are present. We can see the gross degree of calcification of both the posterior and anterior mitral annuli. Okay. Yes, sir. Okay, yeah, here, sir. I have got it back. Yeah, we are seeing the mitral short axis with almost 270 degrees of the mitral annulus being involved in the calcium. So that is again a form, they say below 180, we can call it as grade 1, more than 270 is grade 2, below 270, about 270, we take it as grade 3. Yeah, can somebody help me, please, really? Okay. This is that same person with the 4-chamber view. We are seeing the turbulence on the mitral annulus. We are also seeing a mild grade 1 degree of MR. Okay. This is the PW across the mitral valve, we are seeing that there is a degree of loss of LV compliance as indicated by deceleration time. That means the whatever gradients we are getting are underestimated. Gradients are in the order of 9.48 and 3.21. Typically, we say mitral stenosis less than 5 is mild, more than 10 is severe, and that is only for the rheumatic. Here, more than 3 itself indicates at least a moderate degree of mitral stenosis. And here, because the LV compliance is low, it means the gradient is high. That is loss of compliance. Hence, we can make out that the gradient what we are getting is underestimated. This is another patient where the level of mitral calcium seems to be seemingly less. It is just involving the PML. And you can see the slight dilatation of the aortic root with sclerosis of the aortic valve. As we have said, it is a common association. The same patient, we are seeing a mitral regurgitation, degree of aortic regurgitation as well. Yeah. Same patient, we can see that biatrial enlargement, we can see that she is in atrial fibrillation. There is some degree of calcium in the chordae as well, but it is not a primary chordal pathology. It is mostly the mitral annular pathology. Okay. That same patient, we are seeing it is predominantly the PML that's calcified with a little bit of AML calcium. Yeah. We are seeing a significant amount of MR as well in that same patient. MR is more than moderate. But the degree of mitral stenosis seems to be more significant here. Okay. This is a patient where we are seeing mitral annular calcium. In the 3C, we are able to make it out quite clearly. This is about a 65-year-old lady. And here we are seeing that this mitral stenosis is not your classic PML annular calcium type of thing. It is a rheumatic, as we are seeing by the fixity of the PML. LA is also enlarged. We are seeing bulky AML. Which is AML is prolapsing there. Here we are classically seeing a chordal rupture in the AML. That is because the calcium, it is classic that there is usually in the PML annular calcium also you can get chordal prolapse, chordal rupture because of the involvement of the chordae in that process. Here this is another patient. Here you can see clearly that even though the PML appears densely calcific, the W movement is preserved. The same patient with a degree of almost severe MR, more than 3+. And then we can see that the mitral stenosis per se is not that much. It is only coming up to 2.9 in the... and also we are seeing that there is no significant degree of PAH. Okay, so that is about the different types of degenerative mitral stenosis. Okay. Now, what are all the hemodynamic sequelae of mitral stenosis in this setting? Of course, PAH, mitral regurgitation, and usually MR due to degenerative causes alone would be moderate. As MR, as we have seen in that slide, was due to the chordal rupture. So there is an associated pathology. If it is more than moderate, then we should look for other associated pathology. Calcium can invade into the LVOT obstruction, and it can also, how many more
Dr.
minutes?
Just 1 minute.
Okay.
Oh, and so
then it can cause invasion of the AV node. Calcium can sometimes be seen as a mobile element. In one of those slides, it was a mobile element, but I couldn't recover it. Other thing is liquefaction of annular calcium. Often we see it in the OT. Surgeon will call us saying it's an abscess, but it is just dystrophic calcium with liquefaction. Migration of calcium is rare but serious. How do you measure the severity? Planimetry is difficult, as we can all imagine. And also because of the low compliance of the LV, the PHT will be wrong. Best way to look at it is by continuity equation. And also the PA pressures may not adequately correlate. Any condition with PML annular calcium, mitral gradient more than 8, pulmonary pressure more than 50, mitral valve area less than 1.5 by continuity equation is significant. We basically need to use algorithmically the different modalities. Agatson's score on CT may have a role, but it is still not standardized. There is a lot of dispute between the authorities. PISA again we cannot use because of the evident loss of LV compliance. Okay, so this is another patient where I have shown you
Dr. Meera, I think we'll have to conclude.
Yes.
Yeah.
And then the mitral valve area by continuity is 5.13. So there is no mitral stenosis. And there is also dimensionless mitral stenosis index, which is LVOT VTI by the mitral VTI. If it is less than 0.35, it is severe. If it is 0.35 to 0.5, it's moderate. If it is more than that is, if it is 0.85, as in this case, it is only a mild mitral stenosis. Thank you all for a patient listening. I hope I have made some sense. Thank you. Thank you very much.
Thank you, Dr. Meera. I think since we have shooted up, we'll not be able to take the questions. So we invite the next speaker.
Next speaker is Dr. Vivek Tandon. 6 minutes, please.
Those technical glitches, I thought they wouldn't happen. Okay, thank you.
Dr. Vivek is from Max Smart Saket, Delhi.
Good morning, everyone. Okay, so good morning, everyone. My thanks to the organizers and to the chairpersons for inviting me. I am presenting a very rare valvular case, rare in adults at least. There are two cases which I am presenting very briefly. First patient was a 34-year-old female. She had been treated for dilated cardiomyopathy elsewhere about 5 years ago. And she was admitted at our hospital with chest discomfort. Her angiography was normal. She was referred to us for echo. And on echo, in the first view, which I normally take, the plaques view, you can see there is some restriction of mobility of the mitral valve, which is also evident in the apical long axis views. There is a trivial mitral regurgitation. The flow across the mitral valve, the transmitral flow, is not turbulent. It's a nice laminar flow. When we take the short axis views, we can see that all the chordae are coming to a single papillary muscle, as we can see in these two different short axis views. The mean gradient across the valve is 2.3, which is certainly not elevated. Systolic function was mildly reduced with an ejection fraction of about 45%. So my diagnosis was that this lady, who was a follow-up case of dilated cardiomyopathy, has presented with a mild LV systolic dysfunction still present, and she has a parachute mitral valve with trace MR, no significant mitral stenosis. The second case was a 21-year-old female who had been diagnosed with a VSD in infancy, but she had no records with her. She was asymptomatic and she presented for a check echo. Now in this patient, on the plaques view, we can see the VSD. It's a restrictive VSD, also evident in the modified 4-chamber view. And in the zoom views, the peak gradient across the VSD was 106, confirming that this is a restrictive VSD. But in addition to that, if you look closely at the mitral valve, there are some aberrant chordae which appear to be attached to the interventricular septum. And there is some abnormality of the motion of the valve, which is also obvious here in the apical view. If we look at the short axis view at the mitral valve level, the anterior mitral leaflet appears to be cleft. And there are some chordae which are definitely attaching to the interventricular septum. Further down towards the apex, we can see that there is a single papillary muscle to which all the chordae which are not attached to the septum are going. The mean gradient across the valve was 5.6, not significantly elevated. So my diagnosis was a congenital acyanotic heart disease with a restrictive perimembranous VSD with a left to right shunt, a parachute mitral valve with a possible cleft anterior mitral leaflet, aberrant chordae attached to the base of the interventricular septum with a mild to moderate MR, no significant MS, normal biventricular systolic function, and no evidence of pulmonary hypertension. So the entity of parachute mitral valve is itself a rare congenital anomaly of the mitral valve apparatus seen mostly in infants and young children. Often it is associated with other congenital anomalies, including other stenotic lesions, especially in the subaortic and coarctation, in the form of subaortic stenosis and coarctation, when it can be called a Schoen's complex. It can occur as an isolated lesion. Not much is known about parachute mitral valve in adults as an isolated anomaly or in association with other congenital cardiac anomalies. In this particular paper, the authors did a retrospective search of the database over a long period of time from 1960 to 2008, and they found 9 cases of adult parachute mitral valve who met the inclusion criteria. 5 of them had an isolated parachute mitral valve and the remainder had an associated cardiac lesion. They described the diagnostic characteristics of PMV. Perhaps the most important feature is that there is a single papillary muscle which tends to be posteriorly placed. The chordae are thickened, maybe shortened, and they converge onto this single papillary muscle, which can be easily seen in the various echocardiographic views. Hemodynamic consequences of adult parachute mitral valve include mitral subvalvular or valvular stenosis, mitral regurgitation, or MR associated with a mild mitral stenosis. Compared to pediatric parachute mitral valve, concomitant cardiac abnormalities are uncommon in the adult form, and they are a smaller group of patients with milder lesions who obviously have escaped detection until adulthood. We perhaps underdiagnose parachute mitral valve in asymptomatic adults who may never come for echocardiography. And even after echocardiography, the diagnosis may not be confirmed. Thank you. No.
Cleft without a significant MR.
Yes, unfortunately, both these cases were done on a machine which does not have 3D capability. Though I did them personally, but this was not a 3D machine. It was a portable machine.
Okay.
But I think in the short axis view, it's pretty convincing that there are at least 2 parts of the anterior mitral leaflet.
Because of the tethering rules.
Yeah.
And cleft without MR
is a little unlikely. Yes, I agree with you. MR was only mild, so it was, one would expect a significant MR.
Thank you very much.
Thank you.
So I'm going to invite the next speaker, Dr. R.F. Mustaqim. Is he here?
Yes, I am here.
Okay. And his topic is interesting case of tower.
Good morning, and thanks for giving me this opportunity to present a case here. I'm going to talk about, is T still relevant during transcatheter aortic valve implantment? So in the early days, it always used to be transesophageal guided implantation, but over a period of time, it has changed, and now rarely people are using transesophageal during the procedure. But there are definitely certain situations where. So I'm going to present one case where retrospectively I can say it made a difference. So this patient was an old lady with a past history of metallic prosthetic valve bileaflet at mitral position. She had severe TR, high PA pressures, and she had severe aortic stenosis and gradient of 47, moderate AR, aortic valve was tricuspid, and there was a lot of calcium. And these were the details for implantation. And so when we started the procedure with transesophageal, we could see that the bileaflet PHV, both leaflets are moving quite well. And on the floor also we can see both the leaflets are moving. The gradient was 5 across mitral valve, PA pressure of 31 plus RAP. And so aorta also looks okay except for the calcium at the aortic valve position, and there was mild MR and moderate AR in this patient. And so this was aortic shoot, and then catheter, this wire was crossed across the lesion, and pigtail was put in the LV. We can see on the transesophageal echo also, and so we can still see the leaflets are moving quite well. And so the balloon was taken in, and balloon inflated, so there was a pre-dilatation with the balloon, and so MR remained the same, and the gradient also was okay, and leaflet movement was not affected at this point. Then subsequently valve was taken in, and valve was implanted, and as usual these self-expandable valves, we don't release the whole of it. So at this point we checked how the things are, and so we noticed that the MR was looking okay, gradient was still same, but when we looked at this, we found that the leaflet movement has got altered, and the leaflets were not moving fine. There was a restriction in the leaflet movement, and it was inferred that the aortic valve that has been implanted is impinging on the annulus and compressing and producing this slowed movement of the leaflet. And so it was, we can see on the 3D also the same issue. MR also seems to have worsened. And at this point, I can say that these finer findings we were able to pick up in time because of the transesophageal echo being there. And so the valve was retrieved and again implanted little higher up, and then the check shot was taken, and then you can see the leaflet movement has normalized. We can see very normally moving both leaflets. MR hasn't changed, mean gradient has remained the same, aortic valve gradient was just 8, and so this is the, again we have checked it, and here also we have seen on the fluoro the leaflet movement was fine, and so the valve was finally released, and this was the shot subsequently. We can see this again. We checked on the T, and we found that the leaflet movement was fine. Patient already had an RBB plus LHB, and subsequently patient went into complete heart block, and so the next day PPI was implanted. At that time also we checked that the leaflet movement and the mitral was fine, aortic gradients were fine, and so the patient was discharged the next day. Thank you.
Thank you, Dr. RF. Any questions?
Yes. In such cases where we are seeing that my prosthetic mitral valve is there, we were anticipating that we should be watching it carefully. The distance between the annulus and the mitral was very narrow. And so we have to be careful and watch all this.
So, when we decide, so it was a subaortic implantation. So, can we, I mean, it's a fantastically, very, very nice pictures. So, can you avoid this subaortic implantation by looking at the CT and get the exact measurements?
See, it was a low implant, certainly, and that's the reason why. Now, the issue is that once you have a mitral in situ as a metallic valve, you can play the games, even if it is a subaortic implant. Because you don't expect that strut to go inside the hinges of the mitral. Here, the strut one of the struts has gone inside the hinges, and that is the reason why the leaflet was so lazy. All you have to do is, so actually, when it comes to implantation subaortic versus valvular or supravalvular, once you have a mitral implantation already in place, it doesn't really matter. But it was a slow implant, and that strut went inside the leaflet. Correct me if I'm wrong, Arif.
Yes, sir. Thank you.
Thank you, Dr. Arif. The next speaker is Dr. Karthik Agrawal. Is he here? Doesn't look like he's not here. So we move on to the next speaker, Dr. Mona Bhatia, who shall be speaking on the role of multimodality imaging.
So till the time Mona is coming, Dr. Alagasan says that would it have happened in a balloon expandable valve? Am I correct? So probably not, because that is a very low profile valve. Here it is a very high profile valve. And what was the reason that we picked up any? Because it is anybody's choice. And if you would have used a smaller or a low profile valve, we would have not had this case to present.
Good morning, ladies and gentlemen. Indeed, a pleasure to be here. Thank you, Dr. Parashar and Dr. Chopra, for having me here. Indeed. So I'm going to be talking about multimodality imaging. Let's start with CMR and SPECT. Where do both of them come together? So this is a 42-year-old who presented with an acute coronary syndrome. The patient actually presented as a VT in another hospital. He was shocked and revived, and then he was brought to our hospital. A CAG was done, which showed an anomalous single coronary artery. Now the question was, is the cause of his symptoms ischemia due to the anomalous course of the left coronary artery? Because the whole point was, this was one of our director's friends, and they did not know whether they should actually go and start reimplanting the coronaries and make a difference. So on the SPECT, since myocardial perfusion was the question, a SPECT was done, and the impression was that there is a mild ischemia in the zone of the inferoseptal wall. The question again was, is the cause of his symptoms ischemia due to the anomalous course of the LCA, and does this LCA really need intervention? So then the call was made to cardiac MR. Now, cardiac MR is excellent to differentiate ischemic versus non-ischemic cardiomyopathy. And based on the localization of the late guide images, if it is subendocardial, then we know it's ischemic. If it's transmural or subepicardial, then we know it's non-ischemic. So on CMR, what we found was that there was a very focal nodular hyper-enhancing lesion in the mid-cavity in the inferoseptal region. It was non-subendocardial. It was not along the LV side. It was non-coronary in distribution. It was very focal, non-ischemic in the midwall on the RV aspect of the septum. And because there was edema, so it was definitely an acute focal edema and an acute active lesion. So the working diagnosis made was of sarcoid versus TB. And since it was the question, we did a CT on which we found multiple lymph nodes within the mediastinum. A lymph node biopsy was done, and this turned out to be a sarcoid case. Now, if you look at the spatial resolution of the lesion, what we expect on SPECT is a perfect donut. But what we had found was that there was a focal defect in uptake indicating ischemia in the inferoseptal wall. And if you look at the MR, you can see how this lesion is so focal and how the spatial resolution of CMR definitely beats SPECT. So this is just to bring out that, multimodality imaging is really the way to go. How does CMR work versus PET? Another patient who came with VT, very young patient, the CAG showed that it was normal. The echo and the BTFEs were all quite unremarkable. But what we found on CMR when we did tissue myocardial characterization, there was edema. There were multiple focal lesions within the septum. You can see this mid-wall scar with corresponding lesions and multiple subcarinal lymph nodes that were seen. If you look at the patient was then asked to go for PET because often they want activity on PET. And on PET, what they found was that the septal lesion was active, as were the lymph nodes. Now, if you look at what is happening between PET and CMR, the septal myocardial active lesions were seen on CMR also. We saw the edema, which you saw on PET. You could also see that there was a scar here. The subcarinal lymph nodes that were seen, which were active on CMR, were also active on PET. But if we look at some of the lesions that were not detected on PET, the smaller lesions were missed. So while on CMR we could see small lesions, we could see lesions in the lateral wall, in the inferior wall, and in the papillary muscle. All these were not detected on PET because the PET did not demonstrate really minute lesions. So sarcoid, when we're talking about it, CMR is definitely more predictive than PET. My next case is going to be multimodality imaging. So this is an asymptomatic 38-year-old corporate high achiever who comes for a pre-employment medical checkup to our hospital. And you know how medical checkups, you think it's going to be really fast and we don't really need to do too much. The patient has his labs, then the lipid profile is done, which all seems okay. And the patient is then due for a TMT. But just prior to the TMT, the patient has an ECG. Now, I'm sure you all read this better than me, but what the results were, they were quite unexpected. So there was an ECG T-wave inversion, and the diagnosis was made that this was suspected to be a hypertrophic cardiomyopathy. So the patient was denied the TMT and was advised to have an echo. This is the echo where there was focal apical hypertrophy. Now, since whenever there is a hypertrophic cardiomyopathy, the next step is to go for cardiac MR. So the patient, being a young adult, was sent for a cardiac MR in order to assess further management. On CMR, again, we see this inferoseptal focal hypertrophy with a focal perfusion defect. This is the dynamic imaging, and on dynamic imaging, you can see that while the rest of the myocardium enhances, this area fails to enhance, and there's a focal defect on myocardial scanning and the dynamic scanning, and you can see the corresponding scar on the delayed enhancement. So now we have three non-invasive modalities, all their hands up on ECG, echo, CMR, saying that this is a hypertrophy and this is a focal hypertrophic cardiomyopathy. But when we reviewed the CMR scans, in addition to the fact that there was a hypertrophic cardiomyopathy together with this focal defect, there were multiple small vessels that we saw along the anterior RV aspect of this patient. These were filling together with the LV. So whenever the LV was filling, we saw filling of these small vessels around the heart. So the question was, what's happening there? Was it a warning, and should we be looking at an alternate diagnosis? Now, whenever we're looking at alternate diagnosis with vessels, then we know that CT angio is going to be our best bet. So the patient then went in for a CT angio. On the CT, the left main is fine. The LED was good. The mid LED was fine. All that we saw was at the distal LED, there were few tortuosectatic ends. The LCX was perfectly normal. The RCA, however, showed a very prominent proximal RCA, and then there was this conglomerate of serpentinous ectatic dysplastic channels from the RCA together with small calcifications that was like a phlebolith within an AVM. So this was a nidus of telangiectasia and vascular malformations. Not only were we seeing vessels, but we were also seeing small intramural sinusoids. We were seeing Thebesian vessels, the whole canalicular arboriform vessels that were seen all along the septum. You could even see these few draining into the RV. So this was a coronary AV malformation with telangiectasia with focal hypertrophic cardiomyopathy. And this is a known situation where these telangiectasias are associated with hypertrophic cardiomyopathy. It's a rare congenital anomaly. It occurs within 0.1% of the population, and potential complications are myocardial ischemia, intravascular thrombosis, and hemopericardium. And so for this poor asymptomatic patient who had just come in for a lab test and just for a regular medical healthcare checkup, we'd found this coronary telangiectasia with apical inferoseptal ischemia, due to a coronary steal aggravated by myocardial hypertrophy. So definitely, whenever we're looking at multimodality imaging, we need to look at ECG, echo, CT, TMT. We don't know which one will finally clinch the diagnosis. Thank you so much.
Thank you, Dr. Mona. Any comments or questions from the audience?
This patient was requested to go for a CAG and whether anything should be done, but the patient actually denied it. He said, I don't want to get into anything further. But I'm sure you all know better than me what's further on this patient. But this was an incidental congenital anomaly. I think he was employed for sure. I think the ones that really get denied are the ones which are the pilots. So I have some of these youngsters who come who are 18 years old dying to be a pilot, and then they have some congenital anomaly or something we discover, and it's really sad to break their heart on, they can't fly. Thank you.
Thank you so much, Dr. Mona Bhatia. And thank you, audience. So we conclude this session with this talk. Thank you so much.
Thank you, chairpersons. Thank you, the speakers. Excellent talk, and I really feel that opening batsmen have done really a good job, and so is the umpires. Let's move on to the next state-of-art inter-institutional par excellence cases, and we have a stalwarts chairing this session, and I'll request our own Colonel S.K. Parashar, sir, to be on a dais. The President-elect of Indian Academy of Echocardiography, Dr. Shantanu Sen Gupta. Next is the President of the Indian Academy of Echo, Mani Vasagam, and followed by Dr. Samina Khalil, if she's over here. Can I request Dr. Samina Khalil to be on a dais? And Dr. S. Radhakrishnan. Little bit modification, give us 2 minutes of time, little bit modification of our chairpersons. And I'll request the chairperson to start the proceedings.
Hello, yeah. So this is not a competition, but we thought that every institution should produce their best case, what they have seen or so. So I hope everybody will abide by the timings also, and that is why it is a sort of a very interesting session. So the first presentation will be from Escorts Heart Institute, and Vinay Sharma will present a case of inflamed pericardium, a diagnostic thing. Can some this timer we put somewhere here or not? Because we have to see every time there.
I'll request Dr. Kshitij to attach your laptop on the side of a podium so that we do not waste any time in connecting.
Hello and a very good morning. So I'll be presenting a case. When I'm working on this case, I face a lot of questions, and answer to every question only raise further questions. I try to answer them. So whichever way the thing is going to be learning. And she was a 34-year-old lady, and she came to our lab towards the evening for a routine pre-op checkup, for a pre-op workup, as she was posted for pericardectomy for constitutive pericarditis the next morning. So I recognized the name of the patient, and I asked her, are you the same one who was admitted in the pulmonary ward about 6 months ago? And she said yes. And then I knew that things are probably going to be a little difficult. So when I saw her for the first time, about 6 months before this event, she was in the pulmonary ward. She was very toxic looking. She was running high-grade fever. She was markedly breathless, and she was constantly coughing. Now, this was the time when the first wave of corona has just started. Although she did not have corona, but that explained that how she landed up in the pulmonology ward. So I got involved because they asked us to come for an echo as she was developing hypotension. And this is what I found in that patient. It was a massive pericardial effusion with a swinging heart, collapse of RA and RB, and it was obviously tamponading, massive tamponading pericardial effusion. So a TAP was ordered and a TAP was done, and this is the post-TAP findings. So there was hardly any effusion remaining, but if you look at the images, you can see that there was a septal bounce. And despite the complete resolution, the IVC was dilated with hardly any respiratory variation. Looked further, and you find that this patient has got significant respiratory variation in the mitral inflow. There were annulus paradoxus, reverses. In nutshell, she was having all the features routinely which we look for a constrictive physiology, despite there being no pericardial effusion. So, this situation is raised the first set of questions. What are the diagnostic possibilities? Now, one possibility is that if we go by the persistent of features of constriction even after complete drainage, can we call it effusive constricting? Or if we go by the clinical setting in a patient who was markedly febrile, having very toxic looking, can we go with the diagnosis that this has got acute pericarditis? But acute pericarditis presenting with tamponade is little unlikely. It happens only in 3% patients. And then in this patient, proving the diagnosis itself was very difficult because the features like fever or elevated counts or inflammatory markers, they had another explanation in this patient, as I will show you. And ECG was, although atypical of acute pericarditis, but again, that doesn't help because typical ECG occurs only in 60%. So basically, we were all at sea. We can only make conjectures that this can be acute pericarditis or it can be effusive constricting. And I'm sure many of you will realize that all of you have faced this situation so many times. Now, fortunately, the help came from somewhere else. This patient, despite complete drainage, she continued to have low saturation and a CT was ordered. And on this CT scan, what we found is that the non-contrast CT revealed a massive area of dense consolidation in the right lobe. And the second image which we are showing shows that contrast enhancement. It suggests that there is acute inflammation of the pericardium. So, going by the old teaching that tried to explain two acute pathologies occurring together by the same etiology, I went with the diagnosis that this patient has got an acute pericarditis because of a contagious spread from the lung infection, and thereafter I lost track of the patient. I lost track with the diagnosis. And now, 6 months later, I was again standing with the same patient, and I have found her in the same situation where I have left her 6 months ago, that is with features of constriction. Now, the question that was staring us in the face was that, is it resolving pericarditis or it is evolving constriction? And there is a sound reason why this question has come up. Many patients which are known to have an effusive acute pericarditis, they do develop transient constrictive physiology. It is a very well documented phenomenon. It is documented in literature. It is one of the largest series, and what I want to point out here is that the features of constriction can take as long as 5 years, 58 months to resolve. And consider that in the patient which I am dealing, it is just 6 months from the index event. So the literature says that it can take a huge time for these things to resolve. And the suggested mechanism why it happens is that the transiently thickened and inelastic pericardium resulting from edema, fibrinogen deposition, inflammation. And that thickened and inelastic pericardium is likely to encase the heart in the same way similar to the thickened and fibrous pericardium in the constrictive pericarditis. Now, the echo signs, now this is the most important 4 lines which I can consider take-home message. That the echo signs of constriction, they're all indirect signs. They reflect the hemodynamics of a situation where the heart is caged inside inside a pericardium, and it do not reflect the cause of this inelasticity. CP is only one of them. An inflamed pericardium can be equally inelastic, and the differential diagnosis will require a direct visualization of the pericardium. So we have justified the question. Now, that whether it is a resolving pericarditis or it is an evolving constriction, the next step was how to solve the dilemma. It only comes by the direct visualization of the pericardium. The modalities commonly available to us are CT scan and MRI. On CT, the contrast enhancement suggests acute inflammation, which I have already shown you. Now I'll talk about the MRI. The cine MRI will show a non-specific overall thickening of the pericardium. The T2 weighted images will show bright pericardial signal, and that correlates with the pathological findings of edema, neovascularization, and granulation tissues. And late enhancement detect pericardial inflammation with a sensitivity of 90%. So these three things we are going to look for. Now, before I show you what happened in this patient, I will show you the images taken from the ASC statement on the pericardial disease. Look at these three MRI images. The first image, the cine image, shows non-specific overall thickening of the pericardium. The second is T2 weighted images, and they show a bright pericardial edema. And the third one is the late enhancement on gadolinium. Now we'll compare these three images with what we have found here. This is the first one. On the left hand, you can see the ASC statement image. On the right hand, the two images from our patient, which shows that there is thickening of the pericardium. Next, look at the bright pericardial edema and the ASC statement images. Look at it here in our patient, bright pericardial edema and that late enhancement. Now, all these things, they suggest that this patient has still got acute inflammation, and this is not a burned out, fibrous, calcified pericardium of the constrictive pericarditis. This patient, I called Ramji boss. Dr. Ramji was the surgeon. He agreed, postponed the surgery, and put the patient on some medication. And these are the images taken after 10 months. And about 3 months ago, I have completed almost 4 years of follow-up of this patient. She is still coming. She's absolutely fine. There were no septal bounce. IVC is normalized in size, normal MIP, no aneurysm versus paradoxus. Stain net imaging shows nothing. She was absolutely fine. And actually, she was, if you remember, she was posted for surgery next day when she came to us. So the take-home images, the take-home message is, number one, what we are seeing, that is transient constriction in a patient who is having acute pericarditis is, this is not uncommon. All of us will remember that we have tapped the patient and we still find that the patient has got features of constriction. The second is that, however, although these findings are common, but the progression of these patients to CP is very, very uncommon. It happens in only 1.8% of the patient in a very large prospective series of 500 patients, which was published in Circulation 2011. So, whenever there are features of constriction following an acute pericarditis, consider them reversible. At least give them a trial of therapy before taking up this patient for constriction. And delaying the pericardectomy will not harm the patient. If you remember the Brownwald, they start the first line of the treatment that these patients can be managed for years altogether with a judicious use of salt and water restriction. That is the first line in the Brownwald when they talk about the treatment of constriction. So, and last thing, Dr. Mona will be very happy. Use multimodality imaging, use MRI in conjunction with echo, but ma'am, still, it does not make the MRI the primary modality. Primary is us. We have picked up and we have decided MRI is to be done. Thank you very much.
In a den of lions, I dare not say we are the primary modality. Of course, you're the primary modality.
Thank you, sir. Thank you very much. Next case is, what is the cause of LVOT obstruction? Shitij Southri, All India Institute.
Good morning all. I shall be presenting some unusual and interesting cases of LVOT obstruction that I encountered over the last 1 year. So my first case is a 10-year-old girl with a past history of surgical correction for complete atrioventricular septal defect at 4 months of age. She now presented to us with dyspnea exertion class 3 symptoms for the last 1 year. So we did an echo. So this is an apical 4-chamber view, shows a hypertrophied left ventricle. There was moderate eccentric MR. And when we saw the apical 3-chamber view, there seems to be subvalvular obstruction at the level of aortic valve, and there is mild to moderate AR. So there seems to be a tuft of tissue which was attached to the anterior mitral leaflet just near the aortomitral continuity, and this seemed to be the cause of LV outflow tract obstruction. The findings were confirmed in the parasternal long axis view. Again, we can see a tuft of tissue attached at the aortomitral continuity. The gradient across the aortic LV outflow tract was around 130 millimeters of mercury. So from this case, we found that accessory mitral valve tissue is an uncommon yet an important cause of LV outflow tract obstruction, and usually it exists in conjunction with other cardiac abnormalities. Asymptomatic patients without any LV outflow tract obstruction require lifelong follow-up. However, patients can get symptomatic, and those with a significant LV outflow tract obstruction, they will require surgical management. And to our surprise, the next week, we got another patient, an 8-year-old boy who had undergone arterial switch operation plus VSG closure during infancy. And he again presented to us with LV OTO. Again, we can see a tuft of tissue which is attached at the aortomitral continuity, causing significant LV outflow tract obstruction. The next case is an 18-year-old male who presented to us with class 2 symptoms with dyspnea on exertion and angina on exertion for the last 6 months. Examination was significant for an ejection click and a grade 3/6 late peaking ejection systolic murmur. ECG showed LVH with strain pattern. On echo, the patient had bicuspid aortic valve with severe AS and no AR with a peak gradient of 130 millimeters of mercury. Since the patient was symptomatic, we took up the patient for aortic valve balloon dilatation, and the aortic valve was dilated with a Ty-Shak 2 balloon. However, post the procedure, the patient still had persistent LVOTO. This is the apical 4-chamber view, shows a hypertrophied left ventricle. Parasternal long axis view showed good opening of the aortic valve post procedure and asymmetrical septal hypertrophy. So this is the M mode confirming the findings, asymmetrical septal hypertrophy, and there was systolic anterior motion of the mitral valve leaflet, anterior mitral valve leaflet, causing significant obstruction. So this obstruction seems to be at a subvalvular level. Again, the findings were confirmed on the parasternal long axis view. There is significant turbulence at the subvalvular level, causing significant LV outflow tract obstruction with a peak gradient of around 68 millimeters of mercury. And SAM causing mild to moderate MR. So the learning points from this case were that a small, although valvular AS patients generally have concentric left ventricular hypertrophy, however, there is a small subset of patients who can get asymmetrical septal hypertrophy as well. And dynamic LVOTO, whenever it is present along with a distal valvular aortic stenosis, it may not manifest because of the afterload excess that is there. And once the distal obstruction is relieved, the dynamic LVOTO may come into force. So the asymmetrical septal hypertrophy, it can either be an adaptive response to the afterload excess, or it might be a coincidental existing disorder. So it is important to recognize. And we had a similar patient, a 15-year-old boy who had coexistent aortic stenosis as well as asymmetrical septal hypertrophy leading to dynamic LVOTO. That's it. Thank you.
Great cases, Kshitij. So we have like 1 minute. In the first case, you said that there were accessory some tissue there.
Yes.
So what was it coming from?
So it was arising from the anterior mitral leaflet, and it was confirmed on CT as well. It was an accessory mitral valve tissue.
I think it was a case of hypertrophied heart.
Yes, sir.
Yeah. So I think it's a good idea to define the mitral valve apparatus on echo all completely, because and you see almost in 10 to 12% of cases of HCMs, you have mitral valve apparatus abnormalities which can cause the obstruction. So was it a chordal SAM or what kind of?
Sir, it was a valve-like structure which was arising from the anterior mitral leaflet only, and that was prolapsing into the LVOT, causing obstruction.
Very nice.
Case.
If you look at the parasternal long axis,
Yes.
it's a very beautifully seen excessive mitral edging out, because you can see the body arising from them.
Yes, sir.
If you go back just 30 seconds, because it's very, very interesting case. Go back and show that the behavior extends into the LVOT, and from there the chordae is arising.
Please show the slides.
Very nice. And actually, it is very well defined on that.
I think it is it will be a good idea to zoom it up and try to show it, parasternal long axis view. Yeah. 6th number.
Yes. Play. And see that it is extending back into the LVOT, and from there the chordae are arising.
Yeah.
Yes.
So it is very beautifully demonstrated.
Thank you.
Should have done it better.
Thank you.
I think very nice case. Thank you so much, Ritesh. Nice cases.
Just one question. Your third case was showing a mid-systolic closure of the aortic valve. Here, Dr. H.K. Chopra this side.
Sorry, sir.
And the third case which you shown, there was a classical mid-systolic closure of the aortic valve. Was it a hypertrophic heart or hypertrophic cardiomyopathy after the aortic valve procedure?
Sir, before AVBD, we had taken up the patient as valvular aortic stenosis, and there was initially no gradient at the subvalvular level. However, post AVBD, when the obstruction was relieved, there was significant gradient at the level of LVOT as well. So maybe the dynamic LV outflow tract obstruction was not manifesting because of the distal lesion, sir.
Yeah, that's a problem.
I was ballooning done. I was not surgery done. I'm happy that surgery was not done, because the moment you would have done the surgery, afterload would have reduced, and further gradients would have manifested like the way it is.
Yes,
Unless the surgeon was very good at looking at the shelf inside and doing a myomectomy. Because this patient needed a surgery with myomectomy. But why was ballooning done?
So because when we took up the patient, he was taken up as valvular aortic stenosis, sir. There was no gradient at the subvalvular level initially.
Why BAV was done? At the age of 18 years. At the age of 18
Okay.
years. Why was BAV done? Why was not surgery done? Surgery meaning valve replacement.
Not
Why
sure.
am I surprised?
Yeah, just one more comment on that. I think that's a huge spectrum of disorders of LVH, going from the concentric to the asymmetric. So we cannot ascribe a pathology to it directly. What we need to do is look at the LVOT and the mid cavity as a whole, find out where is the maximal obstruction and exactly what's happening. And in my experience, transesophageal echo does a very good job of defining all this, looking for any subaortic membrane. The thing is, we should keep an open mind, because chronic AS also, like you said, can produce a HCM-like picture. Thanks. I think that was a very interesting set of cases.
Thank you so much, Shitish. Can I request the next presenter, Dr. Monesh Tomar? Okay, I think we move on to the next, Dr. Rekha Mishra from Apollo Hospital. Munish is here? Yeah, okay. Madam is here. So she is going to present on what is complete, corrected and isolated malposition.
I'll request Dr. Rekha Mishra, please attach your laptop to the next podium so that you do not waste time.
Rekha Mishra here.
Rekha is on. She's here.
There is a delay in setting up the laptop. Yeah, correct.
So good morning, everybody. So this sort of rare association, I'm presenting sharing one interesting case plus definition related to transposition or malposition, these are the words used in cardiac anomalies. So this is a 9-year male child with history of increasing exertional dyspnea, fatigability, and cyanosis. On examination, there was central cyanosis, clubbing. There was situs solitus, dextrocardia, no cardiomegaly, and auscultation-wise, P2 was soft and delayed with grade 4/6 ejection systolic murmur. And this was the echo starting from the subcostal view. This is situs solitus, liver on right side, stomach is here. This is aorta, IVC. So subcostal views where it was situs solitus. There was dextrocardia, and on the when we follow the segmental analysis, so right atrium is connected with right ventricle, which is hypertrophied, significantly hypertrophied, and LA is connected with the left ventricle. So AV concordance is there in this 4-chamber view with situs solitus and dextrocardia. Moving forward from the 4-chamber view, from the subcostal only going anterior. So from the hypertrophied right ventricle, which is significantly hypertrophied, there is a great vessel was arising, and on color flow mapping, there was turbulence across that. So it is a stenosed one great vessels arising from the right ventricle. Further anterior from the left ventricle, it was the another great vessel, which was the aorta. So there was no obstruction. So it was basically situs solitus, dextrocardia, AV concordance, VA concordance, but aorta is anterior. So in the most posterior plane, I am saying 4-chamber view, then pulmonary artery, and then aorta. So normally we expect aorta to be posterior and the pulmonary arteries to be anterior, but along with there is pulmonary stenosis. And this was a short axis view. So aorta is left and anterior. Bilateral SVC on two imaging you can see. So bilateral SVC was there and aorta was malposed. So what was the definition? It was situs solitus, dextrocardia, AV and VA concordance, L malposed aorta. PFO was right to left shunt, which was leading to cyanosis. In the setting of the severe pulmonary stenosis, it was mainly infundibular. Bilateral SVC, left SVC to coronary sinus with normal systolic function. Arch pulmonary veins were normally connecting. So this was a case of isolated malposition of the great vessel. So again, going to my main topic, that is complete, corrected, isolated. What are these terms? So transposition means when the great vessels are not arising from the respective ventricle, so that they are basically arising from the aorta from RV and the pulmonary artery from left ventricle with or without AV concordance or discordance. So it was basically ventricular-arterial discordance. Here great vessels has to be abnormally related in relation to ventricle and in the special relationship also in short axis view which see. When there is atrioventricular and ventricular arterial discordance, so it is physiologically corrected circulation. So it is being called as the corrected transposition of great vessels. So both are transposition with corrected or the complete transposition of great vessels. Then what is malposition of great vessels? Malposition of great vessels means great vessels can be normally or abnormally connected, but they are related to each other. They are not related normally. So normally aorta is right and normally aorta is pulmonary artery right and left and anterior to aorta. Aorta can be right anterior, that is demalposed, commonest type of malposition, complete transposition of great vessels. Aorta can be left malposed, which is the commonest association with the corrected transposition of great vessels, can be side by side, can be anteroposterior. So any sort of these fives, demalposed, L malposed, anteroposterior, side by side, or the normally related great vessels can be associated with underlying VA discordance, double outlet right ventricle, double outlet left ventricle, double outlet single ventricle, or concordance, that is isolated malposition of the great vessels. And even in transposition, whether it is TGA complete or the corrected transposition, great vessels can be in short axis normally related. So when we are going through our segmental analysis, we have to look at all the segments to reach the final diagnosis. So all segments to be described in relation to each other, where they are placed, how they are related. So these definitions are obviously to be given at the end of the, but the hemodynamics and the connections are as per the segmental analysis. So complete transposition of great vessels, where pulmonary artery and aorta are inverted. So PA from LV, aorta from right ventricle, you have atrial communication. For the mixing, you may have VSD, you may have PDA. When the communication are not great, then the child will be very blue and require so-called early intervention, that is transposition of great vessel with due to severe cyanosis. So this is complete transpositions. So RA, RV, and the left ventricle is giving right to pulmonary artery, and other view RV is giving right to aorta. And this is the parastern long axis view. The parallel great vessels LV, PA, which is going posterior, while the right ventricle giving rise to aorta, which is going into the aortic arch. And this is in short axis, aorta right and anterior to the pulmonary arteries. Sometimes you require septostomy to stabilize these babies. Otherwise, nowadays, most of the time, they are within the first week of life, they go for the surgery, that is arterial transposition of great vessels. So that is something to be done on time with the intact ventricular septum. When there is large VSD or large PDA, to give us time. So within the 1 month of age, we go for the switch operation. When the presentation is late, you go either for the sending or the 2-stage switch operation. When there is VSD-PS physiology, when we go on a VSD-PS pathway, that is BT shunt and the Restily operation later in the life. This is the surgical plan for the transposition of great vessels. Other is the AV and VA discordant, that is corrected transposition of great vessels. So here, this child, it was an infant presented with again cyanosis. So this is the situs solitus mesocardia. So heart, if you look at the heart, it is just in midline, centrally placed. So LA is connected with right ventricle, RV with the left ventricle. When we again going from 4 chamber to the 5 chamber, you can see there is VSD. You will find the pulmonary artery from the left ventricle, and then further anterior you will find the aorta from the right ventricle. And in short axis, aorta is left and anterior to the pulmonary arteries. So pulmonary artery is bifurcating and aorta is sitting here in a circle. So it is AV discordance, VA discordance with VSD-PS physiology here. So presentation with the corrected transposition depend on what is underlying defects. So it could be ASD, VSD. Very commonly is dysplastic or the abstenoid tricuspid valve leading to the significant tricuspid regurgitation. VSD-PS physiology, arch anomalies, or when present in later life with the RV dysfunction, with the systemic ventricle leading to cardiac failure and arrhythmias. The complete heart block is a very common association. Almost 40 to 50% of corrected transposition in life, they have complete heart block. So presentation could be just because of the heart block in these patients. The incidence is 2% per year, which is very significant. So in adult presentation, when patient come with the complete heart block, we should rule out the corrected transposition underlying. In these situations, intervention depend on the time, type, and the associated anomalies. On that, we decide about when to intervene in corrected transposition of great vessels. Anatomically corrected malposition, which the first case, which index case was, here the great vessels are arising from the respective ventricle. Relationship to ventricle is normal, but they are abnormally related to each other, and the bilateral conus in both. Again, the associated malposition decide the clinical presentation and the timing of and type of intervention in these patients. So in the transposition or the malposition, it is basically sequential segmental analysis should be our approach, looking at the relationship and the associated defects and the hemodynamics in these patients. Thank you.
You have to read what you saw.
Any comments or questions? अगर सबकी समझ में आ गया हो तब. It is very clearly explained, very nicely explained, I think. Very good. So now we come to...
just one little question.
Yeah.
Yeah, I think excellent presentation, as Sir has said. Basically, I think we need to think of this as a whole family of conotruncal disorders with the spiral septum, and then look at the other defects. And as you said, there is no substitute for this mathematical stepwise analysis that we go through. Thank you so much, ma'am.
Thank you.
Thanks.
Thank you, Manish. Now we come to the next presentation, an uncommon and interesting case of valvular heart disease by Rekha Mishra, who is the chief of the non-invasive department at Apollo Hospital, Delhi. Please.
Thank you very much, sir, for giving me a chance to be here. It's truly an honor. Respected chairpersons, and good morning, everyone. I am presenting an interesting case of valvular heart disease. This 24-year-old lady, she came to the cardiac OPD with chief complaints of dyspnea on exertion and YHA class 2 to 3 and palpitations for a few months. Physically, she was lean and thin built. And on cardiac examination, there was evidence of left parasternal heave, normal S1 with split S2. Systolic murmur was well heard at the apex, and ECG showed sinus rhythm with right bundle branch block. So she was sent for an echo in the department, and these are the pictures. Started with a parasternal long axis view. We can see that the LV function is fair, and the most striking thing what we see is the mitral valve is slightly thickened, and there is appears to be a diastolic doming of the AML. But when we look carefully, the outlet segment of the LV is more than the inlet segment of the LV, so it's the typical gooseneck deformity. Short axis view. The RV is dilated, and in the second picture we can see that it's a clear mitral valve and there is no cleft. Short axis at the base of the heart, the aortic valve is normal, the pulmonary valve is also normal, and there is normal laminar flow in the pulmonary artery, and the pulse width Doppler across the pulmonary valve also shows this a normal velocity flow and good acceleration time, suggesting that the pulmonary vascular resistance is not high. And four-chamber view, there is evidence of a large primum ASD measuring 4.1 centimeters, and there is no VSD. And the left atrioventricular valve is normal from this side, and there is a tricuspid valve with a subvalvular apparatus seen clearly. And just beneath the RV, we can see that there appears to be another chamber. And when we look carefully in the next slide, we can see that there are two tricuspid orifices. One is very close to the interventricular septum, and other is just adjacent to it. And both of them have the independent subvalvular apparatuses. So it's a double orifice tricuspid valve, and color flow across the left AV valve, there is just mild regurgitation. And when we look at the tricuspid valves, the first valve close to the interventricular septum, there is a severe TR having an eccentric jet directed towards the left atrium, and the second valve in the second picture is just mild TR. And the continuous wave Doppler across the tricuspid regurgitation, it was a low pressure TR. The gradient was just 16 millimeters of mercury. And the RV function was normal, suggested by the staff say it was 26 millimeters of mercury. So the final diagnosis was a cyanotic congenital heart disease with partial AV canal defect and double orifice tricuspid valve. So review of literature shows that double orifice tricuspid valve is an extremely rare congenital anomaly, and the first case of tricuspid duplication was described by Pisenti in 1888. It is the presence of an accessory subvalvular component that distinguishes true duplication from a simple fenestration of the valvular leaflet, and isolated occurrence is extremely rare. It is associated with other congenital cardiac malformations that determine the patient's outcome. And most commonly associated malformations with double outlet tricuspid orifices are the septal defects, comprising of 40% of the associated lesions, then mitral valve malformation, pulmonary valve malformation, Epstein's anomaly, tetralogy of Fowler, and transposition of the great vessels. And the classification of double outlet tricuspid valve, Hartmann was the first person to describe the types of double orifice atrioventricular valves in 1937 into three types: the L type, 2 ostia of unequal size; B type, 2 equal-sized ostia without an independent set of chordae and a set of papillary muscles for each ostia; and S-type, 2 similar-sized ostia with each orifice has an independent set of chordae and a papillary muscle. So our case was S-type. There were 2 ostia, they were equal-sized and having independent subvalvular apparatus. Thank you.
What a great case. What a great case. Any comments from, I think, Sameer and Munesh may give some comments.
So, 2 questions. One is, what was the axis on the ECG? And number 2, how many papillary muscles were there on the left side?
So actually there were multiple, when we look at this, the picture, there were multiple, the subvalvular apparatus, when we look at it, there were multiple, this thing.
Can you show the case? Can you put the slide, please?
Yeah, I'm showing it. This one, sir.
Audiovisual guys, can you put the case, the slides?
One is this one. And there's multiple, and they had independent subvalvular apparatus.
No, you're showing the right side. I wanted to know about the left side. Left papillary muscles, how many were there?
The left papillary muscle.
Because I could see only one. Because if you go back onto the fix, one was a moving slide on the left side, and then the fix was there. And in that, I thought it was a single papillary muscle. Go back. Back.
Okay.
Back. There was one slide in which left was moving. That was the first or the second slide. Go back.
Previously.
Yes, this one. If you play this, the left one will play, right will not play. And there I thought that there was a single papillary muscle. It didn't show as if it was moving.
But there was no stenosis and...
I am not too sure about stenosis because AML was doming, which is a part and parcel of the AV canal defect.
That is like gooseneck deformity,
correct.
Sir.
But I am not too sure. Anyway, and what was the axis?
So it was a right ventral branch block.
With axis?
I don't remember, sir.
Doesn't matter.
I think it's a very nice case. Any way you can show, it's possible to get an in-fast view? Because I know it's a difficult imaging.
It was a difficult imaging, actually. Yeah. I have shown in the short axis view. The mitral valve, there was no cleft, and the commissures were not fused or anything. This is at the mitral valve level.
But I think if you can try to put on the tricuspid, and it's a very difficult. Put on the left side. See, you are looking at the tricuspid valve over there. So if you focus, it's a very nice case. I think the papillary muscles in the chordae should be highlighted.
I think subcostal short axis view, that gives the en-face view of the both AV valves, especially in the AV canal defects.
Yeah.
That is the best view to define the AV valve.
In this AV canal defect, I think the valves are so deformed, so you may not be able to do it, but an effort should be made.
Yeah.
Great case. Thank you so much.
Thank you.
So if I can request Dr. Manish Bansal from Medanta, he is going to show us a case of pulmonary hypertension, unraveling the cause.
Good morning, everyone. So I am going to show a case of severe pulmonary hypertension in an elderly patient which we come across recently. So this was an 83-year-old gentleman. He had hypertension, no diabetes. He had undergone CABG and aortic valve replacement in 2010, around 14 years ago. He had received 2 vein grafts and a 19 mm size peri-mount valve at aortic position. So he was doing well after that, but for last 1.5 years, he started having exertional dyspnea, with which he presented, and he underwent initial evaluation at other centers. His stress nuclear scan was done to look for any inducible ischemia. It was normal. Echo was done. It showed severe pulmonary hypertension. Angiogram was also done because he continued to be symptomatic. 3 months after the thallium scan, showed native triple vessel disease. Both the grafts were patent, and there was no new obstructive disease apart from the disease in the third vessel, which was not amenable to revascularization right from the beginning. Now, his symptoms continued to worsen. He developed bilateral pleural effusion, also underwent pleurocentesis twice. The fluid was transudative, so it was all because of back pressure, so congestive heart failure. These are echo images when he presented to us. In the echo, the plaques view and the short axis, there is nothing really remarkable except that the left atrium appears dilated. There may be mild LVH, prosthetic valve, not well seen but looked okay. This is the apical fourth chamber view. In this, there is mild degree of LVH, vital enlargement is there. LV systolic function appears near normal. On actual estimation, EF was 50%, LV GLS was mildly reduced, minus 15.2%, but there was no specific pattern to suggest any kind of cardiomyopathy like amyloidosis. Valve function was okay. He had mild valvular AR, and the mean max gradient across the aortic valve were 19 and 35 millimeters of mercury, which was only slightly elevated for what we would expect in tissue valve at this position. But when we looked at mitral inflow pattern, it was clearly restrictive pattern. E by A ratio was 3.5. E velocity was quite tall, 111 centimeter per second. Medial and lateral E primes were reduced, 4 and 7 respectively. So the E by average E prime ratio was very high, 20, suggestive of significant LV diastolic dysfunction. Looking at the right side, he had mild TR with TR gradient of almost 75 millimeters of mercury, and RVOT flow very suggestive of pulmonary hypertension. As we can see, the acceleration time was very short, 61 millisecond, and there was mid-systolic reduction in the flow also, so suggestive of very severe pulmonary hypertension. IVC was high normal in size, collapsing, suggestive of CVP around 8. So all these findings basically showed that he had near normal LV systolic function, aortic valve function was okay, he had grade 3 LV diastolic dysfunction, and he had severe PH with pulmonary pressure around 90 millimeters of mercury. So to further evaluate him, we looked at other parameters. So among lab parameters, most of it was normal, except that NT-proBNP level was very high, 2260. ECG was normal, not a low voltage ECG to suggest amyloidosis. Serum free light chain ratio was almost normal, 2.4. Immunofixation electrophoresis also did not show any AM band. So there was no hematological disease suggestive of amyloidosis. Now, because he had severe PH, we performed CTPA to rule out pulmonary embolism. So there was no pulmonary embolism or DVT. But the CT also reported normal pulmonary arteries in size, which was quite surprising, because with this kind of severe PH, we were expecting the pulmonary arteries to be dilated. But probably it was a relatively short duration history. That's why the arteries were not dilated. Pulmonary function test was done. It showed only moderate airway obstruction. So no significant lung disease also to explain significant pulmonary hypertension. Now, because he had advanced LV diastolic dysfunction, we performed cardiac MRI. So there was no suggestion of any myocardial disease. There was mild RVOT hypertrophy. MPA was normal size, and there was moderate pleural effusion on the right side, which we knew that had always been there. So basically, what we found was severe PH and grade 3 LV diastolic dysfunction, but PH appeared to be out of proportion to the LV diastolic dysfunction. So we eventually performed cardiac cath to further assess the pulmonary hemodynamics. So as we can see here, mean PA pressure was 30, so clearly significant pulmonary hypertension. The wedge pressure was 14 and PVR was 3. So if you look at the criteria for pulmonary hypertension, this would actually fit into pre-capillary PH, because wedge pressure was less than 15 and PVR was elevated. So it would be here. But we knew that this patient had severe LV diastolic dysfunction. So this slightly lower wedge pressure could have been because of the diuretics that the patient was on. And we also did not make him do exercise in the cath lab. So this was probably underestimation of the wedge pressure. And PVR was slightly higher than normal. So we eventually made a diagnosis of combined pre and post capillary pH, but predominantly group 2 pH, and most likely heart failure with preserved ejection fraction. So based on this, he was started on ARNI along with the pH therapies like ambrisentan and tadalafil. His next follow-up was done over video consult 2 months after that evaluation. He was symptomatically much better. We've not had any follow-up since then. So this was in short about this patient. Most likely elderly age-related idiopathic restrictive cardiomyopathy resulting in significant heart failure with preserved ejection fraction leading to significant pH. And some component of group 1 pH also could have been there, but predominantly group 2 pH presenting with persistent right heart failure, bilateral pleural effusion, transutative. Thank you so much.
Great case, Manish. Just a comment. So the PVR was 3 Wood units. It was like borderline. So did you measure the tricuspid valve annulus size? Or can this be AFTR?
Sorry?
Atrial functional TR.
TR was only mild.
Okay, TR was mild.
He had severe pH. TR was just mild.
Manish, I need to look at the AR. If you look at one of the slides, I thought AR was significant. And there is some AR here, but in one of the see, AR is there. Now look at the diastolic blood pressure, 46. 154 by 46. This is an AR which I would have wanted to be defined better, because I didn't see the suprasternal, and forget about the abdominal, but I am not too sure that did we miss on the AR which was significant. LV is not dilated, I agree, but it's a very short history, so it could be. Yeah. And certainly it's a smaller size valve. Valve is 19. It is 19, a little better than pediatric size, but
in India we most often use 19.
Not in size. India, but yes.
But sir, this patient did not have significant AR. I don't have the other images.
Not this one. One more clip, and you would have the AR.
Actually, sir, the mean gradient is also not that high to
blood pressure
consistent with
154 by 46.
Possibly because of age-related arterial stiffness. At that age, isolated systolic hypertension is very common, because if AR had been significant, mean gradient across the aortic valve should have been much higher.
This is tissue valve 10 years back.
15 years old.
15 years old. So I'm not too sure whether it will really translate into those logic.
I think it's surely a case of HFpEF. That's a substrate. But I can you look at the tricuspid valve? I mean, do you have the TR thing there?
So with color, I don't have the image here. It was mild TR only.
Right. But I think you have the envelope of TR.
Yeah.
Can you?
Yeah.
So if you see the envelope TR, it goes to 4. So I think it's a multiple things happening together. There is a HFpEF component, there's a mild AR component, a lot of things. But this is the challenge we face on a day-to-day basis. Interesting case.
So in this patient, pH appeared to be out of proportion to his diastolic dysfunction. Although patients can present with severe pH, but it was too high PA pressure for his LV diastolic dysfunction.
Yeah, what I would suggest, see, we are seeing 2 jets of AR there. There is a bigger jet that's going to the apex. There is a smaller jet on the side. And these kind of patients, as you are looking at the 3-inch chamber, as you are focusing on the AR, if you kind of try and close the aortic valve, then you'll see the entire spectrum of the AR jet. I think this is probably a significant AR. Also, you see the motion of the mitral valve that shows the AR jet impinging on it.
Yeah. So actually, I don't have the images in this presentation here, but this patient did not have significant AR. Yeah.
I just have to ask one
Professor,
question.
yeah.
I hope this is Anita Saxena.
Ji, ma'am.
Just wanted to know there is no element of OSA, because I have had some elderly patients presenting with pulmonary hypertension, and we don't get that history because we are not with them. But you have to really, ask for that history from the people
Yes, ma'am.
around.
So this was a relatively thin-built person. I should have mentioned the body mass index also here.
I mean, the tissue valve obviously is degenerated, and there's AR. So when did you do a follow-up after that?
Sir, he connected with me via video consult 2 months after this presentation. He was symptomatically better. I asked for a repeat echo, but he has not had another consultation so far. So I should be having a consult with him in the next 1 month.
Yeah, because these valves degenerate very quickly now, because you're seeing at least moderate AR there, and then it's going to turn into severe AR very soon. I'm not sure about how much AR is contributing to rise in LV filling pressure, because it's difficult to estimate what the severity of AR is, but your pulse pressure is very high. I don't know how can you explain that. I mean, diastolic pressure was only 46, did you say?
Yeah, but sir, at 83 years age, we commonly see patients coming with diastolic blood pressure in that range.
Okay. Yeah.
Thank you very much for the nice cases we had in this session. Very great cases. Thank you very much for all the speakers. Now we go to the next session, please.
Thank you, chairpersons. Thank you, speakers. A great interactive session. And I'll have a pleasure to introduce two very important persons over here. We have with us none other than Dr. Professor Anita Saxena. She is, ma'am, please be over here. She was a professor, head of department of All Institute of Medical Sciences. Then she moved on to Vice Chancellor at Pandit B.D. Sharma, University of Health Sciences at Rohtak. And she's back with us now as a head of pediatric cardiologist at Fortis Ascot Heart Institute, New Delhi. Thank you very much for being with us. And I can say, like, many of our students are sitting over here. And I still remember my days when I started my training program in Ashok Vihar in Sundarlal Jain Hospital. She was there to support me in the beginning of my programs. That's what the personality is. And next we have very elegant person from UK, my colleague, my friend, my elder, Dr. Professor Roxy Senior. Roxy, please be just over here. He is a cardiologist based at Imperial Heart Institute at London. And you must have learned a lot of, or seen a lot of his work on myocardial contrast echo, especially with stress echo. Thank you, Roxy, for being over here with us. Thanks. And now, let me move on. We are right on time. And this is, people says Indigo Standard Time. We say Dr. Prashar's time, Colonel Prashar's time, CPT time. So we have moved on to the next session. And the next session, we'll request the chairpersons. We have the chairpersons, Dr. Rahul Mehrotra, Dr. Vinay Sharma, Dr. Purabi Koch, Dr. Rajat Mohan. Dr. Rajat, can I request, Dr. Rajat Mohan is President of Delhi branch of a CSI on a dais. Vinay Sharma is in, you must have heard Vinay Sharma from Fortis Heart Institute. And Dr. Purabi Koch is a cardiologist, non-invasive cardiologist based at Kokila Hospital in Mumbai. And I'll request the chairpersons to start the proceedings.
So now we come to the next session, that is emerging concepts and dilemmas in valvular heart disease. And to start with, I will invite Dr. Algation. We all know him, a very senior person, on the etiology of TS and TR. Sir.
Thank you, Chairperson, dear Captain and colleagues. Going to present the etiology of...
Dr. Alagation, may I tell everybody who's the captain? If you allow me.
Yes.
Dr. Alagation always called Dr. Parashar as captain. Captain of the ship. He called him coach. So it's a coach-captain combination. Triple C.
Going to discuss only the etiology of tricuspid regurgitation. Tricuspid stenosis will skip. The common cause of tricuspid regurgitation in 70% of the people is physiological tricuspid regurgitation. Tricuspid regurgitation is either absent, trivial, or mild in normal people. If it is more than moderate or more than moderate, then it is pathological. The Carpentier classification can be used for describing the mechanism of my tricuspid regurgitation. Type 1, normal leaflet and normal caudal motion. Type 2, prolapse or excessive motion. And type 3, restricted motion of the tricuspid valve leaflets. The etiology of tricuspid regurgitation previously was described as primary and secondary. Primary due to leaflet abnormalities and secondary or functional TR with normal tricuspid valve leaflets and normal supporting structures. The present classification which has been suggested is the secondary tricuspid regurgitation is divided into atrial secondary tricuspid regurgitation and ventricular secondary tricuspid regurgitation. Then we have the primary tricuspid regurgitation, which occurs only in 10 to 15% of the people with tricuspid regurgitation. And we have another category called cardiac implantable electronic device related tricuspid regurgitation, which can be again divided into primary and secondary. So there are a number of causes for primary tricuspid regurgitation. We'll see a few causes. This is a patient with flail anterior tricuspid leaflet. In anybody with having a normal thickness of the tricuspid valve with a flail leaflet like this, you should ask for a history of any accident which may be remote and the patient may not remember. One of the causes is trauma, chest trauma. So this patient has got a flail anterior tricuspid leaflet with a massive tricuspid regurgitation. Another not uncommon cause is Epstein's anomaly of the tricuspid valve. You can see the sail-like motion of the anterior tricuspid leaflet. There is delamination of the anterior and the septal leaflet and the posterior leaflet, producing severe tricuspid regurgitation in this patient. The regurgitation may vary from mild, moderate to severe as in this patient. This we used to see often traumatic tricuspid valve disease with restricted mobility of the tricuspid leaflets. You can see associated severe mitral stenosis. There is tricuspid stenosis and regurgitation in this patient. There is a significant gradient across the tricuspid valve, which can be used to assess the severity of tricuspid stenosis. This is a patient with infective endocarditis of the anterior tricuspid leaflet, producing severe tricuspid regurgitation. This is especially common in our parts, usually due to septic sepsis during delivery and also in patients who are drug abusers. And this is a patient with carcinoid heart disease. There is involvement of the tricuspid valve, restricted mobility of the anterior and the posterior tricuspid leaflets, producing severe tricuspid regurgitation and systolic reversal inside the hepatic vein also. Endomyocardial fibrosis can affect the left ventricle and the right ventricle. Here this patient is having a left ventricular endomyocardial fibrosis and a right ventricular endomyocardial fibrosis with mitral regurgitation and tricuspid regurgitation. This is usually due to the plastering of the leaflets to the ventricular wall. This is a patient who underwent device closure of ruptured aneurysm of sinus valsalva. During the procedure, they have accidentally torn the anterior tricuspid leaflet here, and there is a tear in the anterior tricuspid leaflet producing a significant tricuspid regurgitation. These are the primary causes of the tricuspid regurgitation. When we come to the secondary tricuspid regurgitation, they can be divided into ventricular secondary and atrial secondary tricuspid regurgitation. This is a patient with atrial fibrillation at the onset of atrial fibrillation. So this patient has a mild tricuspid regurgitation. This is after 2 years, the regurgitation has become a significant one, moderate tricuspid regurgitation. The atrial secondary tricuspid regurgitation can occur in atrial fibrillation and also in heart failure with preserved ejection fraction. In these patients, the tricuspid annulus is dilated, but the ventricle is usually normal in size, or it dilates only in the basal portion, and the conical shape of the right ventricle is preserved. The right atrium is markedly dilated, especially in patients with atrial fibrillation. These are the classical features, and there is no evidence of tethering of the tricuspid leaflets in the initial stages. This is another patient with tricuspid regurgitation, a significant one with an atrial secondary tricuspid regurgitation. The right atrium has got markedly dilated. The tricuspid annulus also is dilated. The basal portion of the right ventricle is dilated, but the conical shape is maintained, which differentiates it from the ventricular secondary tricuspid regurgitation. This is an example of ventricular secondary tricuspid regurgitation, where there is dilatation of the right atrium, but it is much lesser than what it happens in atrial fibrillation. The tricuspid annulus again is dilated, but it is lesser than in atrial fibrillation, and the right ventricle is much more dilated, and the apex is elliptical. It is not triangular, it is elliptical. So these are the differentiating features between the atrial secondary tricuspid regurgitation and the ventricular secondary tricuspid regurgitation. In both the conditions, there is a dilatation of the tricuspid annulus, dilatation of the right atrium, and dilatation of the right ventricle, which differs in the degree of the dilatation. The tricuspid annulus also, instead of the saddle shape, it becomes flat, and the anterior position and the posterior points are flattened, indicating that there is a tricuspid annulus dilated. Here again, you can see in atrial secondary tricuspid regurgitation, the right atrium is markedly dilated, the tricuspid annulus is markedly dilated, but the right ventricle is small, it's almost normal in size. There is no tethering of the tricuspid valve. The right ventricle is conical in shape. Whereas in left heart disease or pulmonary hypertension producing ventricular tricuspid regurgitation, the right atrial dilatation is lesser. The tricuspid annulus dilatation also is lesser. There is tethering of the tricuspid valve during systole. If you have any doubt, you can go to this classification, which describes the leaflet morphology, chamber size, the systolic function, etc. This is the Tricuspid Valve Academic Research Consortium differentiation between atrial secondary and the ventricular secondary tricuspid regurgitation. If you go cases of ventricular secondary tricuspid regurgitation, this is a patient with severe primary pulmonary hypertension, marked dilatation of the right ventricle. In these patients, the right ventricle, the posterior papillary muscle is usually displaced, and the septal papillary muscle also is displaced in these patients, producing a tethering of the tricuspid valve and a severe tricuspid regurgitation in this patient. This is a patient with rheumatic mitral valve disease with the tethering of the tricuspid valve, producing secondary tricuspid regurgitation ventricular. You can see the mitral valve disease. Most of the patients who are operated, who later on go on to develop ventricular secondary tricuspid regurgitation. This is a patient with dilated cardiomyopathy producing pulmonary hypertension and secondary tricuspid regurgitation. There can be primary disease of the myocardium also, which can produce right ventricular myocardium, which can produce tricuspid agitation significant. This is a patient with inferior wall infarct. The left ventricular function is almost normal, but you can see the akinesia of the right ventricular anterior wall. Here you can see the akinesia of the right ventricular wall. The apex is moving briskly, the mecanal sign. And there is a severe tricuspid regurgitation with the dilatation of the IVC and aorta, IVC with absent respiratory changes. Here there is another example of inferior wall myocardial infarction with ventricular secondary tricuspid regurgitation. A massive tricuspid regurgitation here. And this is a patient with dilated cardiomyopathy affecting only the right ventricle, producing tricuspid regurgitation. So there are two types of ventricular secondary tricuspid regurgitation: left heart disease producing pulmonary hypertension and tricuspid regurgitation, primary pulmonary hypertension or pulmonary hypertension due to other causes which can produce secondary tricuspid regurgitation, and RV myocardial disease which can produce secondary ventricular tricuspid regurgitation. This is another example of rheumatic mitral valve disease with atrial fibrillation and all that. I'll skip this electronic devices induced tricuspid regurgitation. It can be primary or secondary. This is an example of primary. Here is an example of secondary. This patient has had a CRT. The lead position is excellent. It is in the center. It is not producing any obstruction of the to the tricuspid valve movement, but there is significant regurgitation due to the left heart disease. So it is a ventricular secondary tricuspid regurgitation occurring in a patient with CRT. And when you want to assess the CRT, we have to use all the modalities: transthoracic echo, transesophageal echo, and three-dimensional echocardiography. And these are the pictures which I obtained from the literature. The lead impinging over the anterior tricuspid leaflet, lead impinging over the septal leaflet, lead impinging over the posterior tricuspid leaflet. This is another thing where the lead position is good, non-impinging. In the middle, it is in the anterior-posterior commissure. Here it is over the posterior commissure. Here it is the anterior, between the commissure between the anterior and the septal leaflet. So when the lead position in the commissures or in the middle, it doesn't interfere with the leaflet movement and doesn't produce significant regurgitation. But it is near the septal, posterior or anterior leaflet, it can impinge and produce significant secondary tricuspid. I will leave you with the last case. This is a patient who has undergone mitral valve replacement with a disc valve. So the right ventricle is markedly dilated due to pulmonary hypertension. This patient had a tricuspid annuloplasty with a ring, but the ring has given way. It is very difficult to repair the tricuspid valve, either a Divega or other modifications, or even with the ring. The ring gives way, and this patient has got a torrential tricuspid regurgitation, and there is right ventricular dysfunction also. Apart from that, you can see that pulmonary valve. You can see marked dilatation of the right ventricle and right ventricular outflow tract. Even the pulmonary valve is not able to close properly, and this patient has got almost the flow is continuous between the right ventricle and the pulmonary artery with a severe pulmonary regurgitation. Thank you.
There's only one question, Dr. Allegation. I think it's a very nice presentation. We have published recently an article in Indian Heart Journal on HFpEF and left atriopathy. Is there any association of left atriopathy with right atriopathy in HFpEF? HFpEF with left atriopathy is very well known, and Dr. Solomon from Harvard has classified it into 4 categories: A, B, C, and D. C and D are irreversible because there is a lot of fibrosis. But in the right side, I have not much information. Is there any evidence of right atriopathy in HFpEF? Left atriopathy is known, and it's all very well known, but I don't know about the right side or a combination of both right and left atriopathy in HFpEF.
I don't know about right atrial cardiomyopathy. Left atrial cardiomyopathy is very well described. Right atrial cardiomyopathy also occurs in different conditions in patients with right heart disease, but I'm not specifically know about right atrial cardiomyopathy in HFrEF.
As such, we are not really doing strains of right atrium as such. So right atrial cardiomyopathy as a term as such is not there presently. Well, thank you, Dr. Alagasan. It was a beautiful collection of different etiologies of tricuspid regurgitation. And if there are any more questions, if none, we'll move on to the next speaker. Dr. Simi is already here. She'll be talking on assessing significance and severity of forgotten pulmonary regurgitation.
Thank you, sir. Good morning, everyone. Good morning to respected seniors and dear friends. So it was a masterly presentation by Dr. Elaghazen, and I'm feeling very small in front of him because my presentation is next. So I'll try to do justice to my presentation. So the topic given to me has been assessing significance and severity of forgotten PR. Actually, it's an extension of tricuspid valve only, because earlier, 10-15 years back, we were paying a lot of attention. We started paying a lot of attention to tricuspid valve because it was then considered that it was a forgotten valve. And as now we have, we are now tuned, our minds are tuned to look more carefully at the tricuspid valve. Now is the time, I think, has arrived for pulmonary valve also. So I'll start my talk with a case. This is a 52-year-old lady, and she is a post-AST surgical closure, and there was a history of intervention to pulmonary valve also 5 years back. But now she started having fatigue, dyspnea, class 2 for last 6 months. ECG was showing RBB. The slides are not very fluently moving. Slides move karne mein. So this is transthoracic echo, and you can see this is the parasternal long axis view. The LA, LV, mitral valve, aortic valve, all are looking okay, but RV is looking dilated. And on the short axis view, this confirms that there is some element of RV dilatation. RV function looks okay, and there was no significant TR was observed. The slides are not moving, please. But this one. I'm trying to do it. It's not going. This one? Yes, ma'am. So. Tissue Doppler across the RV free wall, systolic function of right ventricle is normal, and CW across the tricuspid valve, PA pressures were relatively okay. So this is a short axis view. I'm trying to focus on the pulmonary valve, and you can actually see that there is thickening of the pulmonary valve and there is some disruption of the pulmonary valve. This patient had severe pulmonary regurgitation, probably had a balloon valvotomy at the time of AST repair, and now she's presenting with severe pulmonary regurgitation. We need to follow up the patient, and she might need an intervention in the future. So this is the flame of pulmonary regurgitation. You can actually see the width of the PR jet and the length. This will actually tell us about the severity. I will further elaborate in my presentation. And this is a color M mode, and you can see that the whole of diastole, there is pulmonary regurgitation jet seen, similar to what we see in patients of aortic regurgitation. So primary PR, as you know, is due to abnormality of pulmonary valve leaflets. It could be due to congenital heart disease, it could be post-off repair, and also post-balloon valvotomy for pulmonic stenosis. And secondary PR, by definition, pulmonary valve leaflets are normal. And rare causes, it can occur in less than 1% of the patient with history of rheumatic fever, infective endocarditis, carcinoid valve disease, and also in blunt chest trauma. Secondary PR is most common with elevated PA pressures, although the volume of regurgitation is usually small. So goal of echo evaluation for PR is identify and assess abnormal degrees of pulmonary regurgitation. For that, we need to inspect the RVOT take a good look at the pulmonary annulus, MPA, and proximal branches. And we have to try and conclude and come to the etiological diagnosis and look for associated lesions, because ultimately consequences will depend upon that, and definitely decision of management will come from there. So mild PR is a physiological PR. Whenever you do an echo, you put a color Doppler, a small spindle-shaped color droplet can be picked up as a physiological PR when you're doing short axis, and whenever you put a CW across it, you can get a PR jet. If the jet is mild, it will be a faint looking jet and the envelope may not be complete. Jet length of less than 10 millimeter is suggestive of insignificant PR, especially if it is narrow at origin. And in severe PR, the width of the jet would be wider and the length would be bigger. So important thing is that when you take a spectral Doppler across it, the jet would be, a dense envelope. So how to pick up the PR jet, that is pulmonary artery, it can be imaged in parasternal short axis view or in subcostal view, which is very favorite of pediatric cardiologists, and you can actually pick up the pulmonary valve in both these views. Regarding coming to the grading of severity of PR, definitely jet size, as I have described, is important. Less than 1 centimeter in length, thin flame-shaped, narrow at origin is usually mild. And for severe, as you can have a look, it is generally a large jet with wide at origin, but duration does not matter here. Regarding jet density and deceleration rate by CW, we can get the grading of PR. So if it is mild, the envelope is soft and there is a slow deceleration is there. But in cases where there is severe PR, it is a steep deceleration, jet is dense, and there is an early termination of diastolic flow, because sometimes there can be equalization of RV pressure and the pulmonary artery pressure. So actually the jet will terminate early. Pressure half time less than 100 correlates with hemodynamically significant PR, and sensitivity and specificity range up to 90%. Regarding grading, according to jet width, you have to take a ratio of jet width and RV outflow diameter. It is mild if it is less than 1/3, and severe if it is more than 2/3 of the RVOT outflow diameter. Regarding PR index, we can use a CW jet and duration of PR and total diastolic time. So you have to calculate the diastolic time and the duration of the jet. If you take this ratio, if it is less than 0.77, it indicates significant PR. Other important parameter is diastolic flow reversal. So all the calculations we've been doing till now were at the level of pulmonary valve. Now you go into the MPA or into the branch pulmonary arteries. If there is a diastolic flow reversal in MPA, that is, if you see a red color Doppler signal, which is very clearly evident here, you can actually see the red color Doppler, which is actually diastolic flow reversal. If it is mildly seen in MPA, it is a mild PR. But if it is a severe diastolic flow reversal, that is like a white arrow. This is a pulse Doppler across it, and you can see a dense reversal here. It indicates that it is a severe pulmonary regurgitation. So this is again depiction of the red contrast, and it's a diastolic flow reversal in the MPA. Another parameter is grading the severity of PR is diastolic systolic time velocity integral. So you can actually take a pulse wave Doppler across the pulmonary valve, and you can take a VTI of the systolic and the diastolic VTI. Take a ratio, that is diastolic TVI and systolic TVI. If the ratio is more than 1, it is severe PR. If the ratio is less than 0.49, it is mild PR. Other parameters are like calculation of regurgitant fraction. By taking a RVOT stroke volume minus the LVOT stroke volume, you get the regurgitant volume. And if you calculate, put it in the formula of regurgitant fraction, that is 1 minus this ratio into 100, you get the regurgitant fraction. So more than 40%, it indicates severe pulmonary regurgitation. Vena contracta, we can definitely take a measurement across the narrowest point and calculate the severity of PR. PISA is not considered very important here because the assumption of hemispheric shape is not valid in cases of PR. So once you take a color Doppler across chronic pulmonary regurgitation, you have to decide whether it is mild. If we've discussed most of the parameters for severity in mild PR as well as for severe PR, and you can grade it mild or severe. I will just show one or two cases. So this is Dr. Alagason has already shown the tricuspid part of it. This is you can see the thickened tricuspid leaflets and they are very stiff. This patient had presented with palpitations, flushing and diarrhea. And taking a look at the pulmonary valve, again there is thickening and the valves are stiffened, and this patient has severe pulmonary regurgitation. So you can take all the possible calculations to decide the severity of PR, and this patient had a early diastolic flow reversal in the MPA itself, and again spectral Doppler across it, severe PR. This is another patient who is a post-TOF repair and had a history of infective endocarditis, and you can see a big flagellar structure at the level of pulmonary valve, and this patient also had severe PR. So post-TOF repair, you can take the PHT less than 100 milliseconds. So again, concluding that this patient has severe PR post-TOF repair followed because he had infective endocarditis led to further worsening. So diastolic flow reversal is mild PR if it is originate only in MPA, but if it goes up to distal PA branches, it is a marker for severe PR. This is a patient with grade 1 pulmonary arterial hypertension. You can see these pictures of, you can see that there is a D-shaped septum, RA-RV are prominent, and when you take color Doppler across it, there is evidence of pulmonary regurgitation. This will actually help us in calculating the diastolic PA pressures also, besides the systolic, which can be calculated from the tricuspid regurgitation. So you can, so finally, coming to my last two slides, significance of PR. It tends to occur in younger population who have been treated with pulmonary valve stenosis, RVOT obstruction or TOF. It is also common in patients with pulmonary arterial hypertension. Diverse range of etiological factors, they contribute to PR and hence its treatment. PR causes volume overload and dilatation of RV, and so most patients they represent with right heart failure. And finally, it is a neglected valve in routine adult echocardiography. So we are trying to make a mark. We should all try and look up for the PR, and it is easily viewed and assessed with transthoracic echo. Patients of TOF repair often have PR. So assessment is important because it's a asymptomatic pathology initially, but ultimately enlarged RV, and then you have to take a call when you want to do a pulmonary valve replacement, because these patients' longevity is increasing, our follow-up is increasing. They can have interventions and have a better quality of life. Thank you so much for your patient listening. I'll be more than happy to answer any questions.
Yeah, I think it's a really nice, comprehensive talk and wonderful images. Just a couple of technical comments. One is, I think, significance of PR is basically its impact on the RV. So in any case of PR, we will have to objectively assess the RV in terms of RV, FAC, strain rate imaging, and so forth, and the, of course, TAPC. So you would have to look at it more objectively, the RV.
Point well taken, yeah.
That, and then see, when you're seeing the pulmonary valve, if you just rotate clockwise by 30 or 40 degrees, you can see the valve en face, even on the transthoracic. The other thing is, when you're going for a 4th chamber, if you rotate clockwise, you can open up the pulmonary artery pretty much the same way as you open the aorta. There also you can get a very beautiful imaging of the PR. So just a couple of technical points, that's all.
Thank you.
Can I make a small comment?
Yeah, sure.
So now
please.
we're discussing about severe PR, and we had a couple of things on severe TR. So we commonly see that the RV function assessment is done by TAPSE and RVS prime, even in these cases. So there has been a recent lot of changes which are occurring, and one of the guys who has done is Luigi Badano and Denise Meraru. They are suggesting that whenever you have severe PR and severe TR, don't mention TAPSE or RVS prime, because they may not be the marker of giving an understanding of RV function, because these are all load dependent structure. Yeah. Because we routinely see these things being validated and shown that the RV function by TAPSE is normal, but they may not hold true. That's a comment.
Right. Thank you so much, Dr. Sime. In the interest of time, we'll just continue and go ahead with the next talk, please. So the next talk is on, does mean diastolic gradient in mitral stenosis have some value in assessing the severity of in 2025, or should it be discarded? And can I invite our next speaker, Dr. S. Please forgive me if I'm pronouncing this wrong. Shanmuga Sundaram, please. Thank you.
Meanwhile, I'll request Dr. Saurav Suman, if he's here, please attach your laptop on the right podium. Dr. Saurav Suman.
Good morning. Dr. Parashar doesn't like me. That is the reason for getting a controversial talk for my presentation.
Does not like anybody, man. Don't worry about
it. When mitral stenosis assessment requires assessment of morphology, dysfunction, both stenosis as well as regurgitation, and most importantly, the severity of obstruction. Early 80s, we had a 2D echo machine, which did not even permit us to get an automated area measurement. I used to take a transparent paper, put it on the scope, draw the circle, use a real planimeter and measure the mitral valve area. Then, I thought instead of just believing only the anatomy, why not we use the functional parameters to assess the severity? Then came in the Doppler. Studies have indicated that Doppler gradient, mean gradient, and the invasively measured gradient matched quite nicely. But the problem was the pressure gradient is influenced very much by the flow as well as by the heart rate. If you look at the left side of the slide, for a valve area of 1.5 centimeter square, a flow rate of 200 ml gives a mitral valve area of 1 centimeter square, and pressure gradient of 12 millimeter of mercury, and with the same valve area, mitral flow of 250, the pressure gradient went up to 20 millimeter of mercury. Then we thought the pressure half time would be a better method of assessing the severity. Whatever we did in the invasive lab, got transferred to the echo lab. Simple method, 220 by pressure half time gives you the mitral valve area. Very simple to perform. Measurement variability is quite less. But unfortunately, many other factors, particularly the compliance of the left atrium and the compliance of the left ventricle, seem to influence the pressure half time very much. So that in many coexisting conditions like left ventricular hypertrophy, LV dysfunction, aortic regurgitation, atrial septal defect, pregnancy, all these conditions, believing this puts us into the trouble. This is an example where the mitral valve area by 2DE was 1.2 centimeter. By pressure half time, it was 1.9 centimeter. This discrepancy we get to see everyday practice. Then after balloon valvotomy, all of us know that pressure half time method of estimating the mitral valve area is quite unreliable. At least in the next few days, you may not depend on this. What are the alternatives? You can do a pizza, but time consuming. Most of us don't do that. And we have to use some angle correction because the mitral valve area is something like a funnel. Then continuity equation, simple concept, but the problems are multiple measurements. So an error in one or two measurements will result in altered mitral valve area assessment. So we went ahead, went full circle and came back to say that mitral valve area by 2DE or 3DE is the best way to assess the severity of mitral stenosis. It is true, if you get a good picture like this, undistorted mitral orifice, easy to measure, this is the gold standard. Particularly when you have a 3D echo, all the more reliable to assess the severity. But in real life practice, we get to see quite often mitral valves like this, densely calcified, and the short axis view, the orifice is so distorted that you can't rely on 2D estimation of mitral orifice. Here comes the value of measuring the mitral gradient. Look at the mean gradient, it is 29 millimeter of mercury. Another example where the distorted mitral orifice doesn't permit you to do calculation of mitral area in short axis. Moreover, if you look at the slope of mitral gradient, it is a non-linear slope, so you can't use pressure half time effectively. So here also comes the value of estimating the mean gradient across mitral valve to assess the severity. Few examples of congenital mitral stenosis which we have already seen. In short axis view, however hard I tried, I couldn't get a oval or circular orifice. It was so distorted. And not only that, in congenital mitral stenosis, the obstruction may not be at one level. It may be at the valve orifice. It may be at the subcaudal level as well. Another example of congenital mitral stenosis, look at the mitral orifice. It looks as if it is mild mitral stenosis, but look at the gradient. The gradient is so much and the pulmonary hypertension so severe. So the obstruction is not at the valve level. It is probably at the subvalvular level in a parachute mitral valve. And if you have a configuration of the continuous wave Doppler across the mitral orifice, I'm sure you can't use pressure half time method here with the configuration of Doppler gradient like this. Post mitral valvotomy, when the commissures are split, again you have a problem of measuring the mitral orifice area. Whenever we have discrepancies between the symptoms and the severity of mitral stenosis, we are supposed to go for a stress echocardiogram. What is measured in stress echo is not the valve area, not the pressure half time, but it is the gradient. If with physical exercise, if the gradient goes beyond 15 millimeter of mercury, or if it's a dovitamin stress echo, if it goes beyond 18 millimeter of mercury, you are sure that you are dealing with severe mitral stenosis. Then comes the next common cause of mitral stenosis, degenerative mitral stenosis. In contrast to rheumatic mitral stenosis, where the valve is something like a funnel, in calcific mitral stenosis, it is more like a tunnel. And obviously, you may not be able to measure the orifice in calcific mitral stenosis. There are only two methods. One is the Doppler index, LV/VTI divided by mitral valve PTI, or use the continuity equation to assess the severity of mitral stenosis. So here also comes, if you get a calcific mitral stenosis like this severe with regurgitation, the measurement of gradient is the best way to assess the severity. This study looked at the natural history of calcific mitral stenosis. One of the parameters which helped us in choosing people who are at high risk of progression of disease was the transmitral gradient of more than 8 millimeter of mercury. This is another frequent problem for us, combined mitral stenosis and regurgitation. You know very well, whenever there is a combined valve lesion, methods like continuity equation, methods like pressure half time are quite unreliable. And on the same note, measuring the gradient also is likely to be exaggerated because of volume overload of the left atrium, increasing the pressure gradient across the mitral valve in diastole. But if you look at the fact from the patient side, what is important is the left atrial pressure. The left atrial pressure is obtained by the transmitral gradient. So in a combined valve disease, it is the transmitral gradient that determines the outlook of the patient, determines the patient's symptomatology. So when you have a transmitral gradient of more than 15 millimeter mean gradient, it tells you that what we are dealing with, the so-called moderate MS and moderate MR, functionally it is a severe mitral stenosis. One need to consider intervening with the issue. Here is an example of mild mitral stenosis, valve area of 3.5, but look at the mean gradient, it is 6 millimeter of mercury. If you look at the different methods of assessing the severity of mitral stenosis, each one has flaws, each one has difficulties, but the gradient estimation is relatively simple and straightforward. When the valve is distorted, most often due to calcification, we have to depend upon the gradient. When the valve obstruction is at different levels, or at least not at the orifice, again gradient estimation comes handy. If only you recognize clinically that it is a flow-dependent parameter, if you have clinical situation that tells you it's a high flow state or low flow state, accordingly you can modify your approach. As none of these individual parameters is foolproof, multi-parametric approach is definitely required, and we cannot dispense away the calculation of mitral gradient in this multi-parametric approach. The last slide. This is a study which looked at the discrepancy that happened between mitral valve area and the pressure gradient. Korean study, retrospective study of nearly 2,600 patients. If you use the mean gradient of more than 10 millimeter of mercury, nearly 76% of the people were graded as moderate mitral stenosis. And if you lower the gradient or the cutoff to 5 millimeter of mercury, nearly 26% of people with moderate MS became severe mitral stenosis. Something like what happened between the gradient and the valve area in aortic stenosis. Such discrepancies also do occur in mitral stenosis between the gradient and the valve area. But realizing the pitfalls, we need to work further to identify which is the best cutoff to use to define the severity of mitral stenosis. Thank you.
Yeah, thank you, sir. It was indeed a very good presentation, and there is always something to learn in mitral stenosis. However, it may have been a very old lesion and something, but always there is more to learn in it. If there are no questions.
Good morning, sir. That was a really good presentation. My question is that with in the recent guidelines, the cutoff for mitral stenosis, the mitral valve area cutoff has been changed. Now it is 1.5.
Yes.
So less than 1.5, the mitral stenosis is considered to be severe. But in our day-to-day echo practice, we have seen and in the guidelines, they have not changed the cutoff for mean gradient. So in our day-to-day echo practice, in most of the patients, if the mitral valve area is somewhere between 1.3, 1.4, we usually do not get mean gradient of more than 10. So does it mean that with this newer cutoff of mitral valve area defining the severity of mitral stenosis, now the mean gradient has less of value? Because I don't remember getting mean gradient, unless patient is tachycardic or has got mitral regurgitation. In pure mitral stenosis, mitral valve area of 1.4, I don't remember getting gradient of mean gradient getting more than 10. So does it mean that it has less value in the light of newer guidelines? What is your opinion on that?
That was the discrepancy which was addressed in the last slide, like the Korean presentation. They realized that the valve area of 1.5 centimeter square or less than that to call it a severe mitral stenosis. There seems to be some discrepancy between the gradient and the valve area for using it as severity assessment. But I think most of us have moved towards what AHA has already told us, like using 1.5 centimeter square as the cutoff to call it as severe mitral stenosis. Because if you look at the indications for balloon mitral valvulotomy, people with symptoms 1.5 centimeter square or lesser than that is an indication. But I would definitely accept that 1.5 centimeter is severe mitral stenosis. But the discrepancies do occur, like between the anatomy and the physiology.
Yeah, thank you, sir. I think so. We'll move on to the next.
Just a sec. Dr. Roxy Senior has something to offer.
Sir, 1 minute. Yeah, I think this is a very interesting topic because it has become a contemporary topic actually. Mitral valve area of 1.5 and the mean gradient. But what is clearly shown physiologically is that if the mitral valve area is less than 5, then the mean gradient varies between 6 to 10. So if you have a mean gradient of more than 6, right, and it's a younger patient, and the compliances of the ventricle and the left atrium are not so much affected, then it corresponds to mitral valve area of less than 1.5. So if you get that gradient, then the chances are very high that it corresponds to mitral valve area of less than 1.5. And not more than 10. And that's why the discrepancy in the Korean data, where they took 10 as the cutoff for severe and 1.5 for the cutoff of a severe mitral stenosis based on anatomic area. But if you really try to marry this up, between 6 to 10 is severe mitral stenosis, and corresponding to mitral valve area of less than 1. That's number one. And number two is the mitral annular calcification. You know, this concept of 8 millimeter, 10 millimeter doesn't hold true for mitral annular calcification, because the gradient in mitral annular calcification is predominantly due to compliance issues of the left atrium. And that's why when you see the gradient, you will see the early gradient is very high, like 20, and then it comes down very sharply. So obviously there is no real obstruction that is occurring. It's just the starting point is very high. The problem is the left atrial compliance. And that's why in mitral annular calcification, if you operate on that patient, most of the time the patient doesn't feel that good, because you're not actually, you're not actually changing the gradient very much at the end of the day, because it's the left atrial compliance which is causing the left atrial gradient. And also, of course, with mitral annular calcification, the other comorbidities which don't get affected, I mean, they don't improve if you just do the mitral valve. So there are two reasons. And that's why, in our hospital, when we see a mitral annular calcification, even if the gradient is more than 10, 12, and they're mainly elderly patients, more than 80, we know that even if you operate, number one, the operation is very difficult. Number two, even if you're successful, the patient still comes back very breathless and uncomfortable.
Yeah. But the LA complaint seems to affect the peak gradient rather than the mean gradient. Am I right?
Yeah. Yeah, the mean gradient also goes up. But the slope, you will see, comes down very sharply.
Okay. Thank you.
Yeah, thank you, sir. May I request Dr. Omer? We have non-specific autoarthritis with AR. What's the cause? Dr.
We have Dr. Sumans Saurav over here also.
Good morning, everyone. Today I'll be talking about a rare association of AR. This is the case history. A 32-year-old male resident of Bihar with a known case of hypertension for past 6 months. He had on and off multiple increased BP recordings. However, he was not taking any treatment. He presented to us with dyspnea on exertion class 3 for last 1 month, which has worsened to class 4 for last 3 days. And he was also complaining of chest pain for last 3 days. On examination, pulse was 120 beats per minute, regular, and the blood pressure was 84 by 36 millimeters of mercury. Saturation was around 92 on room air, respiratory rate was 30, and JP was raised. On CVS examination, S1, S2 were present, and only we can find early diastolic murmur in the left third intercostal space, and bilateral creps were there. So basically, he presented in acute decompensated heart failure. The patient was dyspneic and he was not able to lie down, and the preliminary transthoracic echo showed AR. However, we were not able to do a complete evaluation. So after stabilizing the patient was put on mechanical ventilation, and we did the transesophageal echo. In this we can see that there is fluttering movement of the mitral valve with dilatation of the non-coronary cusp, and there seems to be defective movement in the leaflet of the aortic valve also. Here also the same finding is there, that we can see that there is a dilatation of the non-coronary cusp. However, if we look closely, we can see that there is a rent in the non-coronary cusp. However, we don't know what is the cause of this. On color Doppler examination of the same view, we can see that there is a severe eccentric AR jet, and there is a color flow jet from the non-coronary cusp which is going into the LV. And in this view, we can see that the aortic ascending aortic dimensions were normal. So there was no ascending aortic dilatation, only the cusp was dilated, and there was a flow from the non-coronary cusp which was going into the LV. This is a short axis view at the level of aorta. In this we can see that the right coronary cusp and the left coronary cusp are fine, but there seems to be a rupture in the non-coronary cusp of the aortic valve.
The short axis you were showing. Short axis across aortic valve. You said non-coronary cusp. Yes, this one. This. Go to the short axis. Go to the short axis. Yeah, play this with the color. Play this. Go back and come back, and you'll get it. Play. Go back on slide. Come back. Play.
So this is the right atrial septum. This is the interatrial septum. So this is the right coronary cusp, and this is the left coronary cusp, and this is the non-coronary cusp which is showing the red.
Where is the non-coronary cusp?
So this one. So this is the right coronary cusp. This is the left coronary cusp.
No. That's the non-coronary cusp. Non-coronary cusp is absolutely normal. Doesn't matter. It doesn't matter. Semantics is something which we are not discussing. We are discussing the etiology. In anything connected with the interatrial septum is the non-coronary cusp.
Okay.
Go ahead.
So this is the same view in which we have confirmed that there was a severe eccentric AR, and there was a jet coming from the non-coronary cusp into the LV.
Go back again. There is some very play.
It's not playing.
Go ahead. Play this. Yeah. So which is the non-coronary cusp?
So this one is the non-coronary cusp, and this one is the right coronary cusp.
Nah.
In the plaques.
This is not plaques. This is transesophageal echo.
Yes.
In
this is the aortic long axis view at the level of aorta in the mid esophagus.
Actually, your angle is like that this is neither a perfect short axis, this is neither a perfect long axis view. It is basically something in between, and that's why you are getting the shape of the non-coronary cusp like this. Look at the angle of the probe where you have steered it. That's the issue.
So actually, this is right coronary cusp.
Okay. So in this we can see that there is a fluttering movement of the mitral valve with mild LV dysfunction and concentric LVH. And there was mild MR likely due to the AR jet which was impinging on the mitral leaflet. So by this time we were sure that there was an aneurysmal sinus of Valsalva, likely RSOV with rupture from right coronary, could be right coronary or non-coronary cusp to the LV with a normal ascending aortic dimension with severe eccentric AR with a tri-leaflet aortic valve. There was mild MR, mild concentric LVH with mild LV dysfunction, and there was no associated VSD, and there was no vegetation or clot. However, for further management of this patient, we did a CT angiography, and this is the 3D reconstruction, which showed that there is narrowing at the origin of the left subclavian artery. And this is the section which is showing the same finding, that we can see that there is narrowing of the left subclavian artery, As well as in this sagittal section, we can see that the caliber of the aorta in DTA is lesser in comparison to the other parts of the aorta. So there was basically narrowing of the subclavian artery and the aorta. And this was the 3D reconstruction image, which is showing the aortic root. And this is the right coronary cusp, left coronary cusp. And there we can see that there is a connection between the non-coronary cusp, which is going into the LV, which was confirmed on the CT in the same view. So we diagnosed the patient as a case of non-specific aortoarteritis with ruptured sinus of Valsalva aneurysm with severe eccentric AR, mild to moderate MR, presented with NYHA class 4 with mild LV dysfunction and normal sinusitism, and there was no signs of infective endocarditis. So what was this peculiarity about this case? That usually the non-specific aortoarteritis patient have AR, but these are usually due to the aortic root dilatation or due to the involvement of the aortic valve per se. But so the prevalence is around of SOV aneurysm is 0.09% in the general population. Causes can be congenital or acquired. When it is acquired, it is usually infectious causes like infective endocarditis, syphilis, tuberculosis. But it can be rarely caused by the autoimmune diseases like Behçet's and Takayasu arthritis. So in this we can see that the involvement of the aortic root per se is in around 36% of the patient, but aneurysmal dilation of aorta is much less common, and this was basically a type 2A non-specific aortoarteritis. And by far there have been only few case reports of ruptured sinus of Valsalva aneurysm caused by in patients of Takayasu arthritis. The most common complication of the SV, sinus of Valsalva aneurysm, is usually the rupture into the RA or RV. However, the rupture in LA and LV are rare. And that too in a patient of Takayasu with RSOV rupturing into the LV is a rare association. So this patient was basically taken up for surgery for RSOV closure and aortic valve repair plus minus replacements. Thank you.
Thank you, Suman. Now, since we are short of time, so I'll be inviting the next speaker. He is Dr. A.K. Umar. He is Director of Non-Invasive Cardiology in Fortis Scots. And he will be talking about something which lies at the frontiers of the modern cardiology, that is interventions in structural heart disease, where the changes are happening on two fronts, one in the device designs and another is where to use it. And with very rapid evolution of literature, Sir will be updating us that where do we stand as of today in 2025. Dr. Umar.
Thank you for kind introduction. Thanks, Dr. Prasad and organizing team to give me this topic. So, we all know that the TAVI is becoming very prominent as far as the severe aortic stenosis is concerned. It was started in 2002. Alan Crevier, you can see the first patient was done in France. And this was the balloon expandable valve. Soon after that, we had in 2004, with the help of Dr. Jack Sequin, Dr. Seth did it, a self-expandable valve in 2004. If we look into the world incidence of the tower, you can see in Western countries, it is almost like 100 to 150 per million population. But in India, we are just like 1 in 1 million population. But so we are catching very fast. If you look into just go with we started with the extremely inoperable patient. And the results were quite promising. And here is the balloon expandable and at the same time is the self-expandable with the partner 1B and core valve ER trials. Then came the high-risk patients where the partner 1 trial, 1A trial and core valve HR trial were there. Results were TAVI was non-inferior to surgical AVR in terms of all-cause mortality, 30 days, 1 year, as well as the 5 years. Similar was with the core valve trial also. Then came the further trials with the intermediate risk patients, where the partner 2 and SAR-TAVI. Here also results were very favorable, and the all-cause mortality and this happening stroke was quite comparable with the SAVR, rather better than SAVR. You can look here all the trials with the reducing SAS score, and also the mortality was also decreasing. So it was from the high risk patient, surgical risk patient, came to the intermediate risk patients. Now what is interesting now, it has come to the low risk patient, less than 4% of the SAS. Here the 4 major trials had been there, that is Notion, Partner 3, and the Evolute-R, and Dedicated in the German trial. So all these trials have shown the superiority of the tower in the even in the low risk patient group. So what has changed? Why the results are getting better and better with the tower? Is the seat size for the delivery system has from 24 to 12 to 14 French. Sealing technologies such as the outer skirter of the pericardial wrap contributed to reduce the rate of parallel leak, the frame height, and also like the position of the valve, particularly intra-annular or supra-annular, that has all these things have been changed. If you look into the route of the TAVI implantation, the multiple routes we all know about that. But now, if we say that over 90% of the cases are done by the transfemoral route. Why? Now you come to see the seat size I have already mentioned, from 24 to 14. These are the dilated, self-dilated seats, where these are the hydrophilic seats which self-dilate after putting the femoral artery. Then the vascular complications had been many, like pseudoaneurysm, hematoma, dissection, perforation, all that has reduced because of the ProGlide device and multiple devices like that, and there had been vascular plugs also. Intravascular like the femoral arteries are very calcific, small, so their devices like we know the IVL is frequently used, which dilates the artery before putting the valve inside. You can see this one of the patients where IVL was used, and after the dilating the femoral artery and decalcifying it, and then we put the valve. The cerebral protection device here, if you look into literature, 0.5 to 0.5 and 0.6% cases have a CVA. The risk factors, multiple risk factors are there. I won't go into detail about that. The devices are like Sentinel. Sentinel has been used here also. Very commonly used in these patients. And there are other devices. But Sentinel, you should know only the internal carotid is protected. The vertebrals are not being protected here. So there is one of our patients with a lot of calcium in the valve, and we utilize the Sentinel device. You can see the Sentinel device was put here in the covering both the carotids, and finally the valve was implanted and the device was removed. So various other things about that, the conduction abnormalities, like it has reduced from the around 5 to 10%. The further procedural thing like reducing the depth of implantation and use of the cuspal overlap techniques reduce the conduction abnormality and the pacemaker rates. Parallel leak has been quite a major thing, like 12%. Now it has reduced to 2%. And in minimal parallel leak, we are not concerned, but the more than moderate to severe leaks are very uncommon these days. Post-TAVI imaging, we know that particularly transthoracic imaging, 30 days, 1 year, and yearly thereafter follow-up is there with the transthoracic echo. What are the valve changes? Valve, now if you look into the balloon expandable valves, earlier we know that the Sapien or Sapien XT was there, and now the Sapien 3 and Sapien 3 Ultra, where there is outer skirt is there, so parallel leak is reduced. Self-expanding valves, there are many changes in the core valve, evolutar, and these are there. But recently introduced the valve like Portico. It is self-expanding valve, fully reseatable and retrievable valve with the leaflet geometry designed to function in both round and elliptical. This is an intra-annular valve. Then the navigator valve has a key innovator in the active outer fabric cuff that is also being used. Now, this had been a development of the mechanical expandable, but these are currently recalled due to issues with the product delivery system. And what is the valves in active fixation mechanism? Like what is important in the aortic regurgitation, Jena valve has a paper clip-like fixation mechanism. Is currently the only tower valve has a CE mark. Then we all know that structural valve failure is around 4.9% per year. What happens if it happens? Then we have a option for explantation of the valve and surgical replacement, or we can have a tower in tower. Incidence of coronary artery disease is very common with the aortic stenosis, and here we can have a pre-assessment with either the calcium scoring or the CT angiography before going for the tower. Of course, both the procedures can be done simultaneously and with the very good results. But the post-op complication of the bleeding is much higher if we do both the procedures simultaneously. Post-TAVI coronary intervention, it's a difficult with the self-expandable valve because the size of the valve and then particularly a lot of modification has been done with the self-expanding valve, where the cell size has increased and the cup, the valve is intra-annular valves are being introduced in self-expanding also. So these things have modified. And as for the balloon expandable valve, usually there is no problem with the coronary. And there is a lot of reports are there. It is not a real problem having the post-tower coronary intervention. AR is like 10% of the cases of the AR is being done with the tower. But what are the complications? Complications are the migration of the prostatic valve in 20% cases and the parallel leak. There are possibility of annular rupture. This has been combated with the oversizing 10 to 20% to reduce the parallel leak. Here I have already told the Jena valve has been used. In bicuspid valve, the bicuspid valve, now it's approved, FDA approved, and there are a lot of controversial data. But recent report by Dr. Makkar has told that it's almost equivalent results in the very big series. Now you can see that it's growing in the bicuspid position. Then the valve-in-valve transcatheter, valve-in-valve, as well as if you compare the tower simple or valve-in-valve, tower valve-in-valve, they both has a very comparable results. Moderate AS is not a very, I'll just take a minute. This is the couple of studies are going on, but not much of the results are there. So I'll leave it here. Looking into the TAVI is passing the surgical aortic valve, all kind of, either it's a surgical only plain or with association. But the TAVI, you can see the mounting. This is of 2019, and now the data is even much better.
So we need to wind up. We are getting late with the next session, please.
I'm coming to the final slide, leaving some data. See, the TAVI is evolved tremendously, and there are a lot of things like new technological innovation, cerebral protection devices, novel occluders, parallel skirting, all that has improved the results of the tower. Thank you very much.
Thank you, speakers and the chairpersons. We need to conclude this session, please. Thank you all for the wonderful session. And dear audience, I'll just hold you back for a small formal ceremony from the coffee break. We are certainly going to give you some time for the coffee. And let me welcome all those who have joined us late. On behalf of the organizing committee, I'm sure you all must be enjoying the academic feast. So we move on for a small inaugural ceremony of the academy. And let me just share today that the conference is being held on a very auspicious day of Basant Panchami. And I pray and hope that Goddess Sharda bless us all with wisdom and knowledge today and always. Let us all stand up for a brief while for Sharda Saraswati Vandana. Thank you all.
Ya kundendu tusharhara dhavana Ya shubhravastravruta Ya veena varadanda manditakara Ya shveta padmasana या ब्रह्माच्युत शङ्कर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा
Thank you all. Please be seated. So we proceed for the formal program. And now let me take the privilege to invite a legendary figure in the field of echocardiography, who is also the founder of the Academy of Echocardiography, Dr. S.K. Parashar Sir. And we all know Parashar Sir has been relentlessly working for the Academy and has set the legacy of continuous learning in echocardiography across India. Let's all give him a warm round of applause as he gets up on the stage. Sir, a few kind words.
Short also, sir.
Well, we are not the founder. We are the longest serving servants of the Indian Academy of Echo. That's all, no founder also. And the main aim of this meeting was that the Academy is very actively involved in various academic affairs. So this time there was a gap of about 16 to 18 months between the two conferences, as a result of which we thought of having a midterm conference so that our academic things doesn't suffer also. So that was the reason for this meeting. And also for one day meeting, Roxy, my old friend, has still come here because he is a very active part of all activities of the Indian Academy Echo. So thank you, Roxy, and all others who have come here, and thank you very much. This is the occasion to meet everybody. Thank you.
Thank you, sir. Thanks for your kind words. Now I call upon the stage our esteemed President of Academy, Dr. Mani Vasagam, to please give your welcome note.
Good afternoon, everyone. Respected Colonel Professor Parashar Sir, the National Organizing President, and also Dr. H.K. Chopra, National Organizing President, and Rakesh Gupta, Executive Organizing President, Samir Sivatsa, Organizing Committee Chairman, and members of the Executive Committee, and national, especially Professor Roxy Senior, national faculty, and all over India, the Indian national faculties, and above all, the delegates who are present here. We warmly welcome you to this academic feast. This is carefully chosen in such a way, this is case-related presentation, and you will all, I hope you will all enjoy this. Thank you very much.
Thank you, Dr. Panivasakam. Big round of applause for our president. Now coming on to Dr. Shantanu Sengupta, our young and dynamic president-elect of the Academy.
Thank you, Hansa. So let me welcome you all. I think before I continue, let me congratulate Dr. Rakesh Gupta, Dr. Parashar, the whole team in Delhi who took this effort. Let's have a round of applause for all of them. This has been amazing. So I think I will be taking care of the scientific chair for Echo India 18, 19, 20, 21st of Kochi. And it's going to be again a case based. So I look forward to welcome you all there. And it is going to be a lot of fun. Thank you so much.
Thank you, Dr. Shantanu, for being really brief. I now take the privilege to call upon the stage the backbone of this conference, Dr. Rakesh Gupta, who is very well known to everyone for his marathon contributions to the Academy and yet a very humble persona. Dr. Rakesh.
Thank you. We can have, continuing with Dr. Shantanu Sengupta, we have a stall outside where we can register for online for the next Kochi conference, where for a very minimal sum of 12,000 rupees. So you can scan the barcode and you can register it. As far as conference is concerned, the theme of this midterm conference is a case-based discussion, which you must have seen already, especially for the busy physicians in practice, highlighting the importance of how clinical echocardiography and multimodality imaging can change the complete scenario as far as diagnosis, prognosis, and management is concerned. Wonderful personality like Dr. Roxy Senior and my humble, respectable Professor Indra Saxena amongst all of us is over here along with international and national faculty par excellence. And I'm sure once you leave this hall today evening, you will realize the mighty power of clinical echocardiography and multimodality imaging in clinical practice, ultimately benefiting the human mankind under the influence of ubiquitous God. And last, I'll leave with this word: speak in such a way that others love to listen to you. Speak in such a way that others love to listen to you. Listen in such a way that others love to speak to you. Thank you very much.
Thank you, Dr. Rakesh. A huge round of applause for each one of us. Thank you very much. We conclude this ceremony for now. We disperse for a short coffee break and quickly assemble within next 10 minutes. Five minutes. Okay, this is not possible although, but try as quickly. Yeah, as quickly we can do. You can bring inside your coffee and we'll start with the next session.
And enjoy the kachori also. This lying outside. Wonderful kachori they created over.
I would request the people who are standing outside to please come back and join. So next session is for 1 hour and it has 6 eye-opener cases, very senior faculty. So we are all looking forward to it. I'm looking for the chairpersons also till now. Actually, I don't see. Okay. So I'll request all the chairpersons for this session to please come on the stage and start the proceedings. Dr. Vivek Tandon, Dr. Meera Govindarajan, Sangeeta Porwal, Kshitij Chaudhary, and Arif Mustaqeen. I would request Dr. Amuthan to please head towards the dais. Somebody has to actually, I think, ring the bell outside to call people inside. We are starting the session.
Shall I start, Semi?
I think we can wait for a minute. Okay. So let most of the people come inside.
In that case, don't start the timer for you.
Yeah. We'll take care of that. Yeah. So Hansa is not around, so there would not be any strict marking, you know. Hansa's ears are open. So Dr. Prashar has come inside. So I think we can start. Most of the people will follow him. Hanji, hanji. Okay. I set the stage actually. So yes, sir, we can start. I think people are settling, so we can start. It's 12 o'clock. 10 minutes to go.
Good afternoon, everyone. We are starting with the session of 6 eye-opener cases, and we have fantastic speakers to present these cases. We start off with Dr. Muthan from Madurai. 2 cases of LAVI stress echo. Sir, please.
Good morning. First of all, I am sorry that I am not listening to our father of echocardiography in India's words to remove my or trim my mush. So let us have a talk on LAVI stress echo. Now, this left atrial volume and index can be important factors in stress tests, as they can help predict cardiovascular risk and likelihood of coronary disease. This is just to highlight that we no more follow the protocols of regional wall motion abnormality in stress echo. We do total echo before and at the peak. So the advantages are that normal LAVI, that is less than 28 ml per meter square, can indicate a low risk of coronary events. LICs can help detect myocardial ischemia during stress testing, and it can correlate with abnormal left ventricle contractile reserve. And in patients with hypertrophic cardiomyopathy, it is associated with the increased risk of arrhythmias and major clinical yes. Now, the most important thing is the heart failure with the preserved ejection fraction. It helps a lot. As you can see here in heart failure, PEF score. This is from ESC. The main factors are first step 1 is clinical, step 2 is intensive testing with echocardiography and BNP, and step 3 is diastolic stress test. As you can see, this compares very well with the H2 PEF score, which is more on clinical grounds, and echocardiography comes later. And the sensitivity is higher with H2F PEF score compared to Heart Failure Association PEF score. Now this is the H2F PEF score, and this is comparable to Heart Failure Association PEF score. And you can see here it is based on functional as well as morphological and biomarker criteria, and left atrial dimensions or left atrial volume index of more than 34 is considered as major criteria, and 29 to 34, this is very, very important. Previously we were telling only 34, now it is 29 to 34 is considered as a minor criteria in Heart Failure Association PEF score, and more than 5 points, and you can have a diagnosis of heart failure with preserved ejection fraction. 2 to 4 points, it is diastolic. You have to do the diastolic stress test. Now this LAVI stress test, I will show you 2 cases. This is a case 1, 64 years male, diabetic. He did 7 minutes of exercise in Bruce protocol, and we did the left atrial focused apical 4-chamber view. As you can see here, this is the classical apical 4-chamber plane, whereas this is the LA focused apical 4-chamber plane where the LA is focused. The apex is no more there in the center, and it is all LA. The whole walls, all the 4 walls of the LA are seen here, and we specifically select the apical triplane view so that you get it in a single beat. It is a single beat. So you have to see to that all the walls of left atrium are seen in this view, and this is the basal in this our case. The GLS is 18.5, ejection fraction 57, LA strain is 36%, LAB max is 25. This is the biplane view which you see, and this is the E by E prime is 8.97. This is post exercise. GLS is 18, ejection fraction has increased to 68%, LA strain is 32, and LIV max is 21. You note that the LA size has reduced, and you can see in the territorial strain there is abnormality in the anterior septum and infralateral and anterolateral wall, and his E by E prime is 9.7. And this is the hemodynamic profile. This typical E by E prime normal or increased only with the stress, and this is the LAV. And this patient underwent angiogram. You can see here there is a 90% occlusion in the major OM, major OM. You can see that. And this patient was stented, and he is doing very well now. This is a case where I was shown there is a reduction in the LA size, where the prognosis is good. As such, he had only single vessel disease, that too involving OM. So that is how it goes. This is another case. This is a patient, 62-year-old man, who did only stage 1 bruise. He developed a marked ST depression in the V4, V5, and V6. And this is the basal. You can see GLS is 8.3, EF is 30%. And this is the diastolic, this thing E by A prime is 26 in this case, you can see here. And this is the area under curve. You can see that this is the pressure strain loop, is very important for these patients. And this is the LA strain is 3D LA strain 2%, LAV max 70 ml. Compare that with the biplane images. I always say 3D is superior because of this. And Badano has done Louis Badano has done a big study where he compared the 2D biplane to 3D LA volume size, and always there was a difference of 10 ml, not 1 ml or 2 ml. It is 10 ml. When you do the 3D, and 3D compares very well with the CMR and not the biplane images. And this is the post-stress. You can see here there is an increase in strain abnormality in the anterior wall, anterior septum, and this ejection fraction is 32%, and E by E prime is 25, and this is the biplane. The biplane shows LA strain of 20%, LAV max of 58 ml. And this is the 3D, which shows LA strain of 12%, LAV max of 80 ml. This is a pre-stress, this is the post-stress. You can see the marked increase in the territorial strain, and basal 3D LA strain is 2%, increase to 12%, LAV max 70 ml, increase to 80 ml. And this is the hemodynamic profile for LA dilatation at stress. There is prevalence of reduction, stabilization, dilatation profile of LAVI during stress test is 29%, 41%, and 30%. And dilatation more frequent, near threefold in heart failure with reduced ejection fraction, and in patients with hypertrophic cardiomyopathy than in heart failure with the preserved ejection fraction. LAVI change is distribution the same with bike and treadmill exercise test, and resting predictors of stress LAVI dilatation, that is E by E prime more than 14 and the ejection fraction less than 50%. And the carry home message is LAVI stress, a normal LAVI less than 28 ml per meter square can indicate low risk of coronary events with 2 years. And LI size can detect myocardial ischemia during stress testing. It correlates with abnormal left ventricular contract reserve, and it predicts the arrhythmias in patients with hypertrophic cardiomyopathy. Thank you for your patient hearing.
Thank you, Dr. Murugan sir. That was a brief but brilliant exposition of LA volume index as part of a stress test and how it can be useful. Sir, could you just tell us, is it your practice to do this in every stress test that you do? And how useful is it in exercise stress echo as compared to dobutamine stress echo?
This stress test, I believe in treadmill exercise stress test. It gives you so many other parameters. You have the heart rate, you have the blood pressure, you have the ECG changes, and that is very easy. Just before the onset of the treadmill exercise, you put the transfer, and just at the peak, after the exercise, you do the routine echo. That's all. You grab the images, analyze later. Don't go by protocols which you are following in routine stress echoes. No protocols. Just grab the images and just requires the expertise to do the images from the apex. That is a triplane images. You have to get the triplane images for LV, you have to get the triplane images for LA, before and after, and then you can have the 3D images just before and after, and that is as easy as that, and you get the Doppler, tissue Doppler, and do the calculations later. It is very easy, and it adds so much dimensions to your assessment. It gives you easy response. It is 100 times more cheaper, available, readily available. Yes.
Dr. Amuthan, it was a brilliant presentation. I just want to ask one question. Did you find any correlation of LA pressure with LAVI and LA strain rate in E by E prime ratio, all the 4 parameters?
LA pressure, that is the get the TR. It may be difficult to get the TR, especially in high heart rates. But TR getting is very easy, and you can correlate with the LA pressure.
LA strain?
Pardon, sir?
LA strain.
Yes. LA strain, I have shown you the LA strain. It comes with 3D. When you do 3D, actually it goes with LA strain and LA volume. In biplane view also you can have the simultaneous LA strain and these things. And this is particularly useful when there is a tachycardia where there is a fusion of the E and A. In those cases, LA strain is, you can add that, and then you can compare the LA strain basal and post exercise.
Thank you, sir. So we'll go on to the next speaker.
Thank you, sir.
Yeah, traditionally we associate ANCA with renal disease. Here is Dr. Jesu Kripa from Vellore, who is going to give us an informative talk on the cardiac manifestations thereof. I welcome Dr. Jesu Kripa.
Thank you. Good morning to you all, and I'm honored to be here. Thank you for the opportunity given. So I'll be talking on ANCA-associated cardiac disease. Sorry. It might sound a little obscure, but my idea here is not to present something very exotic or just to baffle everybody. Hopefully, there will be some takeaways from this particular case. Some of you might have heard it because I presented it a while ago in one of the southern meetings. So this is a 46-year-old male, has dry cough for 1.5 years, 3 episodes of redness of the eyes with mild pain for 1.5 years, exertional dyspnea. He could walk only about 0.5 kilometer for 4 months, nasal stuffiness, low-grade fever, erythematous macular rash with some pruritus and spontaneous recovery, fullness, a sensation of both the ears. Apart from that, he's also a hypertensive. His blood investigations, he's mildly anemic. His ESR and CRP are elevated, obviously. Total leukocyte counts are normal, including the eosinophils. Platelets are normal. Liver functions, renal functions, sugars, everything is okay. Urine also is fine. The initial ECG, I've put the dates down because the whole story is in chronological order. What we can see, obviously, is a first-degree AV block. Other markers for SLE, rheumatoid arthritis, which I've enlisted here, scleroderma, Sjogren, they are all negative. Rheumatoid factor, which is non-specific, like ESR-CRP, is elevated. Anti-nuclear cytoplasmic antibody, or ANCA as we call it, earlier called P-ANCA and C-ANCA, which stands for perinuclear and cytoplasmic. That is elevated. Anti-MPO is normal, whereas anti-PR3, which is C-ANCA, is elevated grossly. MPO stands for myeloperoxidase and PR3 stands for proteinase 3. Now, this is the current X-ray, but a year ago, a CT chest was done, which had shown some confluent nodules in the left upper lobe. Those images I don't have, but those have also completely resolved. Now, coming back to our area of interest, which is echocardiography, this is the very first view taken. Nothing very remarkable, as it's not a great image, a little bit of AR. We progressed with the study, that's a 4-chamber, and now this image is certainly better. And what is obvious is a thickened anterior mitral leaflet starting from the base till the tip of the leaflet. Now, this is a little kind of unusual. This is not like the usual kind of mitral valve thickening that we see in many of the common conditions that we know, namely rheumatic heart disease or other such conditions. Again, a peculiar pattern of how this mitral valve is thickened. There's no subvalvular thickening. PML also is fine. It seems to be extending from the base to the tip of the leaflet. And here also, we can see the aortomitral continuity, aortomitral intervalvular fibrosa region quite thickened, whereas the anterior part of the aortic valve or the aortic annulus is not really thickened. So you can notice this marked thickening. So with this information and first degree AV block, the patient goes a few days later for a PET CT. And these are the images. You can note this is the, this is the aortic arch, as you can see. And that is shows uptake. That is the ascending aorta there. This is the descending aorta. Descending doesn't have any uptake. Ascending aorta has an uptake, as we would have imagined from that parasternal long axis and other views. And you can see how that uptake extends into the mitral valve also. So that all that thickening that we saw is all inflammatory activity happening. Notice also the descending thoracic aorta, which has now gone into the abdominal aorta. There's nothing much there. I haven't yet scrolled through. I go down further. And then there is activity further down in the abdominal aorta close to the renals. Also, you can notice inflammatory activity in the maxillary sinuses in this particular patient. The patient didn't present with this, but now has syncope in the ward and requiring a pacemaker, and the patient has complete heart block. Now, we have a young patient with heart block and these kind of inflammatory findings, aortomitral involving the large vessels also, that is the aorta. So now this is the classification for any. So aorta is inflamed, so it's a vasculitis. That would be a large vessel vasculitis. Large vessel vasculitis that we commonly know of would be Takayasu arthritis. In our context, that is the commonest. But then this is the Chapel Hill classification. And when we look at it, we have medium vessel vasculitis like the polyarthritis nodosa, Kawasaki disease, and the small vessel vasculitis. And typically, ANCA-associated vasculitis is a small vessel vasculitis. And you have three main conditions: MPA, that is microscopic polyangiitis; GPA, that is Wegener's, what used to be called as Wegener's; and EGPA, that is eosinophilic granulomatosis with polyangiitis, what used to be called as Church-Strauss. Then, of course, you have immune complex, HSP being the most common one or the most well-known among them, which involves the kidneys also. So that is like a broad classification when we are thinking about vasculitis. So what does this patient have? So this patient certainly has a GPA, that is a granulomatosis polyangiitis with arthritis. And that is based on the 2017 criteria. The ACR EULAR criteria is what is used for many rheumatological conditions. I'm not going to go into the depths of it. Suffices to say that just an elevation of ANCA itself puts this patient, it's very specific. So the fact that the patient has C-ANCA or ANCA itself makes it vagus granulomatosis or granulomatosis with polyangiitis. Apart from that, of course, there was hearing loss, there was painful eyes, there was a nodule in the chest, and many other things which prove it beyond doubt that the patient has vagus granulomatosis. And this is just to show what are the different ANCAs that are elevated. I already kind of alluded to this initially. What was the patient treated with? I'm not going into the details, but there are treatment algorithms like this available. Our patient got steroids followed by rituximab. Story doesn't end. The patient had a vertebral artery aneurysm and a bleed, altered sensorium and all, which was coiled. And this is the interesting part. By now, the patient has a pacemaker, you can see. But what is interesting is all that thickening has gone off with the immunosuppression. All that inflammatory stuff seems to be resolving. Even this iotomitral thickening, which was very obvious initially, after a few months has almost nearly normalized. The ECG also, the PR interval is normal. The patient is in sinus rhythm. Inflammatory markers are all down. But the story doesn't end, and that's not the main point of my presentation also. This is a Mayo Clinic series, which is the largest large vessel ANCA-associated vasculitis published in 2023 in about 36 patients that they saw. And this was the patient characteristics. What they found was when it came to GPA, that is vagus, they could either have aortitis, which was in the ascending aorta or the aortic arch, periaortitis, which was mainly in the abdominal aorta, temporal artery vasculitis. These were all mutually exclusive subgroups of large vessel vasculitis or large vessel involvement in vagus. There was, in that document, what they had mentioned was of the patients that they saw, there was no overlap between these groups of patients.
Dr. Jesu, I would suggest if you could wrap up. I'm sorry to interrupt.
Yes. So just the last couple of slides, that's it. So there was no overlap. Whereas in our patient, we found that the ascending aorta was involved, the abdominal aorta was involved, and that was probably a little special. And this I already showed you. And what we can see here is that the thickening of the aorta, that is the ascending aorta that we can see, and the aortic arch, and then going down, all the way down, there is thickening of the abdominal aorta also. So
can we have the last slide, please?
Yes.
We're almost 20 minutes down the line.
Yes.
Just last slide.
This is the last slide. So, anti-PR3 or C-ANCA is specific for vagus granulomatosis. Vagus granulomatosis or GPA can be a large vessel vasculitis. Now, it's classified as a small vessel vasculitis, and the central fibrous body involving the iotomitral continuity region can be involved, giving rise to heart blocks. Apologies for exceeding my time.
Thank you, Dr. Jesu Kripa. I think that was a really informative talk, and most of us are not really familiar with this. Just a couple of questions, comments rather.
I'm sorry. Let's move on to
just a comment.
No, please, let's move on. No comments, no questions. We have a tea, coffee, and a lunch available outside. Can we have a next presentation from Dr. Shanmuga Sundaram? I'm sorry, I'm going beyond the limits of chairpersons. Please pardon me for that. I have an option to interrupt me also if I go beyond my time.
This is about an elderly female patient of mine who presented with cardiogenic shock, and it was managed in an unconventional way. Cardiogenic shock is a life-threatening condition. Commonest causes being acute myocardial infarction and acute worsening of heart failure, though there are other causes like myocarditis, peripartum cardiomyopathy, etc. 77-year-old female, hypertensive and hypothyroid, came in the evening to ER with a typical chest pain, sweating, and dyspnea. There was no history of undue mental or physical stress. She was found to be dyspneic but free of chest pain by the time she reached ER. Respiratory rate 28, SpO2 was 57 room air. Cardiac examination was normal. There were crepitations on either side. ECG revealed ST elevation and T inversion in inferior and anterior leads, and high sensitivity troponin I was more than 1000. Point of care echo was done by ER physician. She said, the apical segments hypokinetic, and IVC was dilated, and B lines were present on either side. This was the electrocardiogram. She was started on BiPAP with oxygen. Furosemide was given intravenously. She was given loading doses, and early angiography was advised. But the relatives were hesitant. They said, her eldest son has to arrive only the next morning. Routine biochemical investigations, hemogram were normal. By early morning, she started having low blood pressure with cold extremities. Noradrenaline infusion was started by the CCU consultant. When I saw her in the morning, an apical systolic murmur was very obvious. Angiography was done through right radial artery, which revealed non-flow limiting lesions in LAD and RCA. LV angiography was very typical of apical ballooning, apical variety of Takotsubo cardiomyopathy. And you could also see grade 3 mitral regurgitation. Echo was repeated after the angiography. Typical features, but what is striking is the systolic anterior motion of mitral valve causing LV outflow obstruction and moderate degree of mitral regurgitation. SAM was evident even in remote echocardiography. The Doppler gradient was typical of dynamic LVOT obstruction. P gradient was just 40 millimeter of mercury. Noradrenaline infusion was stopped, and she was started on oral bisoprolol, 1.25 milligram twice a day, and increased to 2.5 milligram twice a day in the next 48 hours. In order to allow the beta blocker to be tolerated by the patient, it's an off-label indication, but we did that. Midodrine 2.5 milligram twice a day was also given along with that. She could tolerate beta blocker with a blood pressure of 90 to 100 systolic. Heart failure improved, and she was discharged on day 5 with statin, beta blockers, and ramipril. This is the echocardiogram done on day 3. LV outflow gradient came down, but still you have this apical akinesia, hyperkinetic basal parts of the left ventricle with some degree of mitral regurgitation. Outflow gradient came down from 40 to 20 millimeter of mercury on day 3. And this is at the time of review 10 days later. And, the LV wall motion has become normalized. No SAM, no outflow gradient, mild MR was obvious. Takotsubo cardiomyopathy is a reversible LV dysfunction, often caused by emotional or physical stress, typically occurring in postmenopausal women. Present as acute coronary syndrome, actually 2 to 3% of all ACS caused by this cardiomyopathy. Troponin elevation is disproportionately mild, in contrast to our patient who had gross elevation of troponin. Wall motion abnormalities in non-coronary distribution. CMR may reveal edema of the myocardium, but less of fibrosis. Dynamic LV outflow obstruction has different causes, commonest being hypertrophic cardiomyopathy. Takotsubo cardiomyopathy is responsible for around 1% of all cases of dynamic LVOT obstruction. When you have a septal bulge of elderly, and when you have hyperkinetic basal contraction, the LV outflow is narrowed. Not only that, hypercontractile basal posterior wall pushes the mitral apparatus anteriorly, setting the stage for significant dynamic LV outflow obstruction. Increased afterload results in further apical ballooning, further worsening of LV dysfunction, and this sets a vicious cycle leading to cardiogenic shock. Mitral regurgitation also contributes to hypotension. Management, someone with hypotension and cardiogenic shock, if there is LV outflow obstruction, IV fluids, if not in heart failure, beta blocker, IV esmolol can be given, followed by oral metoprolol and bisoprolol. Mechanical circulatory support if it is required. it should be either Impella or ECMO, because high BP is likely to worsen LV outflow obstruction. If there is no outflow obstruction, non-adrenergic inotropes like levosimendan can be done, and any one of the mechanical circulatory support can be used. If there is no cardiogenic shock, routine management of stress cardiomyopathy is using beta blockers, ACA, MRA, diuretics if congested, and statin and antiplatelets if there is associated CAD or ASVAD risk factors. Thank you.
Thank you, sir. That was a very interesting case, well managed. You stuck to your time, sir. So I think we can have one question or comment from someone. No? Okay, then.
What is it?
Blood level of epinephrine.
I didn't do that.
What was it? Not known.
I didn't do that.
Blood level of epinephrine.
Blood level of epinephrine. He's asking, but I didn't do that. I didn't do that.
Usually in the ICU setup, whenever there is hypotension, whenever we tend to infuse inotropes.
Yeah.
It is a dictum we should see the IVC in those patients with hypotension, because in those situations, simply hypotension due to dehydration in the presence of inotropic support, it will produce LVOT obstruction and gradient like that, as you said. This is we have to see the IVC also routinely in these circumstances.
So now I invite Dr. Rakesh Gupta to give his talk on unique case of a stroke.
Well, good afternoon, everybody. Very simple 38-year-old male presented with giddiness with a history of not able to pick things from a hand properly. This picture appears to be an incoordination. Nothing significant. He was diabetic. He was hypertensive. And on top of that, investigations were more or less normal. ECG was normal, CT scan head was normal, and that's what exactly we always order to ask for a MRI head, which showed evidence of cerebellar infarct, and patient was referred to us for getting an echo done. We did an echo. This is what the plaques view is, did not show any significant abnormality. Short axis view did the same thing, nothing significant. This is what we were trying to look for LVOT. We couldn't find anything in LVOT or aortic valve. We went on to do a transesophageal echo to look for a cause of this cerebellar infarct, any source which we could detect. 114 views, aorta and a mitral valve, nothing significant. We focused a lot of things on LA appendage or interatrial septum. We did to do a LA appendage, and this is what technology we started using in 2023. Like we are using putting a marker to see an LA appendage, and this machine tell you, look, this is the LA appendage over here is. So we can really get an answer for any stroke cases. So what next we could have done in this patient? That was the most important challenging part. And that time, like we often give it, sir, nothing, no sources available. So should we do something more, or we went further? Anyway, we went on to do a vertebral artery Doppler. Very few people they do it, but it is important. We did on a machine 1, we couldn't find any significant thing in the vertebral artery Doppler. Here is vertebral artery. Second machine, we want to switch on a color flow, and we couldn't find any flow on this vertebral artery. We were not really sure. We switched on a machine to machine number 2. That second machine we had the same feature. We were not able to see any flow in these vertebral arteries. Third machine we utilized, and this particular machine was able to give us some answer. This was a first segment soon after his origin from left common carotid. So we could see some amount of a venous flow and there's some amount of a red color flow suggesting of vertebral artery. Further, artery became still smaller in size, and the segment, when we scanned the second segment, this is what the vertebral vein flow is there, and we could see a dissection on the intervertebral second segments. Looking at a dissection, diagnosing it on a vertebral Doppler, like none of us buy, especially our colleagues, they never buy with us. So that's what exactly happened. I reported a lit, said, look, I'm looking at a vertebral artery dissection. And look, that was a face of my referring physician. Oh, is it really true? Can you do a vertebral artery dissection? I said, yes, let's see. And he immediately ordered a MRI cranial vessels, And after 1 hour, he did not call me back. So I went to his room. I said, "What happened? Why are you hanging with the face down?" He said, "Look, Rakesh, this is what you diagnose by non-invasive cardiology." Mean to say that we were able to diagnose a dissection of the right vertebral artery right over here just by looking at a vertebral artery Doppler flow in a patient presenting with posterior cerebellar circulations. Well, not much literature is available on this vertebral artery dissection. We have a couple of things in the young patients, and the most important thing is quite a common cause. We can decide by vertebral artery Doppler, and the most important thing is duplex. If it done properly, it shows abnormal flow in almost 95% of our patients, provided you have to have a patience for doing it. Important thing is, in this particular segment is, look, what is the most common cause in our country? We go to barber shop, we get a haircut, we get the hair massage, and then he does some neck movements, Massage with a neck movement, and that was the cause with this particular person having the vertebral artery dissection. So beware of the barber. Have a massage, have a haircut, but don't get your neck twisted up with this particular phenomena. Thank you very much for your patience here.
Thank you. And next presentation is my one imaging failure in 5 decades. It's a very important discussion by Dr. Prashar, and I request everybody to listen to it very carefully.
No, nothing to listen carefully. It is a very mysterious case. So normally my principle is that whenever we do an echo, we don't go rebooting the transducer, the sliding, angulation, rotation, respiratory maneuver, this all will always give us a imaging and will not miss it. Now this was a patient who in 1989, his age was 8 years. Now he is 44 years. He was admitted with the occasional palpitation somewhere. Heart rate was 140, regular, and a systolic murmur found the apex suggestive of mitral regurgitation. That was the period when the angios were done, and the LV angio done showed a large LV, good contractility, huge LA. The RV angio showed RV looks normal in size, pushed to the right side, because that was almost about 30-35 years, so we did not have those images or so. So at that time, a star adverse award was put in 1989, and at surgery they wrote only huge LA, rotating heart anteriorly and to the right. RV pushed to the right side and behind the mitral leaflets. MV leaflets are deficient and large annulus. That was only thing available. So in 1990, he was referred to us for echo. The same thing we said, inconclusive echo, distorted anatomy. We could only see a giant LA with a spontaneous contrast echo. RV could be seen only by a venous contrast echo, which we did and found. Again, he was sent to us by 1992. Again, 2001, same findings. And by that time, the TE was available, so we suggested TE, but then we lost contact with the patient. And so somehow in 2024, he traced me. In December 2023, he had a stroke, but recovered within 24 hours, post probably a embolic stroke. He was admitted to AIMS. The INR was 1.6, then he was stabilized. When he came to us, he was completely asymptomatic, doing regular activities, exertion, nothing, no change, heart rate, BP under control, and the wall clicks were heard normally. And this was sort of an ECG, gave me LV type of configuration. Now this is what we could see. We keep our LV on the left side. So this was the only thing we saw. Huge LA with a spontaneous contrast echo. And this was the mitral prosthesis. And the prosthesis is supposed between the LA and the LV. So where was LV? What were the various structures? Again, you see a spontaneous contrast echo and the mitral prosthesis. Nothing could be known beyond that, and the whole body LA with a spontaneous contrast echo. The pulmonary veins could be seen draining into the left atrium. With great difficulty, the mitral Doppler was obtained because we were not parallel to the Doppler. We were virtually, partly, almost in the same line, but at least we could find that the gradients were not significantly increased. So then we thought, let us. The main finding were normal sinus rhythm, giant LA, never seen an LA of 16 into 10 centimeters, no clot in LA, RV, LV pushed anteriorly, and pulmonary veins were normal. Then we thought of sending to one of our colleagues for a 3D TEE. So once they found that there was a huge LA occupying whole of the image, and this was the prosthesis. Again, this was the aortic wall. The aortic wall is here. The mitral prosthesis is here, close to the aortic wall. But all other structures are completely obliterated. And the flow across the aortic wall was normal, and this is a flow across the mitral prosthesis. So till this time we were completely at a loss that what we are dealing in, why we are failing in our images. So again the fourth chamber view in a T, and you can see this LA, where is LV gone, can't say. This should be possibly tricuspid wall, and then if suppose it is tricuspid wall, the RA looks like this also, but nothing convincing could be seen in this case till now. So it was decided that later on, let's do something. Again you see a 3D echo shows a very, very same thing, and same confusion persisted. So then with the main T findings recorded were in normal prosthetic L wall, no MR, hugely dilated LA with no clot, normal aortic wall, LV not enlarged with normal functions. So this was suggested, why not do a CT to see something, what happens. So a CT was done, and I'll tell you just now. So what they wrote was giant LAV 1200 ml, dilated main pulmonary artery, and distorted anatomy, LVRV pushed anteriorly. So this does not give us much more information. Then we took the help of Dr. Mona Bhatia that please let us know. So her report was, after analyzing, is dextrocardia, aneurysmal LA, LV anterior to RV posterior, and that was the finding she wrote, that this was present, and thus all this, and IV centers and connected to the RV. So that it was this possible finding. So the most unusual features in this case were patient completely asymptomatic, going strong even after 36 years of ball replacement. There was no effect of growth over this period. The valve was put at the age of 8 years, and now it's 44 years. It is still functioning well. What was the cause of severe MR? So most likely, because it was the age of less than 8 years, so most likely it could be a congenital MR. So what was the cause for this? How to evaluate LV and RV? Could it be a congenital LA aneurysm or a secondary to congenital MR? That means a severe MR leading to LA aneurysm or congenital, and the persistence of it then spontaneous contrast echo since about 35 to 37 years. So this was the most unusual features, and then I not go to detail that a congenital MR can be supravalvular, valvular, subvalvular, or mixed. So these where you can go to see this thing also. So that means this we continue to be the most unusual features, and that still some mystery remains also. Thank you very much.
Thank you, sir. Thank you. Ma'am, Professor Anita Saxena, ma'am, perhaps you could add a comment about congenital MR. Dr. Alagason after that, perhaps?
Very interesting. I'm also very intrigued at the diagnosis. I think it would have been a congenital mitral regurgitation with LA aneurysm at that time itself, which over a period of time has got aggravated. And the very fact that he's on good amount of anticoagulant, his spontaneous echo contrast has not become a clot because he must be maintaining his INR around 2.53 or something. And the mitral valve is functioning well despite whatever has been going on, and he's asymptomatic. So I think it's congenital MR with congenital aneurysm of the left atrium. This is what I would think.
Thank you, ma'am. Professor Allegation, sir.
Aneurysm, there were some points against the aneurysm also, but whether it is aneurysm or whether it was severe MR, it will be, and the congenital MR, I told you, could be supravalvular, valvular, subvalvular, and mixed. Any of these cases can consider MR.
We have seen large aneurysm of the left atrial appendage in younger people and also older people that we have encountered. At least I have seen 3 cases. One was a younger patient, but I have not seen mitral regurgitation associated with the congenital left atrial appendage aneurysm.
Because LA aneurysm, appendage aneurysm will be. I'm always scared of Samir.
No.
Yeah.
Sir, the feelings are absolutely mutual.
I could not hear you.
No, my take on it is that the kid must have had a mitral valve replacement for whatever reason. Now, at the age of 8 years, his size of the valve which was put was a small valve. And over a period of time, this manifested as a patient prosthetic mismatch, because of which LA started dilating. So initially, probably LA was normal. I don't think that there could be a LA which is, because one evidence which is there for a high gradients or a high LA pressure is the spontaneous echo contrast. So I think it was, he's grown over a period of time, and because of this, his LA has enlarged and spontaneous echo contrast has manifested then.
At the time of angio and the surgery, it was noted that there is a giant LA with a spontaneous contrast. That means it was present even in 1989. Same thing.
Samir, the time.
Oh, there are no.
Yeah.
Okay.
And he has been completely asymptomatic.
That means it must have been a very large annulus that time also.
Thank you, Samir.
But the
time holds true
prosthetic
also
valve.
for us. Please sit down.
Okay, thank you all. That was a really wonderful session. Now, may I invite Dr. Debika Chatterjee from Kolkata to talk to us about a rare case of syncope. Go ahead.
Thank you, madam. Good afternoon, everybody. My case is an unusual case of syncope in a lady who is 58 years old, female, with unremarkable past medical history, had 2 episodes of syncope in last 2 months. She also had 4 months history of intermittent dry cough, easy fatigability, and progressive shortness of breath on exertion. On clinical examination, BP, pulse, heart sounds were normal, but she had bilateral crepitations. Her oxygen saturation at room air was 94%, which dropped further to 88% on exertion. 24 hours Holter monitoring showed few isolated and couplets of VPCs. So as I started doing echocardiography, in parasternal long axis view, I could see that LV is dilated. And if you look here, this part of the anteroseptum is looking scarred. In the parasternal short axis view, again that same part is looking scarred and aneurysmal. The picture was clear as I went to the apical 4-chamber view, where I could see the basal mainly. A part of the mid-septum was thinned out, notched out, and aneurysmal. So I thought there is some regional wall motion abnormality in the LAD territory, but as I went to the 2-chamber view, I saw that anterior wall is contracting very well. There is no evidence of scarring or wall motion abnormality. On the other hand, 3-chamber view again showed anteroseptum scarred. So regional wall motion abnormality not fitting into the LAD distribution was the finding which I got. She had grade 2 diastolic dysfunction with average E by E prime 15.9. Her RV function was absolutely okay with a TAPSE value of 21 millimeter, and tissue Doppler systolic velocity was 12 centimeter per second. She had a trivial tear with a tear gradient of only 14. IVC was normal, so she didn't have any pH. The strain imaging showed low GLS, minus 15.4%. LVGLS was low. And if you look at the regional strain pattern, these are the areas where the basal anteroseptum and part of the mid where the regional strain was less. The apical part and the mid part of the LAD territory were okay. So if I summarize my echo findings, it's dilated LV, septal thinning, wall motion abnormality, not fitting in classic coronary distribution, with systolic and diastolic dysfunction of LV, low GLS. So what should be my diagnosis? I was at a loss. It neither fits into the ischemic heart disease. So I couldn't give the diagnosis initially. I couldn't come to a diagnosis. I had to give the echo findings. Since she complained of dry cough, a lung function test was done, which showed restrictive pattern, and the HRCT showed typical ground glass opacity with multiple nodules, mediastinal lymphadenopathy. All these features are suggestive of pulmonary sarcoidosis. So now the picture was clear, picture of echocardiography. Probably we are dealing with a case of systemic sarcoidosis, pulmonary sarcoidosis, with probable involvement of the heart, which was confirmed by CMR, which showed basal to mid septal thinning and localized late gadolinium enhancement, showing scarring in the mid myocardium and epicardium of basal to mid septum as well as of the lateral wall, as opposed to the subendocardial, which we get in ischemic heart disease. So it is a case of cardiac sarcoidosis, the incidence of which is said to be 2 to 5%, but actually the number is very high, as is seen by autopsy studies. So what we are getting is the tip of the iceberg. We are missing many cases, and we must remember that once the heart muscle is involved, the prognosis of sarcoidosis is very, very bad. And cardiac sarcoidosis accounts for more than 2/3 of global death in sarcoid patient. There is a variable location of lesion, sarcoid lesion in cardiac sarcoidosis. However, it has got a predilection for base of the septum, LV free wall, conduction system, and very rarely heart valves, coronary artery, and the pericardium. It is because the conduction system is involved, we get various ECG findings in the form of AV block, which may vary from first degree AV block to complete heart block, bundle branch block, ventricular arrhythmia, where we may get PPCs and VT, and supraventricular arrhythmia also may be a finding. Because of this, the variable location of the lesion, we get a wide spectrum of clinical manifestation. It may be silent, asymptomatic, or very mild, benign symptoms, up to severe signs and symptoms of heart failure due to cardiomyopathy, or maybe an arrhythmic symptom like palpitation, pre-syncope, or syncope, because even up to the sudden cardiac death. So this is the symptom which we probably got in our patient, and this is the arrhythmic symptom may lead to the sudden cardiac death due to ventricular tachycardia. So we need to be very, very careful. It is the PET scan which can detect the sarcoidosis with a very high sensitivity, but the technique of choice is CMR with contrast. If we look at the echocardiographic features in cardiac sarcoidosis, the findings are reported in 24 to 77% of the cases in the form of wall motion abnormality, not fitting in classic coronary distribution, LV dilatation, systolic dysfunction, diastolic dysfunction. Even it may involve RV with RV dilatation and hypokinesia, low GLS. But we must remember that echo findings may be absolutely normal, no wall motion abnormality, normal EF. So that way, echo is very, very insensitive technique to detect cardiac sarcoidosis. Normal EF and no wall motion abnormality, absence of wall motion abnormality cannot be used to rule out presence of sarcoidosis, cardiac sarcoidosis. Then why do we do echo? It is because if we have the positive findings, we can start
Ma'am,
suspecting.
sorry to interrupt.
Yeah. Just last slide.
Okay.
We must remember diagnosis is very, very challenging. We should suspect cardiac sarcoidosis if there is prior history of non-cardiac sarcoidosis with new and unexplained AV block, arrhythmia, along with these positive echo findings which I have shown. And then in those cases, we can start active screening, which will promote early diagnosis and treatment. Thank you.
Thank you, chairpersons, and thank you, speakers, for the wonderful deliberations. And now we have a very important session coming ahead. So I would like that it should start now. So the next coming session is very, very interesting. It's a debate. It's a debate on valvular heart disease management, catheter versus the knife, which is better. For this important session, I would like to invite Dr. Sameer Srivastav and Dr. H.K. Chopra as main chairpersons.
Well, this is today like everybody talks of a tower versus sour. Let's see whether tower is tower, sour is sour. So that's what's going to happen next 20 minutes. And we have two very, very dynamic person talking about all these things. One who always talks of a tower, the other one always talk of a sour. So let's, Satish, it's all yours. Our tower to begin with tower.
Dear friends, you just heard 6 eye-opener cases. And this debate is going to be a very outstanding debate. And I still don't know why every time in debate, O.P. Yadav is chosen. I still don't know. I'm sure you'll come to know, and he's looking at me. I know why exactly he's looking at me. And Sameer is next door. So this is going to create a lot of thought-provoking discussion. So we have 2 important speakers here. The topic is valvular heart disease management, catheter versus the knife. Knife is sitting before us. Where is the catheter? Catheter is here. Okay. So I think the speaker for the catheter is Satish Govind, 10 minutes. And the next speaker is no. He says the knife is the answer, is O.P. Yadav, 10 minutes. I'll hand over the mic to my co-chairperson to give the initial comments.
That's fine. I think we'll go ahead. Running short of time. Govind.
Okay. Thank you for the nice introduction. And so valvular heart disease is a big thing. And then the transcatheter interventions, it's like a juggernaut right now, rolling past and then coming out with some newer things. So let us see where we stand vis-a-vis in terms of surgery and the transcatheter itself. So when you look at the cath lab, when you look at the transcatheter, so what comes to mind is you have this cath lab and you have an echo machine with this nice images, and then you have the anesthesiologist, and then you have the cath lab staff. So it's a lot of harmony and synchrony here. But when you look into the OT, and this is what it's going to be. So that is how there are two different arenas, and this is how it looks like. Now let us look at the guidelines themselves. So the guidelines straight away sort of has brought in at class 1. So surgery and transcatheter, as far as the valves are concerned, they are at equal levels now. And you have this new entity, the heart team, which has been there for a while. And then you have the patient over there. So the ultimately it is going to be the patient who is going to be the decision maker, and this is agreed upon both by the ACC and the ESC guidelines. So this is how it is as far as the guidelines are concerned. Now, when you look at the valve itself, so the aortic stenosis, so this is the big the valve which started its journey almost 2.5 decades back, and really created the platform for other interventions to happen. So initially, it started with symptomatic patients. It was with people of older age, and then high risk, inoperable, and then gradually over a period of time, as the data started to come, the numbers started to increase. We started to see even asymptomatic patients being looked at, intermediate risk, and now even at low risk also. So that's where the data is coming. And you can see that the other side, the table, is that there are a lot of areas where the TAVI provides in terms of what it delivers in terms of outcome and other things. Now, when you look at the devices, I think there are more devices than the items which I had in breakfast today at Lalit. So you have a lot of devices here, and they are there to fit every valve and whatever the scenario. So that is where it is, and it's getting bigger and bigger. And typically in aortic stenosis, there is always this fear of the stroke itself. So you have a lot of cerebral embolic protection devices which are there. So that has made the procedure itself much safer. And now we are looking into an era where the third procedure is now being accepted more and more as the skills are getting better. So we have looked at, SAVR. That means you have one surgery, you have a redo, and then now even 3 also. So soon there is going to be TAVR. So this is how the sound is going to be as the time progresses. Now let's look at the opinion on either sides of the arena. So you are looking at one, Dr. Ashok said, so a very powerful statement. The future of aortic valve disease treatment is TAVR. And then you look at the other side also, the surgeon. So implanting a TAVR has become so easy. It is easy to teach someone for a very short period. And when you compare it with the SAVR, it takes a much longer time to master it. And then this is from a cardiac surgeon. So this again is looking ahead now. So what we are looking at is the TAVR itself is now crossing aortic stenosis, getting into aortic insufficiency, and bicuspid aortic valve problem is not a problem anymore. And not just the bicuspid aortic valve, it's also looking at the aorta, the aortopathy also. So here we are looking at endovascular stenting, and this is how the future is going to be, and this is coming from a surgeon. Now, what about the outcomes? Typically, the question is how good are the outcomes? So again, it is here it is at least equivalent, if not superior. And then this is how it's going to be in the next 10 years. So where the SAVR will take a back seat and the TAVR will be in the forefront. And what they are looking right now is a TAVR, which is going to be, right now it's about 2 to 3 days. So there we are looking at a day where possibly a TAVR can be done in the same day, almost like an angiogram. So that's how it's going to be in the future. Now, apart from aortic stenosis, regurgitation itself. So you have regurgitation, the AR, and this was one where a lot of people, especially the severe ARs who had a lot of morbids and then who were elderly, sick people, many of them were left behind. It's almost 70% of them were not really sort of looked into, and they had a 10-year mortality. So what about these patients? So now you have a device for them also. So here is a meta-analysis which has looked at both dedicated and off-label devices, and they have looked at 34 studies, 2,000 plus patients, and then look at the device success itself. It's almost about 93%. So this has been compared with an off-label, but again the success rate is quite high. Stroke rate is comparable, and then the mortality has significantly come down. So this is a group of patients where they are going to be benefited, where the aortic regurgitation is going to be something which can be tackled in the years, probably in the year to come, I would say. Now, moving on from aortic regurgitation, let's look at mitral regurgitation, the mitral valve. So, mitral regurgitation, again, if you look at the guidelines here, if you look at the algorithm as far as 2020, it is again a class 2 here, and then you have the edge-to-edge repair, which is featured very prominently here. And this has again grown in over the years and has become a mainstream sort of approach to treat patients with significant MI. Now, again, devices, there are in plenty. So a lot of devices, again, looking at the valve, looking at the chordae, looking at the annulus, you can name it, they have it. And then this is how it's going to be as things sort of move on and as far as the mitral valve is concerned. Now, echo in this plays a crucial role. So without the echo, most of these mitral valve interventions cannot be done. And with some advancement in the images and the way it is, even complex and difficult cases which were earlier written off are now being sort of given new life, and they are sort of having a better quality of life. So whether it is prosthetic valve, whether it is a mitral clip, or whether it is the valve in valve, and of course you have the stenosis with the PTMC, which has been there for a long time. So transcatheter, as far as mitral valve is concerned, has come a long way. Now, what about the tricuspid regurgitation itself? So this is just hot off the shelf. So this is just come this year, so published this month. And this is looking at transcatheter versus surgery. So again, looking at 2 years outcomes, so better perioperative outcomes with the T-tier. So that is the transcatheter H2H repair of the tricuspid valve. And they have lower in-hospital mortality and lower pacemaker implants. So this is another area which is going to get better. And the final valve, always the most, the difficult one with a lot of the complexities it comes with. It's been sort of been looked into since almost 2000, but here again, a lot of valves are there. And here again, looking at this particular review in this journal. So again, it is, as far as the freedom of intervention is concerned, and when it comes to survival, comparable with the surgical valves. And not to be left behind, so you have these newer sort of, the spin-offs which are happening. So you have the transcatheter aspiration of the tricuspid vegetations also. So you have many of these sort of vendors which have come out with, and this is more on the right side, where you have the tricuspid valve, where people come up with endocarditis, and then they are high risk for surgery, and the debulking approach helps these patients to a large extent, and it is being proven patient by patient as we see it being implemented. So what can the transcatheter procedures treat? So you have a whole host of procedures. You have, starting with the aortic valve and the prosthetic biovalve, and you have the mitral valve, and that list is really long, and I've just sort of compressed it, and it can be a little more complex itself. And so that is what is available and what is going to sort of happen in future as it continues to progress. And who are these patients who are being looked into? So you have the inoperable ones, you have the high risk ones, and then the intermediate risk ones are also being looked into, and even the low risks are now being looked at. And of course, it can be used in the setting of acute and chronic also. And then you have the future where the younger age group and even moderate disease is being sort of considered. So this is where it is going to go in the future. So what does the data show, and what does the patient prefer? So ultimately, it all comes down to what does the data show and what does the patient prefer. So it is going to be the transcatheter. So that is how it is going to be. And then, of course, as far as the patient is concerned, it's always going to be the transcatheter that's the usual patient psychology. That's how it is. But this is backed up by data. So that's how it's going to be. So I would like to sort of end with this. So when it comes to transcatheter procedures, so that's how it's going to be. And, the other side, I leave it. But ultimately, it's going to be the patient who sort of, will take the choice. Thank you.
Lovely. I think you have done a fair job giving all the statistics and numbers. But as the old saying goes, statistics are like bikini. They reveal the most, but they hide the essentials. And having been in this process ever since it started in this country, I know that when catheter fails, Dr. O.P. Yadav is called for. Sir, all yours.
Thanks a lot, ladies and gentlemen. That was a lovely, lovely presentation, Satish. I really enjoyed it. How do we move this, please, here? Yeah. Okay. There is a very famous Greek aphorism, no surrenderes. When meeting someone you are attracted to, spend 40 days and 40 nights together. Love at first sight has frequently led to disapproval, frustration, and expensive outcomes. But we seem to throw this wisdom, ancient wisdom, Patrick's arise when he looked at no restenosis and drug-eluting stents at just a few weeks. He drove a nail into the coffin of surgery, and the entire cardiology community went into an orgasmic ecstasy, thinking surgeon will be obliterated. And what happened? The PCI numbers are coming down. And now, ladies and gentlemen, with TAVI, cardiologists have broken into a jingalala. The debate is, which is better? You only debate when there are two options, then you debate. Do we have any option? When TAVI fails primarily, you have annular rupture, you have dislodgement, you have coronary obstructions, you call the surgery to bail you out, 5 to 10% in expert hands. And then there are absolute contraindication. Don't forget, in India, it's rheumatic heart disease. When you have to put the mechanical valve, can you do it? When you have no large vessel excess, when you have associated pathologies, when you have hostile anatomy of the aortic root, what do? So, ladies and gentlemen, the debate should not be which is better. The debate should be which is more appropriate for a given situation. Second question I posit to you, Satish. On what model of clinical reasoning or propositional logic are you basing use of TAVI, modus ponens, or modus tollens? To my knowledge, none. The model you have taken is called modus convoluted. We are going to do TAVI. If we are proven wrong, we are going to stop. What recompense you are going to give to the patient who has been harmed during this phase of your indiscretion? Have we studied these clinical situations? Have we studied these anatomical problems and hostile anatomies like calcified raphe, severe alveolar obstruction and short membranous septum and all those things? And have we looked at the durability? It has been shown from surgical studies that patients less than 60 years, valve degeneration is in the range of 50 to 60%. And we are using TAVI. This is all late-breaking data of last 3 months. Mortality of TAVI, 5 years, 2.5 times more than surgical AVR. Patients younger than 65 years incurred higher rates of death and readmission in 1 year, published data, and that's why STS released 50% of patients under 60% choose TAVR with worse outcomes. Ladies and gentlemen, the statement should have been not choose TAVR. They are made to choose TAVR because of the wrong presentation of facts by our cardiology colleagues. And look at the Northern England study. This is all last 6 months data. Early mortality in these patients of SAVR less than that of the TAVI, because the moment you go into low risk, the risk of surgery is less than 1%. Look at your data. At 2 years, there is crossing of the mortality curves. Look at the meta-analysis. TAVI has worst outcomes after 40 months. And look at the poor patient-level pooled meta-analysis. Survival, the red line, far ahead of the blue, the TAVI line. And look at the contemporary outcomes, published data, again 24, 8 years survival, 95%. And that is the reason the guidelines, you never showed these guidelines, you showed mitral guidelines. 75 years is the cutoff according to the European guidelines and 65 according to the American guidelines. You didn't mention, but Evolute, only one study which shows some good. Well, almost 1/3 patients had associate procedures and the pacemaker rates were 3 times higher with TAVI. Ladies and gentlemen, you mentioned about TAVI and TAVI. In 20% of patients, TAVI and TAVI is not possible. And when it is possible, it is associated with 3 times higher mortality. Again, current data published by the cardiologists. And not only that, if you require surgery after a TAVI, look at the surgical mortality rate, 15%. You leave no scope for us. And not only surgical off TAVR, If you have to do a bypass or an MVR in a patient with TAVR, there is a higher risk. Bowdish et al.'s published data. What about almost 100% of patients getting conduction abnormalities? Silent severe in 3/4 of patients, and cerebral protection devices do not give any advantage. Thrombosis in 43%, leading to reduced valve durability. And more than 20% of patients, ladies and gentlemen, in the lifetime paradigm, they have associated coronary artery disease. And if they have some problem, almost 1/4 cannot have a PCI. And those who have a PCI, they have higher mortality. What about 1/4 of patients having mild leak? What is the consequence of this long term? We still do not know. And then science must address the aspirations of the society. We should look at the availability. We should also look at the skills available. Do you know the cutoff given? 150 procedures to get per year to be able to do a TAVI of a good quality. May I know which center in the country is doing 150? We are all playing with the patients. And imagine once this nanosynthesized mechanical valve needing no anticoagulation sees the life, the daylight, then where would be the prosthetic or bioprosthetic valves of TAVI? Coming to mitral BMV, I give a class 1, I don't debate. Your mitral valve the replacement has never come out of the bench to the bedside, never. Percutaneous valve repairs only flatter to deceive, and the only one which has worked out to some extent is the mitral clip. But as they say, ladies and gentlemen, one size fits all is good for socks, bad for beliefs. What is the belief in surgery? Whenever we do repair, it is always said, do repair early. And what do you say when you do repairs? Do repairs when you have NYHA class 4 symptom with no option. Do it late. Well, when we do it early, the mortality is 0, and done early, it is virtually curative. And also we need an annuloplasty to support these valves. Do we have an annuloplasty in supporting these valves in percutaneous techniques? Moreover, mitral clip is not universally applicable. There are so many contraindications. And what you declare as success, a gradient less than 10, regurgitation less than 1, barely 60% of patients have success of mitral clip. And look at surgery. Surgery, it is 95% even at 1 year. Operative mortality under 1%. That is the requirement of what is called the reference mitral surgeon in the guidelines. Procedural success 95%. Look at the long-term data, 20 years. Probability of mitral valve reoperation barely 6%, 94% free of reoperation. And when you have direct head-to-head comparison in degenerative valve, 5-year survival, 80% versus 35%. And recurrent MR, look at this, 35 versus 4%. Where are you comparing it? Secondary MR, I grant you, MTR has got survival benefit. I'm not going to debate. Your Meteron study, a lot of other studies have shown, and primary TR, surgery is class 1. There is no indication for secondary TR of these patients. And so ladies and gentlemen, to finish, we need to have a very balanced view of this. And when we are debating surgery versus percutaneous, don't forget medicine is a very potent tool today. Very potent tool. We can't ignore it. We must factor the patient, the pathology, the physician. What is the age of the patient? What is the life expectancy versus durability? Any contraindication to anticoagulation? So, ladies and gentlemen, before this ugly duckling turns into a swan, please do not add to the army of percutaneous victims. Thank you.
Wonderful, wonderful. Always in education and entertainment. Please. Sit here. So this puts two things in perspective. One is, where does surgery stand as far as valve is concerned, and number two answers Dr. H.K. Chopra's question that why is it that Dr. O.P. Yadav always figures into the debates. Your rebuttal, 2 minutes, and your time starts now.
That was a very eloquent and a very powerful talk, but I beg to differ, sir. You're on the wrong side of the fence. So why? I will tell you. So one is changes are coming ahead, and what are these? I will show you. Let us take a look at this data. So this is from 2024, and this is from Cardiac Surgery Journal. So let us look at the heart team itself, the surgeon's involvement, how it looks like. So you have a very big involvement. So surgeons are part of the team now. Involvement in TAVR cases. This is from the US. So that is the only drawback, if I have to say. So you can see that a good number of surgeons are doing TAVRs. So very small number is not involved, and they are missing out. Come down to the tier itself. The numbers have increased. So the yes, the surgeons who are doing is going up. The no's are still there, so we don't know why. But when it comes to TMVR, you have a very high number of surgeons who are involved in the TMVRs now. What about tier, T tier? So tricuspid, it's a no-go situation there. So not many you see that surgeons are not involved there. And then, of course, the TTVR also. And look at the age also. If you look at the two continents, you have Europe and you have the US, and the age is coming down. So SAVR is being more accepted, and we have to wait and see. Of course, we have to look at data. So again, when it comes to it, it's less invasive, and that is how it is going to be as a powerful tool with good outcomes. Now, let's look at the cardiac surgeon future. This is from ACC, 2015, mind you. So it has been described at that time as a dying specialty. It's being overshadowed by its impending decline. And again, this is from the STS. You can't get a better society than the Society of Thoracic Surgeons. So look at their data. So it shows the TMVRs are going up and up and up, while the regular surgical ones are sort of stagnant, and they're a little going down also. And on the other side, of course, TAVR is skyrocketing over there. So that is how it's going to be. And so what's missing? So coming soon, it's going to be more of interventions when it comes to tricuspid valve and pulmonary valve. And then this is just 5 days back, and this is what was spoken at the Society of Thoracic Surgeons. So this is a wake-up call, a warning that if they have to readjust, and they have to show greater intent to operate on the tricuspid valve, and this is the alarm that is there. So transcatheter interventions are here to stay, and that is how it is going to be. Of course, we're going to be very dependent on the surgical colleagues. They are going to be there, and of course, as he rightly said, medicines are also going to be there, but we need to change. So this is what is important. So that is, otherwise, we are just going to fall off the cliff if we don't adapt to the situation. Thank you.
Lovely. And your rebuttal for 2 minutes, and we gave you 5 minutes for coffee. We'll be more liberal for lunch. We'll give you 7.5 minutes. So your rebuttal, sir, and then last comments from Dr. Chopra, and then we'll call it.
But just a small observation for the audience. They mentioned about the involvement of the surgeon. The regulatory requirement of USA demands that for TAVI there is bundled payment. And the bundled payment has to have by law a cardiologist, a cardiac surgeon. Probably the regulatory bodies don't trust the cardiologists, and they want to have the cardiac surgeons on board. The same is not there for tricuspid valve. So a cardiologist, when he sees a patient with TR, he can do the tricuspid TR without talking to a surgeon, but he cannot do a TAVI without talking to a surgeon, or a mitral without talking to a surgeon. That is why you are seeing so much surgeon participation. They are not implanting TAVRs, all of them. They are part of the team. So please correct the exact situation. Second, let me tell you, these debates are never good learning podiums. They are all polarized, and the two extremes And the truth is always in the middle. Always in the middle. I was given a task, I blew it out of proportion, he was given a task. No one says surgery is going to go away, no one says TAVI is a humbug. No. All we are saying, use the right procedure on the right patient at the right time using the right skills. Thank you.
So, coming towards the end of this session, wonderful session, and I completely agree that truth lies somewhere in between. And you kind of have to mix and match the best what is available for the patient. But for all these things, there is a mandated law in our country also, sir, that you have to have a heart team, which consists of an imaging person, which consists of an implanter, surgeon, anesthetist, and that is how the thing should go. Sir, your last comments, and then we'll invite them for lunch.
Ladies and gentlemen, you heard most prolific speakers. OP, I already pointed out, he's in every debate. He's a real orator, a very powerful orator. And I must tell you today with a great deal of confidence, change is the essence of life. No change, no progress. So there is some progress. A time was there when there used to be debate between PCI and CABG. So PCI is winner to a very large extent. I know OP for last so many years now. He's a very good friend and a great debater. Whenever there is something new, initially there is a reaction. And then there is adjustment. And then there is a liking. So we are between second and third phase at the moment. I think our speaker from Bangalore was also very prolific. And he used the word TAVR, TAVR, and TAVR. And on the contrary, he also mentioned that SAVR and TAVR, SAVR, and then TAVR. So there are 3 times TAVR. Am I right? I think this was very prolific. And I think the last statement given by OP Yadav is very well acceptable to each and every one of you. That you have to individualize your patient. See the patient as a whole. Holistic approach is required. We are not giving a universal formula. TAVI for all. It's not like that. And I think Samir was very, very focused in his approach that we must individualize our patient. Last comment I must give, ladies and gentlemen, the debate here is with consensus that both of them are right. There is no fight. The only thing is we have to individualize our patient and see the patient very carefully, who can afford, who cannot afford, who has comorbidity, who is not having comorbidities. And I think since there is a progress, and I remember the words of Govind, he mentioned very rightly, ladies and gentlemen, it's an opening statement and very powerful statement by him that a time has come where TAVI means only daycare. Am I right, sir? You mentioned only daycare, which is not possible in the surgical as SAVR. I think overall, both of them have done a wonderful job, but no doubt, he is a very strong man in speaking, I know it. And I think let's give a big hand to both of them. Wonderful.
Thank you, ladies and gentlemen. Definitely, we saw the 2 judges sitting on the dais and 2 lawyers fighting with each other. And you know what's the final outcome is? Neither the case is drawn, neither case is judged. And that's what was a debate today in surgical versus catheter. And we break for a quick lunch, eat little, sleep less, and listen more. That's what the is. And the lunch is right down in the basement. And my request is please go to the basement from outside, and you can carry your spouses along with you. There is no restriction for any one of you.
So now it's time for our very important session post-lunch. And till the time people join us, I'll announce the chairpersons, Dr. Alagizan, Dr. Manish Bansal, Dr. Vivek Solare, Rakesh Ranjan, Dr. Kartik Agarwal, and Dr. T.M. Agarwal, please.
Let us go ahead with the first case, LBH in a case of CKD. What is the cause? Dr. Aridip Agrawal.
Good afternoon, everyone. So I'm going to present this case of a CKD patient who had significant LVH and in which we had a diagnostic challenge. So this was a 42-year-old gentleman who was a known case of CKD on dialysis with no other comorbidities. He was admitted under nephrology unit for renal transplant workup. An echocardiogram was done as a part of pre-transplant workup, which reported to be suggestive of hypertrophic cardiomyopathy. So in view of echo findings and also for the purpose of renal transplant clearance, we were asked to see this patient. So these are the echo images. These are parasternal views, and we can see that there is significantly increased LV wall thickness, and myocardial texture appears abnormal. Septal thickness is somewhere around 18 millimeter, and there is suggestion of some caudal SAM in the plaques view. There is small pericardial effusion along the LV inferolateral wall. On further imaging on apical views, almost similar findings, but in this apical long axis view, the caudal SAM can be better appreciated. But in these images, it appears as if the septum is a bit more prominent in comparison to the inferolateral and anterolateral wall. So on color Doppler imaging and continuous wave Doppler, there was no significant LVOT obstruction. Now this is the mitral inflow pattern, which is showing E is less than A. E velocity is somewhere around 40 to 50 centimeter per second. E prime is 5 to 6 centimeter per second. Overall reflecting normal LV filling pressures. IVC is dilated with more than 50% collapse with inspiration. And this is the global longitudinal strain bullseye plot, and which showed significantly reduced GLS at minus 9.3%, but it was not pointing towards any specific pattern. So overall, the echo findings, the patient had significant LVH. Maybe there is some degree of ASH, mild caudal SAM, no LVOT obstruction. E is less than A, normal LV filling pressures, reasonably preserved LVEF, but markedly reduced LVGLS, small pericardial effusion. So overall, all these echo findings, they were not really pointing towards any specific pathology. So we looked at the ECG of this patient. So ECG, I would say, further added to the confusion because it was neither pointing towards the typical LVH with strain pattern which we see in HCM, and nor it was pointing towards that typical low voltage ECG which we see in amyloidosis. So it was kind of discordant ECG. So the question was that what could be the cause of LVH in this patient? Now, since I said this was a CKD patient, so it is not uncommon to come across significant LVH in a patient of chronic kidney disease. And generally, the reason for LVH in CKD is hypertension. But this patient had no history of hypertension. He has never been on antihypertensives. So this possibility seemed a bit unlikely in this patient. The second possibility was, as was reported by the person who did the echo, was hypertrophic cardiomyopathy on the basis of that there is some ASH, caudal SAM. Again, because ECG was not very consistent with the HCM, so this was also a bit doubtful. It may be HCM, it may not be HCM. The other possibility was amyloidosis. In fact, when we first saw the images, that was our first impression that probably this is cardiac amyloidosis because of the extent of LVA, discordant ECG, and myocardial texture was abnormal. So we thought that this patient should be worked up on the lines of AL amyloidosis. But when we further saw the records of the patient, we came to know that patient had renal biopsy 1 year back, which showed minimal change disease. Now, this finding was a bit discouraging to our diagnosis of cardiac amyloidosis because renal, it did not show any evidence of amyloidosis. So renal biopsy has very good sensitivity to detect amyloidosis. Now, this negative for amyloidosis, so again, put our diagnosis of amyloidosis under doubt. But the echo findings and the ECG finding, they were kind of bothering us. So we requested for free light chain assay in this patient. Now, this is the free light chain assay report. And as we can see that the lambda chains are markedly increased and there is abnormally low kappa lambda ratio. Now, in a patient of CKD, high kappa lambda ratio can still be seen, but low kappa lambda ratio is almost always abnormal. And in this scenario, we started chasing for the diagnosis of AL type of amyloidosis. So we asked for hematology consultation and a bone marrow biopsy and bone marrow aspirate was done for this patient, but that showed only 4% of plasma mesenchyma cells and did not show any evidence of amyloidosis again. So a fat pad biopsy was done. Again, that was negative for amyloidosis. So all these tissue diagnosis was not giving us any proper diagnosis. So we decided to go ahead that let's confirm our echo findings by doing a cardiac MRI also. So we did cardiac MRI, but again, the cardiac MRI did not show the classical picture of amyloid. It kind of raised suspicion for amyloidosis, but did not rule out amyloidosis. So all of the investigation, except for free light chain assay, all of the investigations were kind of equivocal. Neither they were ruling in amyloidosis or ruling out amyloidosis. So we decided to go ahead with the endomyocardial biopsy because it was very important to decide this in this patient because patient had to go for renal transplant. So endomyocardial biopsy was done, which kind of nailed the diagnosis. Congruent staining showed apple green birefringence on polarized light, and ultimately, like after a lot of ifs and buts and uncertainties, the diagnosis of AL type of cardiac amyloidosis was established in this case. So patient who came with a diagnosis of CKD with minimal change disease, admitted for renal transplant workup, ultimately turned out to be case of AL type of cardiac amyloidosis. And in this patient, renal transplant was cancelled, obviously, and patient was started on chemotherapy by the hematology unit. So I would like to take this opportunity to briefly discuss that why we got so confused and why we were still chasing for this diagnosis despite so many tissue biopsies being negative. Now, if we come across any patient of significant LVH, first of all, it is important to rule out common causes. And if I assume that all common causes have been ruled out, then there are broadly two categories. One is infiltrative disease, in which amyloidosis is most common. The other category is hypertrophic cardiomyopathy. Now, both these diseases, amyloidosis and hyper, they are quite notorious because both of them, they can mimic each other. You can find ASH pattern in amyloidosis. You can find caudal SAM in amyloidosis. And similarly, HCM can present with concentric variant and giving us confusing us further. Now, one simple investigation which can differentiate between these two entities, that we should always look for ECG if we come across this kind of scenario. A classical low voltage ECG can kind of virtually clinch the diagnosis. But the problem is that a classical low voltage ECG is not seen in all patients of amyloidosis. They are seen in only 50% of the patients. And similarly, even in HCM, in 6% of the patient, you will not find any LVH with strain pattern. So it is reliable, but it is not diagnostic. So briefly, if you come across any patient who has signs and symptoms, echo findings, or cardiac MRI suggestive of cardiac amyloidosis, always look for free light chain, and that should be our first investigation. And if you find abnormally low kappa lambda ratio, the next step is to get the tissue diagnosis. Now, normally we can sample the surrogate biopsy sites, abdominal fat pad or bone marrow biopsy, but none of these are 100% sensitive. A negative abdominal fat pad biopsy does not rule out amyloidosis. Similarly, bone marrow biopsy also can tell us whether this patient has plasma cell dyscrasia or not, but it is again not 100% sensitive for amyloid deposits. Then renal biopsy, if a patient has got renal dysfunction, a renal biopsy can be very useful, but the problem is that it is very sensitive. But case reports have shown that in earlier stages of amyloidosis, patients on renal biopsy may show pathological changes mimicking other glomerular diseases, as in this case report, which is very similar to what our case, that minimal change disease was seen on biopsy, and 2 years later when biopsy was done, patient had amyloid. It was suggested that it is because of the amyloid related toxins which causes the pathological changes even before the actual amyloid is detected on the biopsy. Ultimately, you have to go for the endomyocardial biopsy if we have to establish the diagnosis of the cardiac amyloidosis. And if the hematological tests are negative, do not stop your diagnosis if you are still suspecting amyloidosis. You should get a PYP scan to rule out ETTR of amyloidosis. And if that shows significant uptake, you don't really need any tissue biopsy for that. You can straight away make the diagnosis of ETTR type of cardiac amyloidosis. So in the end, I would like to finish with this last two slides, that when do you suspect amyloidosis? Now, this picture is a typical cardiac amyloidosis. This is like textbook picture. But so this is generally not missed. But by the time patient come to us with this echo picture, the disease is always in the advanced stage. What we aim for is to suspect amyloidosis at an early stage, because the treatment is more effective when the treatment is started early. Now, what are the red flags which we need to be very mindful of? Any patient who's got LV wall thickness increased by 12 millimeter and is now presenting with either recurrent pleural effusions unexplained, recurrent pericardial effusions unexplained, and or patient with HFpEF, aortic stenosis, carpal tunnel syndrome. There's a long list, and we should be very careful of these so that we do not miss this diagnosis, because you actually need to have a very high index of suspicion to detect amyloidosis. It is not as uncommon as it was previously thought to be. Thank you.
I think it was a brilliant presentation and a very nicely worked up case. I think it's a real issue. When we subject our patient for renal transplant, they are not worked up the way you did it. And I think this is a very, very important message. I've seen a lot of renal transplants are done. And I think the way you explained, I just want to ask, is rectal biopsy more sensitive or rectal biopsy not sensitive?
So,
for amyloidosis?
As far as I know, none of these biopsies, they are 100% sensitive, but I think, I'm not very sure, but at our center, we generally do either abdominal fat pad biopsy, or bone marrow biopsy is always done to establish the diagnosis of plasma cell dyscrasia. I don't think that we do rectal biopsies anymore. I don't know if anybody else has other opinion.
Dr. Alagation?
No questions. Nicely worked up case. Thank you.
We can go on to the next
We'll go to the second case. RB cardiomyopathy or pulmonary embolism. That's yes, Gopal.
So I'll request everyone to be on time because we are running short of time. We are already 20 minutes late in the sessions.
Thank you, chairpersons, and thanks once again for the invitation. With Dr. Parashar's permission, I had actually changed my topic to align with what Dr. Hardeep had just presented, to reinforce a similar challenge that is very common and that we see day to day in practice. I've kept my timer, and I'm afraid I shouldn't exceed it. So this is a 42-year-old female with exertional dyspnea for 1 month. All pre-admission, she had sudden palpitations with syncope. I put it in chronological order, was found to have VT, cardiac arrest, multiple shocks, resuscitated, normal coronaries. And then after discharge, after all that, was once again found to have palpitation, syncope, again required resuscitation. The diagnosis done elsewhere was a dilated cardiomyopathy, moderate LV dysfunction. She was referred for further management. Younger brother died at the age of 20. That was a positive history there. This was the ECG when she came to us. Broad QRS, bizarre in sinus rhythm, congested with cardiomegaly, mild anemia, iron deficiency mostly, and some hypokalemia. She was on diuretics. Apart from that, nothing very remarkable. This was the echo. Thickened LV walls, which seem to be concentric, a bit of pericardial effusion, dilated left atrium, likely to have diastolic dysfunction. And again, not great images, day-to-day run-of-the-mill images taken retrospectively, showing the same thing. The 2-chamber and the 3-chamber views show a slightly elongated AML. Sometimes we take this as a pointer towards mitral valve abnormality, which might point towards. So in a given case of thickened LV wall, like Dr. Hardeep already explained, there are multiple possibilities which cross our mind. Is it CKD? Is it hypertension? Is it amyloid? Is it HCM? And those are the common things that come to our mind. And then we try to tease out. Nothing here except for markedly reduced tissue velocities and at least a grade 2 diastolic dysfunction. TR gradient elevated, acceleration time shortened, pulmonary hypertension, PA is dilated. So that has been the story for quite some time, it appears. RV function here looks okay. We proceed to a cardiac MRI. Appears to have some asymmetry in the wall thickening as far as the 4-chamber is concerned. And a similar thing is seen in the short axis view also. Some asymmetry is noted. And of course, the LV is dysfunctional too. So EF was 35%, RVEF was 33%. This is the TI scout image. So wherein we can see myocardial nulling before the LV cavity. So this is what we call as a reverse nulling pattern, which was seen in this particular case. So by now we are thinking that, okay, we thought it was something, but now we are narrowing down to HCM, amyloid. And there is some amount of the subendocardial enhancement also, which is seen with amyloid. However, there were some additional findings reported on the cardiac MRI, multiple enlarged mediastinal lymph nodes. The patient obviously had to go for a CRTD, and these were the enlarged lymph nodes which I have just described. So all the lymph nodes, lymphadenopathy is seen. So the next thing, the lymphadenopathy leads us to do a PET. Is it sarcoid or something like that that we are dealing with? And we find uptake, very heavy uptake seen in the LV, involving the septum, and towards the apex, it seems to be circumferential. The same thing seen in the axial views also. A endobronchial ultrasound biopsy or FNAC was done, and that only showed reactive lymphoid tissue. There was nothing suggestive of a granulomatous disease. Mycobacterium culture also was negative. The patient had again multiple shocks, had to undergo a VT ablation. We are still very eager to know what the diagnosis is. Like Dr. Hardeep showed, we were not lucky. There was nothing to suggest granuloma or amyloidosis on the endomyocardial biopsy. A genetic study had been done, and that showed myosin light chain 2 pathogenic variant for hypertrophic cardiomyopathy. How do we reconcile all the findings? You have inflamed myocardium with lymphadenopathy in this given patient with thickened walls. So what is the explanation for that? So this is a document which shows us that patients who were labeled as isolated cardiac sarcoidosis, a significant percentage, or at least 1/3 of them, turn out to have a genetic cardiomyopathy in the inflammatory phase. So that is the important take-home message here. And when we look at, it's not only the dilated phenotype that we are talking about, which is all this Lamin cardiomyopathy, which has a dilated or a non-dilated phenotype, but the hypertrophied phenotype, which is HCM, also can have inflammation, which can present as sarcoidosis. So this is from the University of Washington, myosin binding protein mutation. And we know that in genetic cardiomyopathies, there can be myocardial inflammation. I'll skip through this. This is a recent document where they proved therapy with immunomodulatory drugs also. So I just put it up there. I'll skip through all that. And another university also showed, this is a very recent paper, showed about genetic cardiomyopathies with PET positivity. Again, not just limiting to those causing dilated cardiomyopathy, but even those with hypertrophic, the MYH7 variant also can have, which means HCM variants also can have inflammation. That is the point I was trying to make. I'll skip through all this and try to conclude. Why mediastinal lymphadenopathy? This is something that we discovered in the process, wherein this particular patient, they studied 215 patients, where significant mediastinal lymphadenopathy was there, biopsy negative, and it was attributed to just heart failure. So the learning there was heart failure itself can cause mediastinal lymphadenopathy, and most commonly it is this 4R station, which was enlarged in our patient also, and the biopsy did not show anything. Learning points: not all myocardial uptake is sarcoid, especially in this age where we are trying to rule out sarcoid and TB. Genetic cardiomyopathies can have phases of inflammation, traditionally thought to be only dilated, but now we know it is hypertrophic also. Subendocardial LG in HCM has a worse prognosis, and mediastinal lymphadenopathy can occur in heart failure. Thank you. Thank you for your attention.
I think it was an excellent case, once again showing that you cannot be dogmatic about any finding, and you have to keep the clinical context in mind and look at all the options. So I think we move to the next presentation now. It is by Dr. Satish Govind, an interesting case of structural heart intervention, Lampoon procedure.
With the advent of transcatheter, so this TMR is now becoming more and more implemented. And Lampoon is one spin-off from this. So just to focus on that. So just a brief look at the TMRs themselves. So what does TMR mean? So you have the transcatheter mitral valve replacement here. And it can start with the native mitral valve, and especially when they're not suitable for surgical repair or replacement, this is less done. But more often it is done with a valve-in-valve, and then less often in the valve-in-ring, and even more or less is when there is mitral annular calcification, which is called as MAC. But there's always this risk of LVOT obstruction whenever this valve is put in. So there are two types of obstruction. So one is called as a fixed obstruction, where you have an existing mitral leaflet. When the new valve is put in, the existing mitral leaflet gets pushed towards the LVOT and narrows it, and this is called as a neo LVOT. So how good or how bad is a neo LVOT? For this, the CT is done, and typical risk factors for this is when you have a very acute aortomitral angle or a small LV or a very sort of thick basal septum, and when you have a cutoff of less than 200, that means that there is risk of LVOT obstruction. And this is where Lampoon sort of sets in, because it needs to create an additional LVOT over there. And then you have the dynamic obstruction. So this is typically like the hypertrophic obstructive cardiomyopathy, where you have the SAM, and when you have these long antemitral leaflets. Now, the actual, the acronym, the Lampoon is, the idea is to lacerate the antemitral leaflet and to prevent the outflow obstruction. So that is the acronym for that. And you have two types. So from the tip of the leaflet, you go to the base, or it can be from base of the leaflet to the tip. And this mimics the surgical resection of the antemitral leaflet. Now, our patient is an elderly lady, very frail and symptomatic. She had a biovalve, and she had significant stenosis with some regurgitation and high risk for surgery, and the surgeons were very hesitant because of her frailty. They were not keen on it, and so TMVR was considered, and she underwent CT. And this is a CT, and you have the CT where they do all these sort of calculations, and then you come up with the new LVOT. So if it is less than sort of 200, so then you start to look at the Lampoon itself, and you try to mimic that. And again, the lower image tells you how the posts are. So any bioprosthetic valve, those of you who are doing 3D, you can always see in three posts. They're called as the three pillars of posts, whatever it is. So they have to be sort of exactly on either side of the LVOT. Otherwise, if it's in the middle, then the Lampoon cannot be done. So in this case, slightly sort of towards the LVOT, but still acceptable. So these are images of the echo. So you have a very bad bioprosthetic valve, and there is some amount of AR over there. And on the 3D, you can see that it is both seen on the LV side as well as the LA side. So the LV side is also crucially important here. So you need to get good images. And those three dots are what are called as posts. And the one above is the LVOT. And the arrow that is pointing is the leaflet that needs to be cut. So that is the one. And these are not so great images because we did it at another center with a low sort of end echo machine. And the valve per se was not good. So you can see that all the gradients, everything was all over the place. And we sort of took a comparison baseline LVOT gradient. And then the puncture was made. So the puncture, again, for these TMVRs are low punctures. So the puncture was done without any event. And then the focus then shifted to the left atrial side. And you can see that there is this catheter which is sort of hugging the leaflet which we wanted to lacerate. And then again, the catheter is sort of gradually maneuvered towards the center of the catheter. It's very important that we need to get exactly at that apex, the tip of it. Going on either side can make it eccentric, and that will be a suboptimal outcome. So you can see that it's going back and forth, and finally we were able to locate it, and then the laceration was done with an electrical energy, and you can see those bubbles that are sort of being seen over there. And then you also look at it from both the sides. And this is how the, just an animation to show you how it looks and how the laceration is, is done. So the leaflets are prepared like this. And then it was done about 2-3 times, the laceration, and you can see that those bubbles tell you that the sort of the saline is going in and the electrical energy has passed. And what is of importance is that you start to see the MR which is starting to increase. So once the MR is there, then we know that the leaflet has been lacerated, and then we're absolutely sure about it. And then again, to sort of get an idea of where it is, so again we go back to the 3D, and here again that
the drawing over there shows you how the leaflet is cut. So just to explain to you what is on 3D and what the cartoon shows you. And then you can see that now there are 4 leaflets. So it's cut right in the center and it is going across. So 4 leaflets are there. And then very important to look at the aortic valve also, so that any damage to the aortic valve can cause the regurgitation AR, which was not very good. It can cause sudden problems over there. So that also needs to be looked into. And finally, the valve is put in, and then everything looks good. And then you can see that the leaflets are moving well, and then the flow is coming through the stents also, through the cells of the bioprosthetic valve, and the gradients were not much. So it was a successful one. So these are just images from the cath, which shows you how sort of the went through as far as the fluoro is concerned. So stepwise manner. And then these were the pressures which improved. So you have a pre and post of both the LVOT as well as the pH, the pulmonary artery pressures also. So all in all, it was a successful and uneventful procedure. So this is something which is becoming more and more sort of, as TMV has increased, the lampone is also going to play a big role, and we should be aware about this. Thank you.
Thank you, sir. The next case is by Dr. V. Amuthan, sir, on strain echocardiography for myocardial viability.
Good afternoon. This is a very interesting and controversial topic. Now, myocardial viability is determined by many ways: CMR, PET scan, and strain. Now, in strain, we see the contraction of the muscles, so that's very important. And conventional echocardiography does not do this. You cannot predict exactly, does not predict the viability. And 2D strain is a key predictor of left ventricular remodeling and prognosis after STEMI. 2D strain also shows a good correlation with the CMR in chronic ischemic heart disease. Now, these are some of the studies which show the diagnostic accuracy of strain imaging in predicting myocardial viability after STEMI. And LVEF and regional wall motion score index, GLS, and territorial strain. You can see territorial strain has the highest p-value, predictable. And this is the circulation 2020 and state of the art imaging for myocardial viability. They have stated specifically speckle tracking echocardiography with its ability to perform layer specific analysis has been shown to predict left ventricular functional recovery and remodeling after MI. So I will show 2 cases to illustrate this. Case 1 was a STEMI failed patient, thrombolized, delayed presentation with heart failure, reduced ejection fraction and LV clot. This patient in June 23 had STEMI, anterior MI. This is angio post thrombolysis, and he was suggested PCI immediately, but a co-patient died on the same day. So he went against medical advice, returned again in July 23, and they did PET scan, which showed non-viable myocardium and rejected for PCI by 2 centers. And this was this echo received in our center. You can see the large LV apical clot. Large LV apical clot, and see his pathetic condition, and this gross MR, and this ejection fraction is only 25%. This is the 3D echo, and then this is the LA Vmax was 71 ml, and the LA strain was only 3%. And see, he has this layer pattern, shows the anterior septum and anterior wall blue, then you have the pink and then the lighter grades of red, clearly indicating that the patient has a good chance for recovery after this PCI. So he was taken up for PCI. You can see The patient underwent angioplasty, and you can see this long stent was deployed. There was a totally blocked LAD in the middle AD. It was opened and long stent was placed. And this is the final result, which shows a very good flow post procedure. This was the echocardiogram after the procedure. The MR has reduced to a certain extent, and you can see the improvement in the territorial strain. The mid LV has started contracting. This is the basal, this is the mid LV, this is the apex. Mid LV has started contraction, even though the strain and ejection fraction improvement took much more time. This is first case. So this is before and this is after PCI, and patient has recovered well. And now this is another case. This was a embolic stroke with diabetes. This 40-year-old gentleman, government artist in Tirupur Baniyan factory, he collapsed and was taken to a neuro center where he had a left hemiplegia. Emergency echocardiogram was reported as dilated cardiomyopathy. Treatment was delayed 1 month in Tirupur and 1 month in Ramnad. And you can see the ECG and his condition. This is the triplane view. And 3D echo of the same patient shows the LV apical clot. And you can see here there is a grossly reduced strain pattern in the anterior septum, anterior wall compared to the mid LV segments. And there is a definitive abnormality in the RCA territory. RCA territory, you can see here. This is the inferior wall, infralateral wall, and this is his strain curves. And ejection fraction was only 23%. This patient again had a CTO of the LAD. You can see here LAD is totally blocked. And this is the D1. This is a very big vessel, had 90% narrowing. In addition, RCA was totally cut, mid RCA. So the patient underwent angioplasty for D1 as well as for RCA. So D1 had good results. You can see here the long stent was placed, and this is post procedure, and this is RCA. RCA, mid RCA was opened. You can see here balloon, and then stent was deployed, and this is the final result. You can see here final result. A good TIMI3 grade flow was achieved in RCA. You can see here the RCA. Good RCA results. Good result in RCA. This is the post procedure. The totally blue area in the RCA territory has gone now. And he had an improvement in ejection fraction. The GLS also improved. Ejection fraction 35. This is before PCI. This is after PCI. This is the LV clot has gone now. So carry home message is that all infarct related arteries should be opened. A speckle tracking echocardiography can predict functional recovery, and use of triple therapy including anticoagulants if there is a LV apical clot helps in solving LV clots post MI. Thank you.
Nice cases, sir. We'll move to the next presentation now by Sangeeta Porwal, an uncommon case of LA aneurysm.
Thank you, sir. Very much thankful and grateful to mainly Dr. Parashar sir and all the organizing committee to giving me this opportunity. So my case is of a 47-year-old woman presented to our hospital complaining of chest pain, shortness of breath, fever with chills and rigors, general weakness, palpitation and giddiness. Based on clinical examination, she was found to be suffering from right-sided pneumonitis and Plasmodium falciparum infection. However, ECG showed evidence of atrial tachycardia, disproportionate to her temperature and clinical illness, and hence she was subjected to echocardiography. That's her ECG showing RBVB with atrial tachycardia. So once the echo, you can see the left ventricle very much normal, nothing on the left side, aortic valve After colors, you can see just a minimal mitral regurgitation. Aortic short axis, and I needed an arrow actually. Okay, so in aortic short axis, the suspicion started here actually, because you could see something here. It was connected, there was flow in that, and it was connected to the left atrium. The apical four-chambered view, and you can see the left ventricle function is normal. I was trying to rule out whether this connection is from the left ventricle, because usually aneurysms are seen connected to the left ventricle, but this wasn't so. And you could easily see that this aneurysm which was seen, it was connected to the left atrium and at the LA appendage level. That's the appendage, and you can see that this was it was ballooning up of the LA appendage, and it was compressing the left ventricle. This is you can see the compression here, and it traveled along the posterior and the lateral wall of the left ventricle. There was blood flow to and fro from it. Mitral flow, the minimal mitral rigors, but that was. So after looking to all these findings, the patient was subjected to transesophageal echo. Just some different views I had taken to show that it is not connected to the left ventricle. And here you can see a very nice ballooned up LA appendage. But of course, we subjected the patient to transesophageal echo. Now, once the transesophageal echo, you can see here it is showing some compression. And that's the LA appendage aneurysm. Very clearly seen when we start seeing the LA appendage. Now you can see here, it had a wide neck. It was connected to the left atrium. There was free flow in that. Very clearly seen. Huge neck actually. I did a 3D echo also, 3D TE. Actually, I wanted the diameter of the neck, and the neck, it was a huge neck, but after measuring, it came to around 2 centimeters or so. Till 3 centimeters, you can actually do a percutaneous closure of this aneurysm. So the patient was subjected to CT, and now you can see a huge aneurysm here. And it is compressing the left ventricle as well. Just another view. So LA appendage aneurysm is an abnormal dilatation of the left atrial appendage. It can be congenital or acquired. Increased chances of thromboembolism and arrhythmias. Female preponderance is there. Mean age is 30. Transesophageal and cardiac MRI are investigations of choice. The treatment is surgical resection, 94% success, anticoagulation in case of thromboembolic events. An aneurysm of left atrium appendage is one of the rare but potentially hazardous heart diseases. The risk of lethal complication grows with its size. To date, about 150 cases of this defect have been described in the literature. So left atrial appendage aneurysm is a rare and dangerous heart pathology that requires immediate surgery to prevent relative complications. Left atrial appendage aneurysm is a rare cardiac anomaly that requires careful management to prevent complications such as arrhythmias and thromboembolic events. The most definitive treatment involves surgical resection, that is aneurysmectomy of the aneurysm. This typically involves removing the aneurysm part of the left lateral appendage. The aneurysm is removed and the base of the aneurysm is sutured. Most patients show significant improvement post-surgery, and it is considered the primary treatment method for symptomatic individuals. The method may be used to patients who are not good surgical candidates due to comorbidities. If the patient have these comorbidities, the patient can go for a device closure. So a left atrial appendage aneurysm is a rare and potentially life-threatening condition. During evaluation of a patient with palpitations or embolism, this rare entity has to be kept in mind. Thank you so much.
It was really a very nice case, a rare entity. I think because of paucity of time, we'll not have any questions and we close this session. A big round of applause for all the presenters. We had excellent cases by all our presenters.
Now we move on to our next session, which is back to basic clinical cardiology, including advances in cardiovascular therapeutics. So may I invite the chairpersons on stage for the session. Dr. Rakesh Gupta, Dr. Hansa Gupta, Dr. Neeraj Agrawal, and Dr. Amuthan, please. So the first topic in this session is a very important topic, and Dr. Shantanu Sengupta would be presenting the talk. The topic of discussion is myocardial work. What is it, when and how? So 10 minutes for each of the presenters. Please stick to the time, everyone.
Yeah, thank you so much. Can I have the slides? Yeah, so before I move on, let me all invite you to Cochin. That's the Echo India 2025 meeting, 18 to 21st September. Now, this is a topic of myocardial work index, entity which is being used for understanding the left ventricular myocardial performance. I'm just trying to make it very simple so that one of the vendors has it, and so that you guys can start using it. So pressure volume analysis is one of the most comprehensive way to describe cardiac function, which gives understanding of cardiac mechanics and energetics. Routinely, the pressure volume analysis is done invasively and it is time consuming, so it cannot be done. We know that strain analysis by global strain can identify ejection fraction and evaluate subclinical LV dysfunction. But speckle tracking imaging for LVGLS is sensitive to afterload, leading to its limitations in accuracy because it is also load dependent. And it doesn't undertake afterload into consideration. So we have now this entity called myocardial work index, which I will be focusing on. So what does it do? It basically incorporates both LVGLS and the blood pressure measurement non-invasively, which has a reflection on the pressure strain loop, and it can evaluate cardiac performance. So what exactly is myocardial work index? It is nothing but a differentiation of strain curve, which when we multiply multiplying it with instantaneous left ventricular pressure. And this product is a measure of instantaneous cardiac power, which is integrated over a period of time. And the time it takes is nothing but from mitral valve closure to mitral valve opening. and it gives you an understanding about the segmental and global myocardial work. This estimates of work uses pressure as a surrogate of force, gives its relative dimension, and it doesn't incorporate the curvature of the LV, left ventricle. So that is an advantage. If the left ventricle is dilating in any of the ways, it doesn't get, take into consideration. So it is nothing but a strain multiplied by the instantaneous left ventricular pressure. It doesn't take into account the LV diastolic pressure. So remember this. So how do you do it? We start with the apical 4-chamber, 3-chamber and 2-chamber view, get the strain, and a systolic blood pressure is taken, and it gives you some nice colorful data, which is nothing but a myocardial work index. So what exactly is it? So this is a loop, and as I told, it incorporates the time of mitral valve opening to mitral valve closure. And on x-axis, there is strain analysis, and on the y-axis, there is the systolic LV pressure. So normal pressure strain loop looks like this. So if you have the, if the curve, this curve moves here, the strains are going down, but the pressures are maintained. So as I was looking at Dr. Amuthan's work, he just presented 2 cases, and I will mention. And this is what happens. These are the different ways you can get an understanding about how the strain and the LV pressures can correlate. So there are a couple of indices, and broadly it is nothing but the global work index, constructive work, the wasted work, and the efficiency. So the global work index is nothing but the work done by the left ventricle during mechanical systole, that is from mitral valve closure to mitral valve opening, and includes the isovolumic relaxation time. While the wasted work is the work which is performed during systole, that is not productive. It includes lengthening during systole and shortening during IVR. And there is a work concept called global work efficiency, which is nothing but the global constructive work divided by the summation of these two. And it is always in the form of in percentage. So there are a lot of things, but remember that we have to only remember these 2 entities. The normal global work index is something around 1900. And this is a number we should start remembering. And the wasted work is something around 80. And the efficiency is mostly always more than 92. Now, this data has come up from the European studies. Unfortunately, we don't have the data from India, and maybe I think we should try to work on this. So the global work index is around 1900, and the efficiency is almost around 95% plus. So let me show you an example. This is the data of a normal person. So this was a global work, again a strain volume work, and you get again a bullseye view. The value is something around 1900. But if you have a patient who has a cardiomyopathy, the graph changes. It turns mostly to the right, and you start getting values which are lesser than 1900. And so global work index in this patient was around 1200. So what does it signify? It signifies, so this is another information. So there is something called wasted work. So normally the curves should be like this. But if you start looking at some graphs which are like this, that means that the LV is contracting, but there is a lot of wasted work. And let me tell you, Dr. Amuthan was not focusing on the myocardial work. He told that the strains were improved after the angioplasty in that patient, but you can see that there was some amount of wasted work. That's why the LV ejection fraction and the strain were not improving. So there is another spectrum. So normal is, as I said, that global work index is around 1900. You can have a lower global work index as seen in cardiomyopathy, but there's another entity. If the global work index is higher, it indicates adverse remodeling. And this is classically seen in patients who are coming with hypertensive heart failure. These are the patients who come up with heart failure with elevated ejection fraction. So there is an entity where the EF is more than 65%. They subsequently will fail. They will go here. they will go down. So be very careful in looking at these values. So you can tell the patients that if you have anything value more than 2500, that heart is going to fail if we don't treat the condition precipitating it. And this is some work which we did on the recreational athletes and gave us few insights. So we saw this was the pre-marathon level. These were the patients who were going for the marathon. Our baseline, the global work index was around 2000, which was normal. But once we looked at a group of patients, we saw that there was two type of patients, two type of runners. One group of runners maintained, and the other group of runners had an elevated global work index during the run, and then they reverted back. And it has been seen that runners who are professional athletes, their ejection fraction may go down. They have dilated LVs. They have strains which are going down. But is it pathological? The answer is no. So significant changes occur during pre and post marathon values. There can be rise in BNP levels. There can be rise in LA volume. There can be overall reduction in LV strain. However, normal or increased myocardial work compensates for this lower GLS or EF seen in these patients. So their work efficiency is very high. Their wasted work is low in spite of their strains going down, in spite of having the BNP elevated. So they are basically the other extreme of the patients. And there is a lot of work which has also now come up about myocardial work index in aortic stenosis. This is Dr. Renuka Jain's work, where she has looked at pre-tower and post-tower patients. There's some work I'm not going to detail. So understanding that in aortic stenosis also there is a change in the afterload, so myocardial work index can have prognosticate importance. Some more work which was seen in COVID population, and in this group of patients there was a correlation that high myocardial work index was associated with lower hospital mortality. So it tells you about the efficiency of the heart thing. The maximum work has been useful in patients who are going for CRT, and this is the work which initially came from Russell, and then subsequently more work has come in JACE, that are both these indices are associated with positive response to CRT. This global work index at baseline significantly is higher in CRT responder as compared to non-responders. So there is a suggestion that
Dr. Shantanu, please.
Yeah, myocardial work index should be done. Now let me also end with one last slide, that you can also look at right ventricular work index. This is a proof of concept which has been done looking at the RV efficiency. The problem is limitations. There is only single vendor which is there, but the potential applications can be helpful for selection of patients of CRT. Any condition where the afterload is changing, it helps in understanding LV contractility, and it identifies overloaded myocardium which may progress to subsequent cardiac failure. So myocardial work index is a non-invasive way which broadens the current available techniques for understanding performance. In principle, it is superior to EF and strain imaging as it incorporates LV afterload. And adjustment to loading conditions help in implementations of this clinical hemodynamic concept, which is useful in daily assessment. Thank you so much.
Thank you, Dr. Shantanu, for your excellent summing up of myocardial work. Next, we will have CKM, heart failure with preserved ejection fraction, clinical echo therapeutics. Now, the previous case which he was mentioning, that in our case there was no improvement. The first improvement after PCI comes in the territorial strain. After 1 year, you have improvement in myocardial work. I will project that in forthcoming conference. Thank you.
Mr. Chairman, sir, fellow colleagues, ladies and gentlemen, it's really a great pleasure and honor indeed for me to be here this afternoon. The topic given to me is CKMS and HFpEF, Clinical Echo Therapeutic Navigation. I think my main agenda presentation is cardiometabolic problems are rising steeply in our country. The percentage is up to tune of 50%, less than 50, 65% over the age of 65. Jack, this is from 2025. Morbidity and mortality is very, very high, and various chemicals are available. We are going to discuss very soon. What is CKMS? It reflects amongst the metabolic risk factors with CKD and CVS with profound impact on morbidity and mortality. This is a very important slide from AHA focusing on stage 0. There is no risk factor. It's primordial and pre-primordial. Prevention, stage 1, excessive dysfunctional adipose tissue. Stage 2, metabolic risk factors known to all of you. While stage 3, what we do is subclinical CVD and CKM syndrome. Stage 4, where it is totally overt and we see there is organ damage. And this is what I want to say, because obesity is really rising rampant in our country. And you see the data, Kerala, Delhi, Tamil Nadu, and Punjab, and the rate of obesity is 5.21. HepF, you all know, is very, very common entity in these patients. And the ejection fraction more than 50%. The prevalence rate is also very well known to all of you, is almost 10% after the age of 65, with number of comorbidities. This is the data I'm showing. One of my slides I published in Indian Heart Journal in 2007, where I've shown central obesity is a very powerful predictor of CVD to a tune of 86%. And see the data. The prevalence is common in females. And we see here the hemodynamics, the systemic volume overload and acute diastolic dysfunction are responsible, besides various factors like ventricular dysfunction, atrial, autonomic, vascular, hypertension, and renal dysfunction are very, very important factor. This is from Banker et al. He has also shown very clearly CAD, diabetes, and obesity are the common factors. And we see here it is a stiff LA, stiff LV, pulmonary artery, and pulmonary vascular, which are responsible for the triple jeopardy. And see the data. The real mechanism pathway is inflammatory, neurohormonal stimulation, and we see coagulation cascading and increase leptin and decrease adenopectin, which are responsible, and see various metabolic factors, vascular pathology. All the vessels are affected, micro, macro, or middle size, and see the outcome. Outcome is very, very clearly known to all of us. And what is the clinical outcome? Highest morbidity, undiagnosed, misdiagnosed with normal coronaries. And see the data of CHARM study and paradigm study are very clear, showing increased morbidity and mortality. And even the terminal heart failure registry has also shown the same. Readmission rate is high and the mortality is very, very high. How do we diagnose? We all know it. In our labs, we take LAVI more than 34 ml per meter square, E by prime ratio, concentric LVH, and anti-proBNP of more than 220 in the patients with sinus rhythm, and more than 660 with atrial fibrillation. And of course, the American criteria is BMI and atrial fibrillation and age always into consider, besides the various workups mentioned here. This is what I do in my lab. And of course, a lot of focus was there today on stress diastology. This also is subject to our patient when we are in doubt. And this is all very clear that LA enlargement, concentric LVH, LV mass are very important. LAVI is very important. This was focused by Dr. Amuthan this morning, that LAVI more than 34 per meter square has got a very, very poor prognosis so far as the recurrence of AF and resistant AF, and we see increased LAVI with poor survival. This is the latest classification by Scott Solomon, showing the atriopathy, left atriopathy. Stage 1, stage 2 are reversible, while stage 3 and stage 4 are not reversible because of fibrosis. This was also covered by Dr. Amuthan. LA pressure. LA pressure, very, very important during rest and at the exercise. Similarly, LA stiffness, increased hospitalization and mortality. LA strain is very, very strong relationship. The lower panel I've shown, the very, very strong relationship when the reduced LA strain responsible for number of thromboembolic episodes and poor increased morbidity and mortality. LA remodeling is very well known to all of you. Increased LAVI and LAEF reduction may cause persistent, resistant atrial fibrillation not responding to LA ablation therapy. And see here, the white areas which are seeing is the increased LA fibrosis by CMR, increased AF recurrence. Ladies and gentlemen, the message is very clear. Fibrosis is dominant in the LA cardiomyopathy. Decreased LA strain, poor increased mortality and morbidity. LV, GLS may predict subclinical LVD in atrial fibrillation. Now, therapeutics. Very clear, there are no outcome benefits till 2019. Paragon, TopCat, iPreserve, PEPS, CHF, and CHARM study have shown no benefits at all. SGL2, which opened a revolution, a reduction of MACE rate, hospitalization, and renal protection. And see the data. Soloist, Emperor preserved, Imperial preserved, and deliver heart failure trial. Functional benefit are seen in this slide. And this is the most landmark trial with almost 6,000 patients over 26.2 months. And we can see the primary composite endpoints as well as secondary endpoints marked reduction, irrespective of ejection fraction or NT-proBNP or diabetes. And see the renal protection, which was shown here. The mortality benefits are seen only with EMPA and DAPA and not with ARNI at all. See the data. 5 study of meta-analysis have shown EMPA and DAPA are most powerful. And we can see here the composite endpoints, primary composite endpoints, worsening, hospitalization, CV death, and all-cause mortality favors dapagliflozin, empagliflozin. And we can see here 23% relative risk reduction in the various meta-analysis data of 5 studies, DAPA-HF, DELIVER, Emperor Preserved, Emperor Reduced, and Soloist. What is the guideline says? So far as empagliflozin or DAPA is concerned, 1A, so far as HFpEF is there. And we, of course, started the loop diuretics, MRA, ARNI, and ARB is very well known to you. The statement given by Eugene Bronwald, SGL2 is a statin of 21st century. It's true. He also said GLP-1 receptor agonist is going to be future and the present. And see the data. In the European Heart Journal, very clearly mentioned Ozempic, available in India as Rybelsus, or Mounjaro is what you call tirzepatide. They are the future, and the whole pillar is all completely changed. And see the data from circulation, very clearly mentioned that these drugs like SGLT inhibitor and GLP-1 receptor agonist, which will be spoken by Samir very soon, a reduction for mortality and morbidity. And we have published 3 books on heart failure, huge data to support what I'm saying. To conclude, ladies and gentlemen, health of millions is at stake with obesity and CKMS and HFpEF in India. Clinical echo metabolic therapeutic navigation is a must in all the patients. And SGL2 is the first iconic miracle molecule of the century in HFpEF. And now, with the help of GLP-1 receptor agonists and Fenenon, all mortality benefits are seen. HFpEF and CKMS are preventable, regressible, and reversible. What's the learning from take-home message? Meticulous protocolized treatment of HFpEF is the need of the hour. It's rampant. SGL2, semaglutide, and tirzepatide in obesity with HFpEF is the future and game changer. My tributes to Anka, Butler, Nassif, Bhatt, Abraham, Solomon, and McMurray. We see here very clearly on the top SGL2 and GLP-1 receptor agonist. I must appeal to all of you, we must take a pledge today. We must treat all the patients of HFpEF with obesity and CKMS very seriously if you want to improve. This is just to show that the CKM health is an expression of total health. Our blood flow in all the patients is up to a rate of 4 nice saying from the Tibetan proverb, if you really want to live long, eat half, walk double, and laugh triple, and love triple. Thank you very much for your time.
Thank you, Dr. Sir. Excellent presentation as usual. And thank you very much for sparing 2 minutes to us. God bless you. And let me call a legends of legend, Dr. Ravi Kasliwal, on a dais. My elder brother, I always say that, to deal with this next topic. And this topic is Dr. Ravi Kasliwal is the main pillar of management of heart failure with reduced ejection fraction.
Good afternoon, Mr. Chairman, ladies and gentlemen. Heart failure with reduced ejection fraction, which is the main pillar of management. This is what my colleagues have asked me to speak on. Let us see, what is a pillar? One who strongly supports a work or cause. So let me see. Let me go through with you a case which will demonstrate, and then you can decide what was the pillar in all this. 39 years old male, progressively increasing dyspnea and exertion for 2 months, admitted with NYHA class 4 for dyspnea, non-diabetic, not a hypertensive, no family history of sudden cardiac death. Vitals, you can see the patient has tachycardia, pulse rate is high, respiratory rate is high, chest auscultation, basal crackles up to 1/3. He is in gross congestive heart failure, narrow QRS, sinus tachycardia. And this is the echo. If you can see, anybody's guess, this is between 10% to 30% of ejection fraction. But that's not the only thing. Let's see. So the first echo done in the emergency room shows dilated cardiomyopathy-like situation. And the 2D echo, see, we are not going into huge things. This is just a 2.5 megahertz catheter transducer applied to the patient chest, gives you huge information. That is the basis today. Poorly contracting left ventricle, mitral regurgitation, which is moderate. There is acceleration slope is acute, and the A wave has merged with the E wave. The global longitudinal strain -6. This is what the patient presents with. But look at the hemodynamics. This is what we should emphasize when we do an echo. It's not just about pictures of poorly contracting left ventricle, which it is, but if you look at it, you are getting tricuspid valve, which is moderate tricuspid regurgitation, and the PSP is elevated. The inferior vena cava is dilated, and you are getting the right heart filling pressure. So just in the first 20 minutes of the patient's arrival, you have got hemodynamics to guide your therapy. Should we give fluid? Should we give diuretic? Should we give vasodilators? Should we put in an AIBP? These are important considerations. When you are asking me that which is the biggest pillar in a condition which has more prevalence than most cancers in the country, then you've got to be sure of what you're dealing with. So you have got poor contraction, you have got tricuspid regurgitation, you have got PSP, which is elevated, you have got increased LVEDP, as well as you have got increased left atrial mean pressure. So salient features of echo, you see a dilated left ventricle, 6.4, about 5.9. Dilated LA, again, could be a forerunner of a AFib. LVEF, which is 15%. Global longitudinal strain, which is -6. Moderate MR. Restrictive MIP, PSP 43%. And so just look at the information that you're getting from 10 minutes of spending with the patient, along with clinical examination, ECG, and a chest X-ray. Course in the hospital, Lasix was given, anti-G drip, the usual stuff. Increased ivabradine, started bolus furosemide. 4th day, clinically stable. This is classic picture of ADHF, and as has been shown, the 4 pillars of heart failure have to be initiated at some stage, and you have to decide that, which consists of ARNI, a beta blocker, MRA, and an SGLT2 inhibitors. As you know, all of these are powerful drugs, but the power is in the team. That when you slowly but steadily, when you apply all these, the outcomes are the best. So initiate, optimize, reassess. This is the mantra with which you will go, and then you have to decide which was the most important of these. Follow-up visit 3 months after discharge, and it takes you that much time to actually get everything on board. Asymptomatic, walking in house, in sinus rhythm, clinically stable, NIHA class 2 now, beta blocker, ARNI, dapagliflozin, once daily epinephrine, all is on board. Just last month, I was going through the journal of the American Society of Echocardiography, and I came across this amazing article, dapagliflozin effects on left ventricular remodeling. Do we even consider remodeling? Mostly we don't. We're just looking at ejection fraction. But remodeling can take away anybody's life. Dapagliflozin effects on left ventricular remodeling and filling pressures in left heart failure, with reduced ejection fraction, HFrEF. Dapagliflozin therapy was associated with positive LV reverse remodeling. Estimated LV filling pressures improved. LVRR and filling pressure improvement reflected by anti-proBNP reduction. Echocardiographic improvements were associated with better outcomes. So just see, the real hero here is somebody who understands these things and applies it on a day-to-day basis. The drugs are there, but when to give it, what are you expecting out of it, only this instrument will tell you. correctly applied. 2D echo after 6 months, you can see the heart function is improving some. You can clearly see the mitral E by A, they are not fused anymore, tachycardia, and the steep slope of the mitral inflow tract is no longer there. Yet, he has some way to go. Sacubitril valsartan treatment increases LVEF. That's what, of course, we are looking at. Significantly within 6 months in patients who were previously receiving ACE and ARB for 9 months. One of the biggest things that happens to these patients, which is heart-wrenching for the patient and to you as well, that the patient went home pretty well and yet came back for a rehospitalization. So here, changes in LVEF occur over some period of time. So you have to be watchful. So in 6 months' time, you have seen ejection fraction has improved. Beneficial reverse cardiac remodeling occurred not only with dapagliflozin but also with sacubitril valsartan, has been demonstrated in multiple studies. What do you see? Shape and function of the valve becomes better. MR decreases. Many of these people are taken away from the transplant list. LV diastolic function improves. Many a times we are just concentrating on ejection fraction, which is of course important, but not the only thing. So LV systolic function improves, and diastolic volumes we should be concerned about improves. LV diastolic, systolic volume decreases, MR decreases, LV diastolic function improves. These are the things which only a person who understands the very basis of what JGV, McMurray and other people have done will take the patient to the next horizon. Otherwise, these people will come back. So 2D echo after 1 year, and you can see that it's nicely resolved. Patient is doing full work, and at 1 year, so these things will take time. So just as COVID has taught us that telemedicine has a value, well, it definitely has in patients of reduced ejection fraction. 1 year follow-up, symptomatically better, NYHA1, same medications continued, VO2 max improved, LVEF improved, and very importantly, reverse remodeling. The LV and diastolic dimension and LV systolic dimension all decreased. And just last week, Jack came out with this article that the sooner you apply the 4 pillars of therapy to your patient, the greater is the benefit. If you look at the last one, see absolute risk difference when you apply quadruple therapy, ARNI, BB, MRA, SGLT2I, you can see absolute risk difference of 24.8. Now you ask me, what is the most important or the single thing which is most responsible for this? I can only say that an astute clinical cardiologist who has knowledge of present-day echocardiography, and that's important, is truly the pillar that plays a key role in patients with heart failure for diagnosis, very importantly, treatment planning, again, and monitoring. See how the deacceleration slope improves. What is the E by E prime ratios, the LA volumes. And he is the person who's actually, as the question asked was, what is the one thing that improves, the most important thing in HFrEF? I think he's the guy who's most important in making HFrEF work. So thank you, Mr. Chairman. One team, one goal, every life priceless. Thank you very much.
Thank you, sir. Thank you so much. So I now take the privilege to invite the eagle-eyed echocardiographer, Dr. Sameer Srivastav. He has been a mentor to me as well, and so it's a proud privilege to call him on the stage. Sir, all yours. He'll be talking on the current status of semaglutide and obesity.
Thank you, Hansa. Hansa, you're looking very nice
today. Start your talk. Are you taking semaglutide nowadays?
Sorry?
Are you taking it?
No, I am not. Hansa, you're looking very nice today. उसको घंटी वाले को बोल देना रुक के रहेगा. And I need the pointer, please. Okay, good evening and good afternoon to you all. Obesity, this is what the title. I have used my extra constitutional rights to write a visit into the disaster. Now, if you look at this, there are several cardiovascular benefits and there are new weight loss therapies which are available. This is 1991. If you look at the orange states, these are the states which have got population greater than 15% which were obese. This was 1991. And less than a decade, this was the status of America. And mind you, the populations which were lesser than 10% did not exist in any of the states. Now, where did it land up with? This was the time when America had almost thought that they had won the war on cardiovascular diseases. The acute MIs were becoming lesser, the people were hypertensive, were getting lesser. But this progressive increase in obesity was thing which was concerning. Why so? Because if you look at these comorbidities amongst obese patients, so these were the three only comorbidities which they were considering: hypertension, elevated cholesterol, and diabetes. They didn't consider NASH, they didn't consider PCOD, they didn't consider psychosomatic disorders, they didn't consider anything except these three. And look at the numbers without comorbidities. It was only 1/3 or lesser than a 1/3 population which didn't have comorbidities. So in any terms like diabetes, hypertension, or elevated cholesterol, one or the other or all three of them contributed in greater than 70% or thereabout. Now they had to find out which is the cutoff. So this data came out not from doctors, not from healthcare professionals, not from nurses, but it came out from insurance companies. And they cut off that the low risk was anything lesser than 25 BMI and high risk continued to be more than 30. It's a little bit of a difference for South Asian populations. I think it would be somewhere around 24 here and somewhere around 28 or 29 for Indian population, because we are a very bad population as far as coronary artery disease is concerned. Now, this is a positive correlation. In statistics, easiest thing to produce is a positive correlation. All my patients who came with acute heart attack were wearing trousers. This is a positive correlation, 100%. But does it mean that people who came without wearing trousers also had a heart attack? So you had to prove that there was a negative correlation, and this is where the data came out from. The intentional weight loss reduction translated into 20% cardiovascular mortality benefit for all-cause mortality. Not only that, cardiovascular disease mortality, cancer-related mortality, obesity-related mortality, and diabetes-related mortality all fell. Another advantage was that when you lost your weight by about 5 to 10% in obese individuals, there was an improved glycemic control, reduced blood pressure, and improved lipid profile. This is, I have already talked about it. The mortality fell down to 20% by total. Blood pressure fell to about 10 millimeters of mercury in systolic and 20 millimeters of mercury in diastolic. Newly diagnosed type 2 diabetes fell by about 50% or thereabout. And there was a significant improvement in all the sorts of lipids. Started the era for pharmacotherapy. When they had data of pharmacotherapy versus behavioral therapy alone, when you combine pharmacotherapy with behavioral therapy, the benefits were much better. So came the concept that you had to combine the two diseases, diabetes and obesity, and then came this new term called diabesity. Now, diabesity is the term for diabetes occurring in context of obesity. Sometimes it is referred as obesity-dependent diabetes, and recently it has been recognized as a major public health problem. Why does it happen? Because with obesity, there is an insulin resistance which happens, and with increasing insulin resistance, there are all the problems of development of diabetes. Now comes the therapeutic part of it. Lifestyle modification continues to remain the cornerstone. And of all the drugs available till now, probably the first comes to mind is GLP-1 receptor agonist. These work by stimulation of insulin secretion, by suppression of glucagon production. Furthermore, they modulate receptors in the gut to delay gastric emptying, as well as neurons involved in appetite regulation. So it suppresses your appetite also, and these mechanisms lead to reduced appetite and improved feeling of satiety, hence contributing to weight loss. They should be taken as the first line of therapy for consideration in diabetes, with remarkable benefits on body weight while also resulting in improved glycemic control. Now, this is the data from several, the ones which are available in the country are liraglutide and semaglutide. Semaglutide injectable is still not available. Oral is, but if you look at across the board, with semaglutide, probably there is the most significant and most impressive weight loss, somewhere around 3 to 4.5 kgs, and over a period of maybe 6 months or so. This is what it is. If you look at, so native human beings also produce GLP-1 receptor agonists. They produce, but what is the problem? The problem is that it gets degenerated very quickly, and there is a very short half-life to it. So this is how it works: decreases appetite and improves satiety, stimulates insulin resistance, insulin release, reduces production of glucagon, reduced glycogenolysis, decreases gluconeogenesis, and delays gastric emptying, and portion size is reduced. This is where it is. You have semaglutide at a dose of 2.4, and this was significantly better as far as reducing incidence of death from cardiovascular causes was concerned. So this was primarily only in a diabetic population. So with diabetes population, we know that it has significant advantages, but unfortunately, GLP-1 receptor agonists cannot survive in the natural form. So they had to combine it with something. So this is what the snack was. And what it did was that 94% of the native GLPs were maintained, and 6% here and there tweaking they did, and that increased the lifespan of GLP-1 receptor agonists. So these are the oral semaglutide, shows greater reduction of up to 2.6 HbA1c from baseline. These are several trials. Not only does the HbA1c reduce, it also reduces your weight loss. So this is clinically relevant weight loss on oral semaglutide. And if you look at this, again, the significant benefit was close to about 5 kgs of weight, which becomes better. Now, not only that, you ask the patient to have sumptuous lunch, which is known as ad libitum lunch. And when you gave semaglutide versus placebo, there was a significant reduction of calorie advantage which they drew. Not only that, there was a better satiety which people had. So they ate lesser, their energy extraction was lesser, and they felt more satisfied as far as their food is concerned. Not only that, there was a significant reduction of central or waist circumference, which again is an independent risk marker for coronary artery disease. So there was a distinct change of HbA1c, distinct change of body weight. Again, when you were targeting HbA1c, when it came to oral versus lira, oral semaglutide 14 milligrams was significantly better, and adverse efforts were significantly higher with semaglutide because it has to be taken in some certain manner, otherwise GI upset is more. When it comes to change of body weight, worst is insulin and dulaglutide, where there is an increase of weight, but there is a significant change in HbA1c, as we have discussed in different studies. So what about other medication? Do other medications survive test of time, or they're better, or they're worse off? What if people cannot take GLP-1 receptor agonists? SGLT2 inhibitor is a good option. This has been shown in research in last many trials that it reduces weight, and the weight loss is somewhere around 1 to 2.5 kgs over a period of time. So these are different data from all the SGLT2 inhibitors. DAPA is available, EMPA is available, rest of the things. Canagliflozin is available, but not so much so. And there is a significant weight loss which can happen over a period of 4.5 years in dapagliflozin to about 24 weeks, which was done in DAPA. Then there are medical devices for weight loss. Very interesting. People have tried gastric banding, limited long-term efficacy and high rate of complication. minimally invasive medical devices. Gastric balloons have been tried, vagus nerve stimulators have been tried, gastric aspiration has been tried, oral hydrogel have been tried, but unfortunately there is no consistent benefit over a period of time.
Thank you, Samir.
Managing obesity, last slide, sir. You are also very handsome. Managing obesity, surgery, as far as efficacy for surgery is concerned, 80% of patients remain at least 10% below preoperative body weight for 10 years post-surgery. And this is my last slide. And thank you very much for patient listening and allowing me to speak. That obesity is the easiest diagnosis to make. A person walking on the street can make a diagnosis of obesity, but probably the most difficult to treat. Thank you very much for your patience.
Thank you, Samir. God bless you. Thank you very much. And take-home message is reduce weight, gain life or age. Let's move on to one of the very interesting topic from none other than Dr. J.P.S. Sahni. He's a professor of cardiology and chairman of cardiology at Sir Gangaram Hospital, which is a postgraduate teaching hospital in Delhi. And in cardiology, they are providing DNB cardiology degrees under the chairmanship of Professor J.P.S. Sahni. And another very interesting molecule is inclisiran. Yours, time.
Okay, thank you. Thanks, Dr. Respected Chairperson, dear friends. Thanks for invitation. I will be discussing in next few minutes about the inclisiran, a molecule recently launched in our country, their indications, safety, efficacy, and outcome. We have published our guideline for lipid management last year, and the most commonly used guideline, European guideline of lipid disorder, has strongly recommended to reduce the LDL cholesterol to below 55 for very high-risk population, those who are suffering from atherosclerotic cardiovascular disease, and extremely high-risk population, those who are getting recurrent events, and the patients which we saw in our country, very highly prevalent were the patient of young heart attack patient with dual hereditary risk factors like familial hypercholesterolemia and elevated LPA to keep the LDL below 40 or 30. So this is a challenge to reach the goal, and this is what we have experienced. And now we have also evidence that in a setting of acute coronary syndrome, we have to stabilize the plaque within 3 months. Otherwise, there is a chance of recurrent coronary events by almost 10%. In our guideline, we suggested that we should hit hard and hit early and start with combination treatment of rosuvastatin 40 or 80 atorva along with ezetimibe in the beginning for every ACS patient, and wait for 4 weeks and look at the LDL. If it is still above 55, add bempedoic acid and wait for another 4 weeks. If the levels are still high, we have to use PCSK9 inhibitor or inclisiran. So at 8 weeks, we have to use this group of drug. Probably the requirement may be in 5 to 10% of patients, but it is required. And by 3 months, almost every patient, the stability of the plaque, which is the most important cause by which we can prevent recurrent coronary events. So this is the role of the drug which we have. And unfortunately, the data from the Da Vinci trial which came from the Europe, and now we have our small data from our country that 575 patients of ACS at the end of 1 year, only 20% of patients were able to reach below 55. And our data, single center data from Gangaram Hospital on 3,700 patients, starting with high dose of statin, but at the end of 1 year, it was just 30%. We started looking into the factor, and it is not the side effect as the common cause, not the media, not the cost. The cause, what we found was that the physician, they reduce the dose for the reason unknown, and they never repeat their lipid profile after that. So when we look into this population, at the end of 1 year, those who are not on high dose of statin, 90% of them were above 55. So that shows the challenge which we see in adherence of the drug. And one of the important reasons for adherence is the number of pills, which we know that you have to take 365, or if you add ezetimibe combination pill, maybe 365. But when we have small number of population, those who need injectable PCSK9 inhibitor, the monoclonal antibody will require 26 injections, and whereas inclisiran will require only 2 injections per year. So we also have data now from our own colleague that shows that the like variability of blood pressure and diabetes, the variability of the LDL is also an important factor. If you keep on changing the drug or reduce the drug, the LDL level goes up, then the chances of having future cardiovascular events are very, very high. Mortality goes up by even 23%. So those two challenges are there, which we see in clinical practice. To overcome that, the inclisiran has come as a rescue to us. So it is the first and only LDL lowering single interfering RNA therapy that selectively targets the liver by two double-stranded. One is the passenger strand, which it takes you to the straightway to the liver. That specific action is there on the liver, and the guide strand, which acts on the PCSK9 and prevents the synthesis of the PCSK9 inhibitor, and that leads to the. And because of this drug specifically acting on the PCSK9 synthesis, you have to use only twice a year to maintain the LDL level. And since they are working on that specific action, the doses are small. Compared to the monoclonal antibody, which we are using, evolocumab, injection evolocumab, which acts on the LDL receptors on the hepatocyte and has to be given twice a month, or some dose 400 milligram can be given once a month also. But there, if you give before the second dose, there is a variability of the LDL cholesterol is very commonly seen, which is not seen with the inclisiran. The inclisiran has been now clinically tried in phase 1 Orion group of trials. Phase 2 trials are also completed now, and phase 3 trials on Orion group are going on at the moment. Phase 4 is Orion 4, which is looking for cardiovascular outcome trial. Then we have the Orion 9 looking for heterozygous familial hypercholesterolemia. 10 is looking for the atherosclerotic cardiovascular disease, 11 for risk factors with atherosclerotic cardiovascular disease, and also the Victorian studies, which are ongoing at the moment for clinical endpoints. And what we have learned from these studies is that if you use this drug, there is 50%, more than 50% reduction of LDL cholesterol. Not only this is important, but it has got a sustained reduction. There is no variability of the LDL cholesterol, which we see with the injection evolocumab. That is the advantage of this drug. And secondly, as we have I discussed with you, the Orion 4 and Victorian trial, which are the cardiovascular endpoint trial, they're still ongoing. So we do not have endpoint data at the moment, but Orion 9, 10, and 11 trials, which have got a data on 3,500 patients. This is not the primary or secondary endpoint, but these trials were not meant for that. So exploratory outcome data have shown clearly that there is 26% reduction of MACE in this population. Myocardial infarction and stroke was significantly reduced in this population. So that shows the drug is effective, not only in terms of efficacy, but also in terms of the reduction of cardiovascular event. Although we are still waiting for the large outcome data on 30,000 population. The data on the acute myocardial infarction or recent ACS is available with evolocumab, but was not available in the inclisiran group. So we have a data now of recent MI and the remote MI, and they have shown that in both the group on patients and compared to non-myocardial infarction population, the results are similar. The reduction of LDL cholesterol by more than 50%. How to use this drug? We have to use subcutaneous injection 1.5 ml, 300 milligram inclisiran, day 0 and 3 months, and then every 6 months. So ultimately it is twice a year injection which we have to give compared to 26 injection of injection evolocumab. Now why to give injection at 3 months? Because the studies have shown if you use the first injection, by 3 months there is slight increase in PCSK9 and LDL cholesterol. If you add second injection at 3 months, it reduces the levels further down, and after that you don't need any booster injections, and you just need 2 injections in a year to maintain sustained reduction of LDL cholesterol. This has been studied in all the clinical trial. And looking at the safety of the drug, what we found that it is very well tolerated, and the adverse effect of myalgia, arthralgia, new onset of diabetes, nasopharyngitis was not seen more. Only problem which we found was the injection site reaction, which was also very mild and self-absorbable. And based on this good data on all the clinical trials with the inclisiran, all the guidelines, the ACC, NICE, and our own guidelines, CSI, we have incorporated this drug in the algorithm of the management of dyslipidemia in clinical practice, because it is safe drug and effective drug. So what we have learned that we have to use this drug twice a year. It is effective and reduces LDL cholesterol. Sustainability and guidelines have accepted it. It is very well tolerated, and it has got a safety profile which is almost equal to that of placebo. And so what are the indications now? The patients, those who are unable to reach the LDL goal despite maximum tolerated doses of statin, HTMI, bempedoic acid, statin intolerance group of population. And the third group which we are finding, those patients are unable to adhere to the therapy, like those who are already on PCSK9 inhibitor, but they are on 26 injections. They want 2 injections per year. This is another area. And for primary prevention, our DCGI and also the FDA has given approval for that. We can use even for primary prevention in this population. So to conclude my talk, dear friends, the recent our guidelines have shown to keep the LDL below 55 in very high risk population and below 40 for extremely high risk population. In spite of the high intensity statin, HTMI, bempedoic acid, many patients, they do not reach the goal, and that is where probably we have to use this group of drugs. So medication burden can negatively affect the adherence, and average LDL cholesterol may not come to the goal level. And the variability is a very important point which we have learned now, which has to be avoided. And no lipid-lowering therapy like PCSK9 inhibitor have shown safety and efficacy, can even provide the optimal liver lipid control and CV outcome. And this small interfering RNAs like inclisiran is a PCSK9 synthesis inhibitor and is equally effective as PCSK9 inhibitor, but it has an advantage that you have to use 2 injections a year, and secondly is that it reduces LDL variability, and third, it is cost effective. Thank you very much for listening to my talk.
Thank you, sir, for being on time and a wonderful summary of inclisiran. Next comes our great president of Indian Academy of Echocardiography, Dr. Mani Vasagam, who is a man of money. He is going to speak on the added role of strain imaging versus EF in cardio-oncology.
Respected chairs and respected Colonel Parashar sir, thanks for the opportunity. Is there any added role of strain imaging versus LV ejection fraction in cardio-oncology? In the past era, lifespan of metastatic diseases were often too short. Cancer killed the patient. In the present era, survival from cancer is possible, prolongation of life is there, but cardiotoxicity of the cancer therapy kills the patient. And there are 2 types of drugs available right now. One is type 1 toxicity producing, that is anthracycline derivative. Type 2 is small molecule, targeted molecule drugs. These are all the examples of that. And previously, terminology is known as chemotherapy-related cardiac dysfunction. Nowadays, it has been changed to cardiovascular dysfunction because of the coronary artery disease, systemic hypertension, pulmonary hypertension, arterial and pulmonary, venous thrombosis. It has been coined as cardiovascular dysfunction. Prior to starting chemotherapy, we have to see the therapy-related factors and patient-related factors. And these are all the echocardiographic things we have to follow. LV volumes, LV mass, 3D ejection fraction is preferable than modified Simpson's method. Global longitudinal strain, E by E ratio, LVA volume index and strain, so on and so forth. Right ventricular dimension, RVS prime, TAPC, FAC, RV free wall strain should be taken. And apart from that, don't forget IVC dimension and valvular and pericardial diseases. And this is one example where the patient is in hemopoietic cancer receiving anthracycline. This is first topmost is basal echocardiography. Ejection fraction is 78%. Exactly 3 weeks after the basal starting treatment, the ejection fraction is again 78%. No change in ejection fraction. Then the right top is again automatic edge detection technique. Ejection fraction is 64 in the basal line. 3 weeks after chemotherapy, 62, no significant change in ejection fraction. But look at the global longitudinal strain and the initial, that is basal global longitudinal strain is minus 21.8, but 3 weeks after that it has dropped to minus 17.6. Absolute drop is by 4.2, relative drop is by 19.2. What is the significance of relative drop? This is the current guideline for detecting cardiotoxicity. Drop by 10% in ejection fraction or to the ejection fraction of less than 53. There are varying values of ejection fraction ranging from 50, 53 to 55. And relative drop of GLS is when it is more than 15%. That means we are dealing with cardiac dysfunction. What is the importance of more than 15%? We have to stop the chemo at that point or restart the chemo at a lower dose or restart the chemo with the cardioprotective agents. This is the variability of ejection fraction across various societies, but global longitudinal strain cutoff is constant. And at mild to moderate asymptomatic dysfunction, we have to take, along with GLS, we have to take cardiac biomarkers also. This is the trial done in 2021, that is called SAKUR trial. And before starting treatment, potentially cardiotoxic drug, basal echocardiography is taken, basal GLS is taken. Here the cutoff of ejection fraction is 55. Cutoff for GLS is 12%. After reduction of LVEF or GLS, cardioprotective agents are started, and then after 1 year, what is the result? It was observed. The key message of the study is LV ejection fraction was not altered by GLS-based surveillance. However, GLS-guided CPT, cardioprotective therapy, significantly reduced the meaningful fall of ejection fraction to abnormal range. The result supports the use of GLS in surveillance of cardiotoxic drugs. And this trial was extended to another 2 years, that is 3-year result of SAKUR trial. This unfortunately and unexpectedly results were not favoring GLS. This shake the basis of GLS physiology as well as pathology. The result was GLS-based strategy for early detection and treatment of CTR-CD was not superior to EF-based strategy. That means EF is in no way it is going to be useful like in this study. But lot of criticism was thrown against this study, and one among them is inherent study design and population characteristics was abnormal. Baseline ejection fraction chosen was it is the normal ejection fraction, and primary endpoint was LV3D-EF, but not any clinical endpoints. This was the explanation given for abnormal result of the 3-year SAKUR trial. A person who is well versed in and pioneer in 2D strain imaging is Tom Marwick. He wanted to conclude the conflict or confusion in this trial. He said he continued the SAKUR trial with the MRI. So along with ejection fraction and GLS, each time he did MRI derived ejection fraction. The conclusion is, luckily, out of 333 patients with CTRD, 105 patients, that is among 33, 1/3 of the patients developed fall in global longitudinal strain. Only 4% developed ejection fraction fall. But out of this 105 patients were put on cardioprotective agents. This cardioprotective agent prevented the fall in ejection fraction, and thereby proving in patients with isolated GLS reduction after anthracycline, cardioprotection is associated with better preservation of 12-month MRI-derived ejection fraction compared to usual care. That means by 2024, Tom Marwick said GLS is definitely useful in identifying subclinical and early cardiac dysfunction associated with chemotherapy, and cardioprotective agents can prevent the fall of ejection fraction. What is the current guideline? The role of GLS in cardio-oncology. Not only it diagnoses cardiotoxicity, but GLS can be used in immunotherapy and radiotherapy. Not only in breast cancer, but also in lymphomas and other hematological malignancies, solid cancers, colorectal cancer, renal cancer, lung cancer, all cancers, it can be used GLS as a marker of identifying early LV dysfunction. Not only left ventricle, right ventricle can also be used to identify the cardiac dysfunction. Right ventricle dysfunction may appear before the LV dysfunction, may be more common than LV cardiotoxicity. Right ventricular free wall global longitudinal strain reduction cutoff is more than 14.8% reduction, says this is cardiac related, cardiotoxicity related dysfunction. Thank you very much.
Thank you, Dr. Manivasagam, for completing in time. Thank you for your talk. And with this, we conclude this session. Over to Dr. Simi.
So now we are heading for the third last session and a very important session. This is by Dr. Roxy Senior, who's our international guest. And his talk would be a case-based presentation, stress echo in aortic valve disease. Before he starts, let me invite the chairpersons on stage. Dr. Manivasagam, you have to be on stage. Dr. Alagasan, sir. And Dr. Shanamuga Sundaram has to be on stage, please.
I request my friend Dr. Roxy Senior to present the case-based discussion on the usefulness of stress echocardiography in aortic valve disease. I think both dopamine stress and exercise stress.
Yes. Oh, they have not changed the. Thank you very much for inviting me to this meeting. And it's a great pleasure to be in India always. So I'm here today. So I'm talking about the stress echocardiography case study in aortic stenosis. So let's start off with the case study. So this is a 77-year-old female with known asymptomatic severe aortic stenosis, typical AVA, 0.6 centimeter square, mean gradient 46. Now, it is in the guidelines that if a patient is asymptomatic, to prove that the patient is truly asymptomatic, the patient should undergo an exercise testing. So this patient underwent exercise testing with echo, managed 4 minutes on Bruce protocol on the treadmill, but the patient complained of mild shortness of breath. Now, the bad markers during exercise test is if the patient becomes hypotensive, if there are arrhythmias or significant ST changes, then these patients are not truly asymptomatic and they should be intervened on. So this is a class 2A indication. So in this particular case, none of that happened. And if you look at what happened to the Dopplers, you will see that the mean gradient at rest was 45, as you can see here, 46, and during stress it went up to 56 millimeter of mercury. So it is expected that the gradient will go up, but if the gradient goes up by more than 20 millimeter, then these patients usually develop symptoms very, very quickly, and therefore the surveillance should be shorter. But in this patient, it went up only by 10 millimeter. So everything seems to be okay. However, if you look at what happened when we were getting the Doppler assessment, you will see that during stress, the flow rate, which was at rest 234, actually dropped. The stroke volume index also dropped, and the heart rate was 137. But the gradient did go up by 56 millimeter of mercury, 256. So what was happening actually? So now if you look at the quartz screen here, you will see what's happening. So what has been happening is the LV has dilated, right? You can see LV is dilated compared to rest, and there's a distinct area of wall thickening abnormality affecting the septum right down to the anterolateral wall, and this is a 3-chamber view showing wall motion abnormality in this LAD territory, but you can see the inferior lateral is thickening well, and the basal anterolateral was also thickening well. So essentially, this patient developed ischemia localized to the LAD territory, and when we did the angiography, okay, that angiography is not playing. Is it not playing there? Is it not playing the angiography? Oh, yeah. So you can see that there's a tight LAD lesion proximally. So this patient had asymptomatic severe aortic stenosis and probably is asymptomatic as far as aortic stenosis is concerned, but the patient actually had coronary artery disease. So as you can see, it is in the guidelines that you don't only look at the change in pressure gradient, you also look at what's happening to the LV. So that will give you a complete diagnosis of how to deal with this patient. So now, so this patient underwent CABG with aortic valve replacement. The patient was 77 years old, fit, as you can see, exercised well, except for mild shortness of breath. So those 77, but a fit 77, the patient underwent surgical intervention. So that's one case. So moving on, another patient, 88-year-old female, now very elderly patient, but known ischemic heart disease and had pacemaker implantation for tachycardia syndrome and a recent diagnosis of paradoxical low-flow, low-gradient aortic stenosis, meaning that the mean gradient is less than 40, the aortic valve area is less than 1 centimeter square. So, you know, severe aortic stenosis, but it's paradoxical because the ejection fraction is normal, but the gradient is low, and had some longitudinal dysfunction and had raised filling pressure. So we went along to give dovitamin to this patient. So we did a dovitamin stress echo because we wanted to increase the flow rate, which is less than 200, as you can see, to over 200 to see what happens to the gradient and what happens to the valve area. So that was done. And so if you look at it, the stroke volume was 57, right? As I've said, the flow rate was actually good, low 179. And so let's go to the next one. So this is during the intermediate stress. Now, during the intermediate stress, as you can see, the mean gradient remained about 23, didn't go up, but the valve area jumped to 1.05 centimeters square, right? And if you look at the whole result now in the intermediate dose, the flow rate has gone up, you know, to 263 ml per second. The valve area went up and the mean gradient remained at 23. So the mean gradient didn't change. That is because the valve was opening well. When the valve is opening well, the mean gradient may not change, or it may go up slightly. So this patient, we made a diagnosis at that stage that this patient has got moderate aortic stenosis, right? Now the thing is, the patient is symptomatic with shortness of breath. So at this point, remember, you can increase the dose further to assess ischemia. Like in the previous case, the patient had coronary disease, whether this patient has got coronary artery disease. So we continue to increase the dopamine dose, but this time we use the pacemaker to increase the heart rate so that it goes up to 85% of target heart rate. So when it went up to that point, you will see that the mean gradient remained the same, but the flow rate dropped, the aortic valve area dropped, and the mean gradient remained just about the same. So again, what is happening in this case? Why did the flow rate drop when we went up to a higher dose? Now, in the previous case, we had a similar situation, but there it was because of coronary artery disease and there was LV dysfunction. So now let's look at the squat screen again. So this is the quad screen now. So what you can see in this four-chamber view is that there is increase during, increase in contractility at low dose, and that remains, there's increase in contractility at high dose. But look at how the septum is moving here, right? This is a typical left one branch block pattern of the septal motion. And that resulted in drop in ejection fraction because it's incoordinate, drop in flow rate, and drop in drop in flow rate, and therefore the valve area also dropped because the flow rate dropped. And so if you look at the total outcome in this particular case, so what you see here is, the only difference was from the previous case is that this patient was in paced rhythm. So the paced rhythm itself can drop the flow and the ejection fraction, and therefore it messes up your assessment of the gradients, etc. So the lesson here is you must always pay attention to the LV whenever you do a stress echo, even looking just for the gradient change or the flow rate change, because that will also give you an extra information of what is happening to this patient. So this patient has moderate aortic stenosis, but with LBB pattern during pacing, which resulted in drop in the flow rate, etc., and change in the gradient. So we found a reason for why that happened. So it's not ischemia that caused it, right? So in this particular case, we didn't do anything to the patient. The patient was fine after that. My patient was short of breath, but not because of cardiac causes at that time. So moving on to another patient. So 82-year-old female, shortness of breath on exertion of recent onset, myelodysplastic, ejection systolic murmur in aortic area. So this is the echo. If you look at the valve is pretty calcified, right? And you can look at the LV. The LV function is down. It is not normal. And when we looked at calculated the ejection fraction, it was 35%. So low ejection fraction. And when we looked at the stroke volume, it is 91 ml, and the flow rate was over 200. So this patient has got, so this is the stroke volume, 46 ml per meter square. The flow rate was 260 ml per second, but the mean gradient is 32. So low ejection fraction, aortic valve area less than 1, but the mean gradient is only 32, but the flow rate is normal. So why is the gradient low if the flow rate is normal, right? Now, one of the other reasons why the gradient can be low despite a normal flow rate is increased vascular disease, meaning decreased compliance of the vascular tree, the systemic vascular tree. That can reduce the gradient without reducing the flow. Okay, so we know why the gradient is low. So again, what we want to do is to increase the flow. So this patient underwent dovitamin stress echo, and you can see that at rest, the stroke volume was 91. It's changed to 100 during a low dose of dovitamin. So we calculated the flow reserve. It was only 10%. Now you all know that a normal flow reserve is more than 20%. But in this patient, the flow reserve is only 10%. So again, look at the LV all the time. So if you look at the LV, right, you will see that the LV has actually improved from 35% to 48%. But the flow reserve is poor. So how would you label this patient? Okay? And not only that, if you look at the flow rate, that has increased to 333 ml per second. And if we go back, the mean gradient has gone up to 54 millimeter of mercury. So the mean gradient went up to 54, the valve area remained less than 1, so clearly we have demonstrated severe aortic stenosis, but with no flow reserve according to stroke volume index. But according to ejection fraction, it's increased contractility. According to flow rate, there's increased flow rate. So again, what is going on here? It is in the guidelines that you measure the flow, contractile reserve through stroke volume, through the stroke volume. Now, what happens with stroke volume, unfortunately, is, first of all, this is a patient with low ejection fraction and normal flow. Why normal flow? Because the LV was large and it can still generate enough stroke volume to maintain the flow, right? So that is number one. So low ejection fraction does not mean that the flow is normal. Number two, no contractile reserve according to the stroke volume derived flow reserve, but increased ejection fraction, increased flow rate. That is because when we give dobutamine in some patients, when the heart rate goes up, because the filling goes down, the volume drops, right? The stroke volume actually drops or remains the same. So that is the caveat measuring stroke volume. And that has been also shown in our study here, where we said lack of stroke volume flow reserve does not always preclude assessment of severity of aortic stenosis. So even without a flow reserve, according to stroke volume, you can still see increase in gradient. And why? That is because if you look at rest, right? If you look at rest, this is the stroke volume. And at stress, this is the stroke volume. Didn't change very much, right? But what changed is the velocity. Look at the velocity going up compared to that. And that generates the gradient. So stroke volume does not generate gradient during stress. It is the increased velocity, meaning shortened ejection time, increased flow rate. And the fact that the stroke volume has a problem is clearly shown in these three large studies, where you can see that in none of these studies that flow reserve had any prognostic value. So what it means is, though it is in the guidelines, it will be taken off very soon, because it's clear now stroke volume assessed flow reserve actually has no diagnostic power, no prognostic power. But on the other hand, this is our study showing that if you look at a stress flow rate by increasing 10 ml per second, that has prognostic value, because flow rate, which is increase in velocity, which measures the velocity also of the Doppler of the LV, is actually a representation of the intrinsic myocardial contractility rather than stroke volume, and also rather than ejection fraction. So then we come to another case, 79-year-old female, right? Again, this patient has got a low mean gradient, low aortic valve area, but here the flow rate also low. Okay, so the flow rate is low, the mean gradient is low, the aortic valve area is low. So meaning it is again a case of low flow, low gradient aortic stenosis with reduced ejection fraction of 27%. So it's a no-brainer. We should do something to increase the flow, which is dobutamine, and we gave dobutamine. And now if you look at the measurements here, so the AVA did not change very much, right? Now, if you look at the mean gradient at the top, that went up to 31. The AVA did not change very much. The flow rate went up to about 209, so it's over 200, right, about 210. And the ejection fraction didn't change very much. So how would you interpret this? Is it severe aortic stenosis? Is it moderate aortic stenosis? Or we don't know. Now, because the gradient hasn't gone up to more than 40, we cannot call it severe aortic stenosis, though the aortic valve area didn't change. Okay? So this we classify as indeterminate gradient, or rather indeterminate aortic stenosis, so we don't know. So what do we do then? Now you can actually do a projected valve area, right? So projected valve area is, you measure flow at 2 points, and then you do a calculation. So this is a calculation on, you can see there. This, and this. By the time you come to this middle, you are stressed, right? The patient is stressed, you are stressed, you said, forget it, I'll send the patient for CT or something. So you can do that, but it's a bit cumbersome. So what we came up is this. So what we said is, all you need to do is to increase the flow rate to over 200, because that's normal flow rate. And if at that time the valve area is less than 1, then it is severe aortic stenosis. So if you look at this slide, this is a multi-center study, by the way, which we led with Peterborough and all that, all the others, including, Poland and US. And you can see here that if you intervene on this valve of that patient, which we called indeterminate by normal criteria, but that patient achieved a flow rate of more than of 210, and the valve area remained less than 1, they did much better than if you left them to medical management. Okay, and not only that, again, it showed that if the stress flow rate is less than 210, the prognosis is bad. So stress flow rate not only gives you the contractility of the muscle of the heart, but also helps you in making a diagnosis of severe aortic stenosis. So you can see, if we had just used the guideline criteria, our indeterminate AS group is 43%. But if we take the flow rate criteria, then the indeterminate drops to 29%. So what do you do with this 29% of the patient? Now there you can use projected valve area, and though it's not on the slide, but the paper is in review, we've shown that if you combine the two techniques, you can reduce the indeterminate aortic stenosis assessment to 9%. So very low. In other words, 91% you can make a diagnosis of severe aortic stenosis using stress echocardiography. So this is a take-home message. Always assess LV function, regional wall motion abnormality, contractile reserve, not with stroke volume. Because I've said here, stroke volume may not be assessed because it may be reduced due to small L volumes during stress echo despite normal contractile reserve. If stress echo is indeterminate, assess AVA at flow rate of 210. And if it remains indeterminate, then you can use projected valve area. CT calcium will come later. And you must have read in the literature that CT calcium is not good in patients with low flow, low gradient aortic stenosis. Thank you.
How do you place the sample volume in LVOT for stroke volume calculation, particularly during stress, like the flow acceleration is going to be very prominent? How do you identify the right spot?
Okay, so all you need to do is to measure the ejection time. So stroke volume divided by ejection time is the flow rate. Yeah?
Base the sample volume, ideally. Like, the flow accelerates during exercise.
Yes.
Or dobutamine.
Yes.
How do you decide the site where you place the sample volume?
Okay, so when we place the sample volume, it is in the usual place we place, isn't it? Right? I know it accelerates. You don't put the sample volume where there's lots of color, but just below that. But normally it doesn't vary too much as far as we know. Yeah.
Dr. Roxy, I've got a very silly question. Pardon me if I'm asking something wrong. My question is, rather than doing all these things, can't we put a probe inside and do a transesophageal echo and calculate the valve area?
When?
in every subject, whenever we are thinking of a severe aortic stenosis,
Yeah.
just do a transesophageal echo and calculate valve area.
Okay. So what you will get in a low flow situation is you will see small aortic valve area because the flow is low, and aortic valve area is also flow dependent. Right? If the flow goes down, the aortic valve area also begins to go down to the severe range. So if you do planimetry, you will still see, a small valve area, but that doesn't mean that the patient has severe aortic stenosis because the flow is low. So if you are going to do stress echo during transesophageal echo and measure at each point, you can do that. But transesophageal echo is invasive or semi-invasive. The patient is uncomfortable, sedated, right? So even though the patient is sedated, it's still uncomfortable, right?
So that's possible.
Of course, it's possible. You can measure by planimetry. Planimetry, throughout the stages, you can do that.
Thank you. Thank you.
Thank you, Roxy. I think I have noted down your publications. I'll go through that and try to understand rather than asking you any question. Thank you. Thank you very much.
Thank you, chairpersons. Thank you, sir, for a wonderful presentation. So now the next session will be on congenital heart disease. I would request all the speakers to please line up their presentations if they are around. Please identify yourself, Dr. Praveen A. Is he around? Dr. Shiva Prasad, PM. Okay. So the next chairpersons for this session are, I would like to invite Dr. Anita Saxena, ma'am. Is she around? Dr. Smita Mishra, I can't see her. Dr. Amit Mistry. Dr. Vikas Kohli, I think all of them are not around. So, whom do I invite? So, at least 3 or 4 of them are here actually. Yeah.
Can I call upon Dr. Vivek Sulere, be on the dais, Dr. Ranjan, be on the dais, and Dr. Meera Govindrajan, be on the dais, and finally Mrs. Sangeeta Porwal on the dais. Last but one the session is. Sangeeta, be on the dais. जा रहे हो? Can I have a first speaker, Dr. Parveen, please on a dais. He's already over here.
So,
Dr. Shiva Prasad, if you are over here, please attach your. He's there. Okay. Dr. Munish Tomar, he's there. Okay. And I know Dr. Neeraj Agarwal.
So, good evening, everyone. Myself is Dr. Praveen. I'm a senior resident in pediatric cardiology from AIIMS Delhi. So, I'll be presenting an interesting case which we managed 4 months back in our hospital. So, this is the story of 9-year-old female child who's a resident of UP. She presented to us with chief complaints of dyspnea on exertion functional class 2 since last 4 months prior to admission. So the child started having this dyspnea on exertion since June 2024 and also had decreased urine output 2 days prior to the admission. So however, there was no significant negative history like palpitation, chest pain or syncope, or no history of any contact with TB, cough, hemoptysis or weight loss in the patient. On examination, the patient had tachycardia, was tachypneic, there was elevated JVP with distended neck veins, there was cardiomegaly, on auscultation there was muffled sounds. And there was also hepatomegaly, but respiratory and neurological examination was normal. And she was accompanied with chest X-ray from the outside hospital, which showed a huge cardiomegaly, which I'll be showing later, and also there was an echocardiography done outside which showed a large collection anterior to the right ventricle. So on further probing the parents, they revealed the history that the child had an history of blunt chest trauma 1.5 years prior to the symptoms. She fell from the motorcycle and sustained injury to the anterior chest wall. But at that time, the child was evaluated in a local hospital with chest X-ray was done and NCCT head was done. It was told to be normal. The child was asymptomatic throughout this period. So this is the chest X-ray of the patient at the time of admission, where we can see a huge cardiomegaly with oligemic pulmonary fields. And the ECG was also showing a right atrial enlargement with diffuse low voltage complexes with right axis deviation. So this is the subcostal view showing you can see all 4 chambers of the heart collapsed and there is a huge collection anterior to the right ventricle. So and we can also see a huge rent also seen in the RA free wall and the cavity is freely communicating with the right atrium through this rent. On color Doppler, we can further see there is a to and fro motion of fluid between the cavity and the right atrium, and all the other 4 chambers also, 3 chambers were collapsed. So we also proceeded with saline contrast echocardiography, where we can see we injected the bubbles from the left hand. We can see the bubble from the right atrium is entering through the rent and is covering and is entering the collection. So with this, our differential diagnosis was a traumatic rupture of right atrium leading to a right atrial pseudoaneurysm, since there is a free communication between the right atrium and the collection. But also we kept a possibility of localized pericardial effusion anterior to the right atrium and right ventricle, but that is slightly unlikely. That is unlikely because we can see the communication in saline contrast echocardiography. So we proceeded with the CT angiography in this patient to further delineate the extent of the collection, and we can see the collection size was around 15 into 12 centimeters, which was very huge for the age, and it is extending till the sternum. So we sent the patient for surgery, and this is the images I will explain. So here, this is the So once we reflect the pericardium, we can see the huge pseudoaneurysm, and once the pseudoaneurysm is open, it is completely filled with blood. Once the blood is evacuated, we can see the huge rent in the RA, and we can also see the pectinate muscles within the RA. So the sac was closed and RA was sutured, and this is the immediate picture of the post-operative period X-ray, where we can see the cardiomegaly has decreased significantly compared to the previous X-ray, and also echo-wise, the collection was also decreased in the size, and all the chambers of the heart have opened up well. And the patient was followed up, and this is the echo 6 months after the surgery, where we can see the RA-RB has opened up nicely and the collection has also decreased, and the patient's vitals also stabilized, and JVP, everything became normal. And this is the X-ray just 6 months post-op, where we can see the cardiomegaly has significantly improved. So blunt injury to chest is not a common etiology, but injury to cardiac chamber is pretty rare in blunt chest injury, where it occurs for only 0.2 to 0.3%. The most common chamber involved in blunt cardiac injury is right atrium, since it is the most anteriormost chamber, and it is involved in more than 40% of the patients with blunt cardiac injury. Most common damage will be contusion, valvular damage, the tricuspid valve damage, or dissection or arrhythmia, but can also pseudoaneurysm and tamponade can also happen. But these patients with right atrial injury tend to have a very late presentation in a significant group, like 20 to 30%, because of the low pressure in the right atrium and the very slow oozing effect to the right atrium, like our index patient. And if we can see the difference between a true aneurysm and pseudoaneurysm, the true aneurysm is just a dilatation of the cardiac chamber, and the wall will contain all the 3 layers. But a pseudoaneurysm usually have a rupture, and the breach will be communicating with the external cavity, and that will be causing the hemodynamic effect. And if we see, there are various etiologies for pseudoaneurysm in various chambers in heart. For right atrium, if we see, the most commonest thing is trauma or any ablation procedures with catheter, which we will be doing. So if we review the literature of isolated right atrial rupture, the most common site of right atrial rupture is the right atrial appendage, which accounts for 35%, followed by RA-IVC junction for 21%. But in our index case, there was damage to RA free wall, which but even in literature, around 15% of the patient has RA free wall rupture. And around 100% of this patient had hypotension and 65% had cardiac tamponade. But asymptomatic presentation of right atrial pseudoaneurysm has also been documented in the literature, but most of them are adults like more than 45 years or 50 years of age. But in a pediatric patient with an asymptomatic cause, this is pretty rare. And the mortality is also around 11% in these patients. So mechanism of injury, there are two mechanisms proposed. One is the direct injury to chest, which will cause an increased pressure in the chamber, which is the anterior most, and which will cause an hydraulic effect like a compression and causes the RA rupture, which most commonly occurs in the RA-SVC junction or RA-IVC junction. Other thing is the rapid deceleration, which sudden change in velocity, which will cause the shear force and the tearing force, which can cause, that is the most common mechanism described for the free wall rupture. And because of the decreased pressure in RA, there is a slow accumulation of blood in the cavity, so this results in the asymptomatic phase. So to conclude, this is a very extremely rare complication of blunt chest trauma, like a pseudoaneurysm, and early suspicion is critical as initial presentations may be subtle or asymptomatic, and surgical treatment remains the cornerstone of treatment.
That was a truly stupendous case. I think we have a little bit of time, so we can have one or two questions.
Madam, there is no time because we have to wrap up by 5 o'clock. So let's move on to the next presentation, please.
Because I thought he finished within this time. So.
No. Time is short. They have given him 10 minutes. It should be 8 minutes now.
So, thank you. The next case is the calcification of vessels in a fetus. And Dr. C. Prasad, PM.
I'm senior resident pediatric cardiology from AIMS. We had this interesting case of calcification of vessels in a fetus. We had this 28-year-old multigravida mother who was referred to us at 33 plus 5 weeks of gestation with a fetus having the pericardial effusion. She had history of previous 4 abortions. The previous abortions which was examined was normal. All abortions happened in the first trimester. This was the fetal echocardiography in this pregnancy, which showed large pericardial effusion, and we can see the hyperechoic walls of aorta, ascending aorta, and DTA, and there was also decreased right ventricular function. So with this large pericardial effusion and hyperechoic aortic arch and DTA walls, the baby was suspected to have generalized arterial calcification. She was closely monitored till term and she was delivered at 37 plus 5 weeks. The baby was 2.5 kg at birth. It was appropriate for age and she cried at birth. And this was the examination of the baby, which has depressed nasal bridge, hemodynamically stable at birth with unremarkable systemic examination. This was the X-ray. As we look closely, we can see the calcification in the DTA in this X-ray. And we proceeded with echo. Echo showed hyperechoic ascending aorta, pulmonary artery, and even extending till the branch PS. This is further showing the same. And when you look at the arch showed ascending aorta and its branches which are hyperechoic. And the function was normal and the pericardial effusion was not there at birth. So the baby had these hyperechoic walls of ascending aorta, arch, DTA, pulmonary arteries, suggesting the generalized arterial calcification. So we proceeded with CT CT showed calcification in the ascending aorta and patchy calcification in the DTA, and the calcification involving the branches like common iliac, external iliac, and common femoral arteries. The same is shown in this VRT image. So baseline investigations, the child had normal baseline investigations with normal calcium and urine calcium creatine ratio. I'll be explaining this in discussion, the importance of this. And the child had normal USG KUB, hearing assessment was normal, and ophthalmological examination was normal, and the whole exome sequencing that was done subsequently showed homozygous mutation in ABCC6 gene, which was responsible for the generalized arterial calcification of this baby. When you look at this entity of GASI, it's a very rare entity. It's an autosomal recessive disorder which manifests as calcification of media of large and medium-sized arteries, which is accompanied by intimal proliferation leading to arterial stenosis. It's first described in 1899. There were only around 200 cases which has been reported worldwide since then, and the major two mutations that are described for the entity is ENPP1, which is the around 90% of the cases, and ABCC6 mutation in around 10% of the cases. The mechanism being these mutation in these basically these proteins are responsible for conversion of ATP to AMP and pyrophosphate, which is an inhibitor of ectopic calcification. When these are mutated, this leads to ectopic calcification in the arteries and other organs. So this entity has bimodal age distribution. Around half of these patients manifest in utero and half of them after birth. Early onset cases as signs of fetal circulatory compromise. They may present as eye drops, polyhydramnios, and fetal distress. Late onset cases may be asymptomatic, like in our case, like if we had not diagnosed in fetal life. They present usually with cardiovascular compromise, with heart failure symptoms and hypertension. So when we look at the percentage of involvement, 90-95% of the cases will have arterial calcification. Around 50-60% cases will have extravascular calcification, and skin involvement in the form of pseudoxanthoma elasticum is known in around 20% of the cases. When the ENPP1 gene is the cause for the disease, we see hypophosphatemic rickets, nephrocalcinosis, and cervical spine fusion and hearing loss. This is the picture showing skin and retinal involvement and the extravascular involvement of calcification. So ENPP1 gene, which is the major cause for this disease, has involvement of kidneys. They may present as rickets and hearing loss in addition to other manifestations. So when you look at the treatment, there is no definite treatment, but we can prevent the calcification and decrease the calcification by using bisphosphonates. The pamidronate is the drug that is IV form, which is available in India. Etidronate is a oral form, which is not available. We used in our case pamidronate at the dose of 0.5 mg per kg per day, 3 doses, with a plan to repeat the same every 3 monthly. If the patient has manifestation of hypertension, standard therapy is recommended. If there is rickets, we need to supplement phosphate and calcitriol. And if there are other organ involvement, supportive therapy is the treatment. So when you look at the prognosis, GASI is a life-threatening disease. Around 50-60% of the cases dies by around 6 months if untreated. But bisphosphonates have shown to be promising in improving the mortality. So the follow-up plan that is recommended based on the expert consensus recommends to do low-dose CTs at every 3 to 4 months during infancy to assess the extent of involvement, and every 6 months in the second year of life. It can be postponed if the calcification is not seen. Echocardiography should be performed more frequently depending on the degree of myocardial dysfunction. So other organ involvement screening should be done in follow-up. And there is a promising ongoing trial for supplementing the ENPP1 deficiency with a recombinant enzyme. This has shown good results in animal studies, and there is an ongoing phase 1B trial for this enzyme replacement therapy for GASI. So in our case, the child has recently received second dose of pemidronate, and the child is developmentally normal, and the repeat CT has showed like circumferential wall calcification still present along the ascending aorta arch and MPA, but the same calcification that we saw previously in the branches is not seen, and the child has normal electrolytes. So this is the summary of the disease entity. It's a rare entity which needs to be we should be vigilant in all cases of fetus who presents with eye drops. This may be the entity that we may miss if we don't focus. And the treatment is still there is no curative treatment. We can the bisphosphonates have shown bit promising therapy in these cases. Thank you.
Thank you for a very nice case. The next case is Lord of Rings, and speaker is Dr. Muniz Tumar.
Very good afternoon, everybody. So in continuing with the interesting cases, both cases were very interesting, presented by AIMS Pediatric Cardiology Fellows. So here is a newborn, just born baby at term, and had severe distress immediately after birth. There was a stridor. Normally when a baby born and there is fetal distress or perinatal asphyxia, that the distress is different, but not with the stridor. Here, because it was a stridor, so it was something different from the usual perinatal issues. Because of stridor, the point of care echo done immediately in the labor room only. There was usual cardiac wise 4 chambers, little bit of RA-RV dilatation, PA pressure obviously has to be systemic at birth, but there was no inflow or outflow obstruction or the regurgitation. When going into the suprasternal view, because the baby was in severe distress stridor, it was getting very difficult to make the supraesternal windows in the baby. So this is a parasternal short axis view. Pulmonary artery bifurcation was normal here. On color flow mapping, there was a significant ductus, means it was normal for a just born baby. So nothing in parasternal short axis view. Suprasternal view, arch was defined from different planes. There was no coarctation and something dilated was seen here. Going further, because child was sick, it was immediately intubated. With intubation, the images were again tried, and this is the suprasternal view. So this is the trachea, and the 2 circle on the both sides of trachea was seen. That made a diagnosis of these 2 circle were in between on the both sides of trachea, compressing tracheal obstruction lumen, causing the stridor or the tracheal obstruction. So this was the finding made by after intubation, intubating the child. The intubation made the child stable, so you are comparatively easy in you're taking time to evaluate the echocardiography. Plus, it gives a very important anatomical delineation to image make the diagnosis of the possibility of double aortic arch. But double aortic arch presenting so early, that is another thing here. Beyond those 2 circles, there was something dilated was also seen. So there were some more thing to compress the tracheal compression here. Then after initial stabilization, shifting to nursery, the CT angiography was done, which made the diagnosis of the double aortic arch, along with there was large aneurysm, ductal aneurysm. So in the first image, the ductal was seen, usual ductus, but when you open in a different view, you could see aneurysm. So it was double aortic arch with ductal aneurysm, compromised the respiratory status of the baby, leading to immediate compromise immediately after birth. So clinical tightness, it was because of these 2 components. Endotracheal intubation was important. It saved the baby and give time to evaluate the baby in details. Then the CT and detail echo was done, and child was operated for same. So to understand the arch development, this is all we are reading from our first year MBBS time of view. So it is a 5th week of gestation. So 5th week of gestation, that time the arch, things are happening. So there are 6 arches which appear and disappear according to the with the gestation age. So first, second, disappear. Third goes into the carotids. Fourth form the aortic arch on the left side, while on the right side it disappears. So basically these are the things which remain. So this is the normal, persistent of the normal left side, and disappearance on the right side of the fourth arch and the lower segment, leading to your normal aortic arch anatomy. Any difference in that will lead to your any type of the vascular ring may be formed. In case of double aortic arch, it is a persistence of left and right, both will persist and make a complete ring. So this is the thing where complete ring will definitely form with double aortic arch. Whether to intervene or not, that is a different question, but complete ring will be formed. So this is almost 1% of congenital cardiac anomalies are the vascular ring, and 55% are by the double aortic arch. What is the presentation for the double aortic arch? Any form of respiratory and the esophageal issues. So respiratory failure shortly after birth or later part of the life, apneic episodes, apneic life-threatening episodes, unexplained events, noisy breathing, cyanosis, persistent cough. Sometimes child is getting repeated episodes of so-called bronchial asthma episodes. They are not responding to nebulization. So anything like that, we need to think for the vascular aortic arch or the vascular malformation. This is one anatomy where we need to search for the tracheal compression, because in your usual cardiac anatomy, nothing will be there to suggest that it could be the double aortic arch or aberrant subclavian vessels or anything. So vascular ring need to be searched when there are any presentation related to the respiratory issues in the on examination. Usually no murmur if there is no associated cardiac defects, and just failure to thrive, and some noisy breathing will be there. So in these conditions, we have to evaluate in detail by echocardiography. If not conclusive, then better to ask for the further imaging. CT angiography give you all the information, what type of anomalies, what type of compressions, you will get every information by the CT angiography. Surgical repair is the mainstay of treatment, and indication symptomatic. If child is symptomatic, you have to intervene. If you are going for some other open heart surgery, the aortic arch anomaly, if incidentally find it, should be repaired. So recently I saw a child who was operated for VSD. So VSD surgical closure was done, and after 1 year of that, child came to me because of recurrent respiratory issue. His respiratory issues were persisting, in fact increased after so-called the VSD surgery. And when we looked on the anatomy, it was double aortic arch, which was somehow missed during the initial evaluation or that at the time of the surgery, because we have to tell the surgeon that this is the anatomy. He just can't go and looking for the vascular anatomy. That is so important. Defining the aortic arch, side of aortic arch, branching pattern, everything we should report in our echocardiography, especially from the congenital point of view. So if you're going for surgery for some other reason, there is double aortic arch, you need to repair. If it is symptomatic, you need to repair these aortic arch anomalies. Can I take few more minutes? Sir is not here.
1 minute.
Okay. So this is another child, 2 year, with stridor. Again, stridor was the presentation. No murmur. X-ray was not so-called any informative. Echo usual was okay, except some mild pulmonary arterial hypertension. This is the parasternal short axis view. So here, this is again aorta, pulmonary artery, main pulmonary artery going to right pulmonary artery, and this is the left pulmonary artery, which is distally arising, and it was encircling the trachea and going into the left side. So again, the presentation is same, slightly older kid with stridor only, and it was the pulmonary artery sling leading to respiratory issues, and again requiring surgical intervention for that. So PA sling usually have almost 30% have some type of congenital anomalies. So could be tetralogy, left SVC, aberrant subclavian artery, any sort of congenital defect may be associated. Syndromic association is also known with the vector anomaly, Down syndrome, Holter-Graham carcinogen syndrome. The thing is, when we are doing echocardiography, our approach should be segmental. All segments need to be defined. Arch need to define the side of aortic arch and the branching pattern. So everything intracardiac, extracardiac need to be commented when we are giving our echocardiography report, because it is something significant and have excellent report, surgical results if we do intervene on time. Thank you.
Dr. Neeraj Agarwal.
Yes.
So last session possibly, let me go through faster this session. I will be talking about scimitar syndrome and some pulmonary venous anomalies here. 4-month-old child admitted with LRTI, diagnosed with large ASD, and you can see the X-ray picture, slightly shifted heart to the right side, and if you see cleanly, you can see a shadow here. I have just marked it for you. This is called basically a scimitar appearance on echo. See that there is a ASD here. You can see an ASD shunting left to right, but see, 4-month-old child, large ASD, should not have so much of dilatation of right side chambers. RA-RV is disproportionately larger than the ASD. Now on subcostal assessment, as ma'am told, segmental assessment is important. I was thinking maybe I am missing some pulmonary venous anomaly. Let's go to the subcostal window. On the subcostal scan, you see this is the IVC, and some red flow goes into the IVC. In subcostal view, what is this vein? In subcostal view, when you see a short axis subcostal view, the right lower pulmonary vein is seen. This is normally you see a right lower pulmonary vein in this view, and right lower pulmonary vein is draining into IVC. I can show you in 2D in color. So right pulmonary vein draining into IVC, basically a scimitar syndrome. There are 4 characteristics: right side PAPVC, variable right lung hypoplasia, dextrose heart, anomalous supply of MAPCAS. CT scan can confirm this diagnosis. See this right side pulmonary vein going via scimitar into IVC. I have marked this. This is scimitar vein going into the IVC. On CT, you can see right lung hypoplasia. So whenever you see a patient with a slightly dextrose heart, slightly right lung volume loss, start thinking of scimitar syndrome. Management of scimitar is surgical repair. VR section. Yeah. So here you can see a descending aorta, and then this one. Scimitar goes into IVC. Surgical repair is the answer for scimitar. Now, how do a scimitar look on X-ray? This is second patient. How does a scimitar look on CT scan? Will give you an idea of what is scimitar. That's why I am showing this NG only now. So femoral venous access, right lower pulmonary vein engaged, and you can see one vein draining into IVC, and then this is the picture of scimitar. You can classically the scimitar appearance draining into IVC. Right upper vein, so all pulmonary veins draining via scimitar into IVC. One more method to assess right pulmonary veins is venophase. So right pulmonary artery injection, wait for the contrast, and you can see the scimitar here again. This is another method to define pulmonary veins when you don't have an access to the pulmonary veins. See this now. Right pulmonary injection, wait for scimitar to appear. So scimitar shows on X-ray, on angio. This is the MAPCA you saw. See the descending autogram, and you can see a collateral here. This one. So collateral supplying the right lower lobe is another manifestation of scimitar syndrome. Now this is the scimitar syndrome. Now what is masquerade? What can look like a scimitar is also important to understand. This is my last case, 4-year-old child, presenting with recurrent uveitis, sent for echo to rule out CSD. X-ray, see right side shift of the heart, some volume loss on the right lung, and maybe a shadow here. I thought there is a shadow which is looking like a scimitar. So abnormal radiopathy in the paracardiac region with volume loss of right lung, I was thinking in my mind, it's the scimitar syndrome. Going to the subcostal view to profile the pulmonary vein, see this pulmonary vein is not draining into IVC. This pulmonary vein is not draining into IVC, it's normal draining into the, most likely into the LA. Defining again the pulmonary vein, right lower pulmonary vein, draining normally. Now compare scimitar versus current patient. This is scimitar. You can see red flow, right lower pulmonary vein draining into IVC. Here, I don't see a vein draining into IVC. So it's not a scimitar, I am sure now. I will skip this. So right lower pulmonary vein I have defined is not draining into. Now let's see the 4-chamber view. In a 4-chamber view, normally you see right pulmonary vein here, but in my case, I am not able to profile right lower pulmonary vein in the 4-chamber view. So I am surprised, where is the right lower pulmonary vein? It's atretic. In short axis view, again I am not able to see right lower pulmonary vein. But in subcostal view, right pulmonary vein was seen, draining into towards LA. Some flow seen, but I see only one vein on the left side draining into LA. And I see a common chamber of the pulmonary venous drainage into LA. I thought this may be varix, maybe common veins, all veins are joining and coming to the LA. Normally you see a pulmonary vein draining into LA here. Here I am seeing a common chamber. CT angio was done, and you see this looks like scimitar. It comes towards IVC, but the contrast doesn't go into IVC. So it's not draining into IVC. Scimitar goes to the LA. Posterior view. So this vein was draining into LA, but using a tortuous course. It's called meandering pulmonary vein or pseudo-scimitar syndrome. And this is a picture from the behind of CT scan. You can see the dilated aneurysmal pulmonary veins draining into LA. This is the echo and CT correlation. On echo, I could see this large channel. And on CT, this is the channel. So right lower pulmonary veins or right upper middle pulmonary veins all making a common chamber and draining into this vein. So this is not a scimitar, this is pseudo-scimitar or meandering pulmonary vein. CT was performed again. So VR scan, and see this now, the scimitar goes, but the contrast doesn't go into the IVC. So the comparison of contrast in the IVC. This is scimitar draining into IVC. This is meandering vein draining into LA, not going into the IVC. So the diagnosis was made of meandering vein and not scimitar syndrome. This should not go for a surgical repair. So my conclusion: dextrose heart with small right side PA, raise suspicion of scimitar syndrome, disproportionate right side heart dilatation, look for venous anomalies, unexplained pH, rule out pulmonary venous anomalies. Thank you.
Thank you. Nice demonstration of pulmonary veins. Thank you. Next speaker, Dr. Debika, a case that baffled me.
Dr. Debika,
Yeah.
quickly finish it or don't baffle us.
So the case that baffled me is my patient, a 50 years old female, referred to our electrophysiologist from outside with for the management of paroxysmal AF with the possibility of RV cardiomyopathy. Echo done outside showed dextrocardia, severe tear, enlarged atria, dilated RV with systolic dysfunction. EP guy has advised CMR for confirmation of RV cardiomyopathy, but CMR ruled out the RV cardiomyopathy. There was no outpouching. RV had a fair systolic function, no evidence of inflammation, infiltration, good biventricular systolic function, dilated RA with severe tear and moderate edema. At this point, the patient was referred to me for detailed assessment by echocardiography. Clinically, I got normal pulse, normal heart sound, a soft systolic murmur. Her SpO2 was 96%. ECG showed normal sinus rhythm. So it was a case of dextrocardia, as you can see here. This is the lever, heart is directing towards the right with situs solitus. Now, as I looked at the four-chamber view, I got a dilated RA as well as the LA. And the patient had intermittent atrial fibrillation. But if you look at her RV, TAPSE was quite good, 17.5. So RV systolic function was well preserved. And parasternal long axis is a problem in dextrocardia, but somehow I could manage to get, which showed mild mitral regurgitation. As I went to the four-chamber view, well, I could see a torrential tricuspid regurgitation with TRVC 14 millimeter. It was a low pressure TR. If we look at the tricuspid valve leaflets, normal morphology, only there is a coaptation failure. Her pulmonary valve was normal. Somehow I got the views. It was a very, very difficult window. An adult patient with dextrocardia is a real problem for echocardiography. Now I started looking at the four-chamber view again. As I looked, I had a doubt initially. I didn't see anything, but now I started looking at it with the color flow. There was a flow from left side to the right side. Now I had a doubt whether it's a dilated coronary sinus or an ASD. The severe TR was there. I looked for the SVCs. The right SVC was very clear, but left I was not very sure. I could see a structure. I was not very sure about the left SVC, but right SVC was there. Now I did the transesophageal echo at this moment, and because I couldn't come to a diagnosis, I wanted to rule out the ASD. Severe TR again. The long axis, aortic long axis is normal. Now, as I went to the midesophageal four-chamber view, this is the only view I was getting in TE also. There it looked like a dilated coronary sinus. And in the next view, you see, I tried to open, and there I could see this is the LA, this is RA. The coronary sinus is draining into the RA, but there is an unroofed coronary sinus, which was showing clean flow from the coronary sinus to the LA. So I did a bubble contrast study. See how the bubbles, entering into the LA and RA simultaneously, which confirms, and it was to the coronary sinus, though I couldn't see in the parasternal long axis view because it was a case of dextrocardia, but it is seen nicely in TE that coronary sinus is dilated. So my diagnosis is unroofed coronary sinus, coaptation failure of tricuspid valve leaflets with torrential TR, right SVC present, query LSVC with good systolic function. With these findings, case was referred to the surgeon. Well, after opening the chest, the surgeons had a problem. There was dextrocardia, situs solitus, normally related gait arteries, but and the superior inferior orientation of the left side and the right side was there. So I was called in the OT. So LA and LV were anterior and RA and RV were posterior, but they got partially unroofed coronary sinus. But again, they got dual SVC, and the surgeon was telling it was the LSVC which was draining into the RA. RSVC was draining into the coronary sinus, which I couldn't visualize. And also, surgeon got an additional large posterior type of ASD. Well, the coronary sinus defect is very, very rare. It occurs less than 1% of ASDs with 0.1% of the congenital heart disease. It is a defect in the common wall which separates the LA from the coronary sinus, resulting in interatrial shunt. 75% are associated with LSVC. So our patient was discharged with no residual ASD, with mild tear on LISI. The operation which were done was roofing of the coronary sinus with pericardial patch closure of secondum ASD, and tricuspid valve annuloplasty. So this is the magic of wide-angle echocardiography. I didn't have the tubular vision. That is why I could come to a proper diagnosis, and we have given a new life to the patient. Thank you.
Devika, just one comment. We had the same thing. We gave an IV agitated saline on left arm, patient collapsed. So we have to be very careful if the large shunt is there, because these bubble will go either into the microcirculation of heart or a brain.
We took consent and we did it very carefully.
No, after the consent, if collapses, it will be liability. So we have to be very, very careful.
Yeah. She was having intermittent atrial fibrillation.
No,
so the RA was enlarged.
That's fine. Tricuspid valve are thickened.
Leaflets. No, it was. They were not thickened. Paraoperatively, these were okay, because if you look at the post-operative.
No, pre-operative.
Yeah, see, no, those were not thickened. Maybe because of the over gain in the picture. I'll go to the
Samir, they get thickened by evening, you know.
Okay.
Just see.
I accept whatever he is.
They are there. Say, look at the tricuspid valve. Okay, I'll show you.
Go into the 4-chamber and this is thickened. Doesn't matter. I mean, the only thing is that at some point of time when you see a low pressure tricuspid regurgitation with thickened mitral tricuspid and mitral being normal, then
So maybe mildly thickened, but the surgeon didn't have to do any repair work. I mean, just other than the annuloplasty.
He would have just put in a ring and come out of it. That should be enough for him. Because they are not bothered about morphology.
I have seen the patient 2-3 days back also. Her everything is normal. This is the picture which I have taken, I think, day before yesterday. This is the picture.
No, I'm not saying anything about what was the diagnosis, but my observation was that the tricuspid was thickened compared to mitral. That's how you compare tricuspid thickness.
Thank you, Samir sir. Thank you, speakers, for this session and the chairpersons. With this, we conclude our meeting. And I would request the organizing president, Dr. Rakesh Gupta, to give the vote of thanks.
So finally, it's my job to pay thanks. I'll say that to begin with appeared a Herculean task to organize this meeting at such a short notice. When Dr. Parashar said, say Rakesh, go ahead and do this meeting. Can you organize it? And whatever the submission was, there is a large gap between the national conference in March 2024 and the next annual conference in October 25. With no thoughts in mind, I immediately said yes. Later on, I realized how much confidence he had in me when he asked this question, despite the fact we were going through a turbulent time in our relationship as father and son duo always have. I am thankful from the core of my heart for his immense confidence in me. Various national speakers readily consented to be the part of this Congress, along with international Dr. Roxy. All of them shared their exemplary skills and enchanted the audience with their knowledge. I am thankful to all of them from the apex of my left ventricle. All of them contributed immensely to the scientific program despite their busy schedules. No conference is possible without the active participation and discussion of the participant. They are like a blood cells circulating amongst all chambers, enjoying the activity, and I'm also thankful to these blood cells in my hemoglobin. Organizing our ECHO conference is a mighty work, needs the support of multiple hands. The entire ELCOR team, Grover Audiovisual System, Hotel Lalit staff made this event possible without any hitch. They all worked like a linear phase array transducer with a cord in my hand. I am also thankful to them for untiring efforts. I would like to pay thanks to many persons behind the scene. I can't name them, all of them, who always stood along with me in the difficult times, as also happened this time also. All the activity of the heart need current, which was provided by three-phase electricity connection from GE, Izaute and Samsung. Thankful to them for keeping this heart alive and running. Before I close, I would like to pay thanks to the master of the ceremony, the pacemaker of my heart, for keeping this program and my heart running smoothly in a normal sinus rhythm. And finally, I, along my entire team, is blessed by Almighty God for making this program successful. And once again, I'll be calling you all again. Can I have a slide of next conference in Kochi? We had a board depicted outside. So join over there in the next conference. And then can I have the slide, please? Yes. Now this is Echo Asia, which we are going to organize in Delhi in 2026 under the chairmanship of Dr. S.K. Parashar, along with this complete band of a non-invasive transducer, a linear phase array harmonic broadband. The captain and the coach together would be the apex of this particular team. And can I have another slide also? No, the other one in Cochin. Anyway, the board was there outside. And last, finally, let's all stand up again to close this ceremony with the national anthem as we started in the morning before we disperse. Can I have the national anthem, please? Much. We'll have a group photo together before we disperse. Okay. Sir, please be on a dais. Everybody, please on a dais. Sir, आइए group photograph हो जाए. Before all of us will come together. Please come. Somebody, the legends on the dais and rest all can stand together downstairs. Please come in all of us, all the delegates, all the faculties, please on our dais. Can I have a group photograph? Yeah, photograph is there.
सर कुछ लोग बैठ जाओ लेकिन घेरा छोटा हो जाएगा आ जाओ सर घेरा छोटा हो रहा है ना बाहर निकल रहे हैं